So as we all know, for last almost a decade, every year in the month of March, Ophthalmic Society of West Bengal organizes a glaucoma meet involving all the glaucoma consultants of city and West Bengal. And we also invite guest faculty from outside West Bengal. This year we are fortunate to have three eminent speakers, Dr. George Putran from Madurai, Dr. Murli Ariga from Chennai, and Dr. Prasanna Ramesh from Trichy. We look forward to listening to them. And before we start, we'll request our Chairman Scientific Committee, Dr. Rupakanti Vishwas, to felicitate our President, Dr. Ratish Pal sir, and garland him so that we can start the session. The first session will be moderated by Dr. Tanya and Dr. Tamnash. So I'll hand over the session to Dr. Tanya and Dr. Tamnash.
Good morning. Very good morning to everyone who has taken their time out on a lazy Sunday morning and come here for this Glaucoma Confluence. So March 12 to 18 is a Glaucoma Awareness Week, and OSW is marking the week by organizing a Glaucoma Confluence conference. And we have pretty interesting topics lined up. The first speaker is Dr. Gitanjali, and she is a consultant glaucoma services, Nayanjyoti Eye Care Center, and she will be speaking on why Goldman tonometry is still the gold standard. Dr. Gitanjali. I would like to ask the panelists of the session, Dr. Manas Bandyopadhyay sir, to come to the, Tutul Chakraborty ma'am, to come to the front row ma'am. Dr. Shouvik Banerjee sir.
A very good morning to all. So the first topic for today's session is why Goldman tonometry is still the gold standard. Intraocular pressure is one of the most fundamental parameters of ocular health, and especially in a patient of glaucoma, where it is very important for the diagnosis and decision making. Tonometry is the act of estimating the IOP. We are not directly measuring the IOP because the only direct way to measure the IOP is invasive. It is called manometry, and it is not done for day-to-day practice. So first of all, coming to the Goldman applanation tonometry. In 1948, Hans Goldman proposed GAT to measure the IOP. It is based on the Einberg-Fix law, which states that the pressure inside a perfect sphere is equal to the force required to flatten the surface divided by the area of flattening. Only 0.5 microliters of fluid is displaced, and therefore GAT is not affected by ocular rigidity. I will not go into the technique, but just to add one salient point, when the inner margins of the circle just touch, it is at this point that the capillary force of the tear film and the corneal inelasticity cancel each other. So if we want to get the best out of GAT, there are certain sources of error that we should keep in mind. First is the area of the tonometer tear film contact. If the tear film is excessively diluted by the fluorescein dye, it causes an overestimation of IOP by up to 5 millimeters of mercury. So the solution is just to dry the prism. Second is performing tonometry without fluorescein. It causes an underestimation till up to 9 millimeters of mercury. So we add additional dye, ask the patient to blink, and sometimes even adding a drop of tear substitute also helps, since these patients have chronic dry eye disease. Third is corneal astigmatism. Any astigmatism of more than 3 diopters results in elliptical Meyers. With the rule causes an underestimation, while against the rule causes an overestimation of 1 millimeter for every 4 diopters of astigmatism. So we take the average in the 0 and the 90 degree and then do the average. Next is the corneal curvature. There is an overestimation of 1 millimeters for every 3 diopter increase in corneal power. Central corneal thickness, very important. The instrument was originally calibrated for a mean CCT of 520 microns. Thicker corneas cause an overestimation, while thinner corneas cause an underestimation of IOP, except corneal edema that causes an underestimation. But these IOP correction algorithms, they are not validated and should not be used for practice. Excessive lid squeezing, tight clothing around the neck, eye position in 15 degree superior gaze, especially in a patient of thyroid ophthalmopathy, causes an overestimation, while repeated applanation attempts cause an underestimation. inter-observer variability is low as compared to other automated torometers, and it requires 1 monthly calibration for proper use. So what are the pros of the GAT? It is very accurate, highly reliable, simple to use, not affected by ocular rigidity. It has a relatively low intra and inter-observer variability, and historically it has been used in most of the clinical research studies. On the flip side, it needs dye, it needs topical anesthesia, it is not portable, can't be used in supine position, needs contact, needs training, needs calibration, and can't be used in certain conditions that I'll just list. So what are the other tonometer devices? First is the dynamic contour tonometry, which is based on contour matching to measure the dynamic pulsations via piezoelectric sensor. So the tip of this probe is concave. So it touches the corneal surface, but it doesn't deform its curvature. And therefore, the readings are independent of corneal thickness. It easily covers between 300 to 700 microns of CCT. It also measures the ocular pulse amplitude, but it tends to overestimate the IOP. So what are the cons? It needs contact, it needs slit lamp and topical anesthesia like GAT, but the contact time is at least 10 seconds. So it cannot be used in patients of nystagmus or those who have poor fixation in the contralateral eye. It has a higher learning curve, and it is an expensive instrument. Next is the rebound tonometry. It is a handheld device, so it has a small disposable ballistic probe that records the velocity change after the probe strikes the cornea. The good thing with this instrument is that you can choose the area of cornea that you want to use for IOP readings, because the area of this probe tip is only 1.5 millimeter square. But the cons is that it works well in the low to mid teens of IOPs, but when it comes to higher IOPs, it tends to underestimate. So it is not reliable in glaucoma practice. Also, it is the instrument that is most affected by corneal thickness readings. And this probe, it has to be disposed after a certain number of uses, so it is expensive. Next is the pneumatic tonometer, which is based on both indentation and applanation principles. It uses a stream of air to indent the cornea with a 5 mm diameter silicon tip. It is also utilized for pneumotonography. But the cons is, again, it tends to overestimate, and it is more influenced by corneal parameters as compared to GAT. This is the Tono pen. It is a handheld device. The good thing with this is that it can be used in any posture. It can be used over irregular corneas. It can be used for children. But the results are very variable. So at best, it is good for screening and other purposes. So what are the tonometers that we can use for special circumstances where GAT won't give reliable readings? For irregular scarred corneas and for readings over the soft contact lenses, the pneumatic tonometer and the Tono pen are the instruments of choice. For keratoconus, post-LASIK surgery, dynamic contour tonometry is the tonometer. For gassed-filled eyes, the pneumatic tonometer. For keratoprosthesis, the diatons tonometer, which is a palpebral tonometer. The instrument is put over the lid and not over the ocular surface. For pediatric patients, the Perkins tonometer, which is the handheld version of the Goldman applanation tonometer, the non-contact tonometer, and the rebound tonometer. For supine posture, again the Perkins, the Tono pen, and the newer variations of the rebound tonometer. The biomechanically corrected IOP, if we want the readings, then it is the corneal visualization Schrimffer's tonometer, the Corvus ST. And for continuous 24-hour IOP monitoring, there is this Sensimet triggerfish system, which is a disposable contact lens that is worn over the eye, which gives up to 280 readings of IOP in a duration of 24 hours. But in the end, I would like to say small-time wonders may come and go, but when it comes to reliable, accurate, reproducible, predictable readings, always trust the gold standard. Thank you.
Very nice presentation by Dr. Gitanjali. Shobhik sir, I want to ask you a comment regarding the that rebound tonometer, like how well it is. Yeah.
Hello. So good morning everyone. As per your insert, the topic of discussion was why Goldman tonometry is still the gold standard. Meaning you have to emphasize an adverb of time still, and gold standard means whether there are other standards like platinum standards or silver standard like that. What you have described is the tonometer. It is not the question. Do you really think that Goldman still holds on today? If so, why the pros and the cons? That is the point of discussion, I think. So, in 2023, do you think that Goldman is still important? If it is important, in coming years, will it be so? Or can be replaced by any other tonometer? That is the query OSWB has put forward to you in the morning. No. My point is that Professor Hans Goldman was an entirely different concept altogether. So, many points are there. Like whenever you are talking of a IOP measurement, actually are you doing a measurement?
No.
You are not.
Estimating.
You are approximating. You are approximating. You have quoted Imbert-Fix law. In no physics book, there is mention of Imbert-Fix law. Okay? And if you ever remember, Professor Ingmar, it is not because of the Imbert-Fix law. He should be remembered for other reasons. I think, I don't know whether anybody knows that. Imbert is the first person to implement radiotherapy in prostate cancer. And he ultimately detested himself, but he was so dejected that he detested from ophthalmology and joined economics. Before completing medicine degree, he was in, he has completed physics, first setup of a biophysics concept in the world, and international level law. So Ingvar is known like that. Very importantly, you have not mentioned the most important person whose tonometer is still valid in Russia and beyond the Eastern Europe, Professor Alexei Maklakov. So the concept was different. The concept was, you are telling that it's a case of pressure given by force per unit area. So either you keep the force constant, you vary the area, or you keep the area constant, you vary the pressure. Okay? So the concept of Maklakov was entirely different. And when he published his study in 1885, in the same journal, Flagger's Archives of Ophthalmology, very prestigious journal of that time, 3 months after, Imbert has put forward that possibly my take on the subject is that pressure possibly can be measured, because Maklakov couldn't explain that how you can measure the intraocular pressure. Maklakov tonometry is celebrating 140th year, double that of Goldman. Goldman was genius because of the Huxley collaboration, different thing, and another very important thing, when Goldberg discovered or invented, it is not 1940, I don't know where you have taken that, the Goldman tonometer, the first report came in 1955, but it was a sheer failure. It was a sheer failure. Nobody was a taker in Goldman because it was presented in International Congress at Brussels, next year Madrid, next year Barcelona, no taker. So they changed the entire concept. Goldman tonometer commercially was not available at Europe at the first place. He changed because he had to bow down before Schios. The Schios tonometry was much in vogue. So Goldman tonometer was launched in 1957 in United States of America. And whatever we are seeing, the bundle concept, you buy a machine and bundle with intraocular lenses. That concept was actually started by Goldman. You buy a Goldman perimetry, you buy a Goldman instrument, bundled with your keratometer. Last one take is that, suppose refractive corneal surgery, after refractive corneal surgery, you are talking of the DCT and other things. So the point is that whenever you are doing an applanation, it's a flat area. Previously it was a concave, but DCT has been replaced already. This year at Boston, October, a new tonometer will be presented with the principle of not applanation. It's a case of reverse applanation method with a convex surface. This will be presented by the Baraker family only. Rafael Barakat will be presented. This is a new prism, which is a convex surface. And Goldman, the advantage is that definitely it is very ready to use, very readily available, etc., etc. The point is that you can change the prism for a better concept. I don't know whether it is available in India, but correcting prisms are available, where the surface has been modified. You can actually, you are concerned about CCT. CCT now, as per all the reports, is constitute only 10% of the corneal biomechanical factor. 17 factors has been identified. You don't know, basically. Last point is that if anybody wants to know about corneal biomechanics and how tonometry has got the correction with the corneal biomechanics, Professor H.H. Maklovich, he has got the extensive work, 35 years work only on this subject. And he has opined that only two things are possible. Ab externo intraocular pressure is possibly not possible. Either you place one diamond tip manometry system, which is impossible, else a charged coupled device inside this Clem's canal, which can transmit data outside. Is it possible? Yes. Last year, Robert Oenreb has done the case, and the chip is manufactured in Germany. Thanks.
So our next speaker, Dr. Chandana Datta ma'am, and he's a glaucoma consultant in SN Kolkata. She will be speak on tips to master gonioscopy.
Thank you. A very good morning to all of you present here. Gonioscopy is a clinical biomicroscopic technique to examine the angle of anterior chamber with the help of spatial contact lens. It is the most underutilized tool in our day-to-day practice. Now, starting with the principle, as we all know, it overcomes the total internal reflection at the ear-tear interface. The indications are diagnosis and treatment of any type of glaucoma, raised intraocular pressure, disc suspect, peripherally shallow AC, pigment dispersion syndrome, pseudoexfoliation, trauma, uveitis, any neovascularization of iris, retina or its associated condition, and suspected raised episcleral venous pressure. Now coming to the types, as we all know, there are two types of gonioscopy, direct and indirect. The direct gonio lenses are helpful for the surgeries on the angle. They give us an erect and panoramic view, and bilateral examination is possible. However, it is very inconvenient to use in OPD because it needs the patient to lie supine, and we need an extra magnifier and a light source. So we use indirect gonio lenses in OPD. They are again of two types, scleral type of gonio lens and corneal type. All the Goldman single, double and 3 mirror lenses are scleral type of gonio lens, which have a larger diameter of contact of 12 millimeter. They need coupling fluid, and so the stabilization is better, so it is better for beginners. However, it cannot do indentation. Whereas all the 4 mirror gonioscopes, they are corneal type of gonio lenses, which has a smaller diameter of contact of 9 millimeter. They do not need a coupling fluid, and they can do indentation. So what is indentation actually? When we are compressing on the central part of the cornea with a corneal type of gonio lens, the aqueous inside the AC, it shifts to the angle and forces open the angle in case of appositional angle closure. So it helps us to differentiate between appositional and synechial angle closure, which is not possible with the help of scleral type of contact lens because of its larger diameter of contact and coupling fluid. Whereas the manipulation is another technique. It helps us to see over the hill view in case of a steep iris. What we do, we ask the patient to look towards the mirror, or we shift slightly the mirror, the lens towards the angle to be viewed. This is again better done by a scleral type of gonio lens. So why 4 mirror in OPD? Reasons are obvious. It views all 4 quadrants at a time with minimal rotation, so takes less time. No coupling fluid is required, so subsequent visualization of retina is possible, and definitely indentation is possible. So coming to the procedure, very important, first and foremost, we have to explain the procedure to the patient so that the patient remains cooperative throughout the procedure. Topical anesthetic is to be applied. The room lights are to be dimly illuminated so that the light doesn't fall on the pupil and inadvertently opens the angle, so that it doesn't happen. The patient is asked to look straight with the other eye. No inadvertent pressure, which is sometimes denoted by the folds on the cornea. It should not be there. and the beam has to be minimum 1 into 1 millimeter with minimal illumination. However, we can increase the width and illumination of the beam when we are doing indentation or seeing the details in the angle recess. We have to remember when we are seeing the mirror image that it is the mirror image, but it is not laterally reversed. So when we are seeing the 6 o'clock position in the 12 o'clock, the 5 o'clock position we are seeing just the opposite and not at the 11 o'clock. Now this is a normal open angle which is where we can see all the angle recess structures from anterior to posterior. They are Schwalbe's line, trabecular meshwork, scleral spar followed by ciliary body band. This is a closed angle which is opening on indentation. Now that we have seen the angle, we have to grade it. Whatever grading we are using, I am not going into detail because of the time constraint, but we have to remember that we are to document which grading we are using and use the same grading every time. Or what we can do is, we can document the posterior most structures seen on the primary gaze as well as on indentation with details of the additional findings if any. Something like this. Now what else we can see in the angle? Peripheral iris configuration may be of 4 types: flat, convex, concave and plateau iris. The other additional findings in the angles are peripheral anterior synechia, which are the iridotrabecular or iridocorneal adhesion areas. They do not open on indentation and they inhibit the flow of aqueous, which are to be differentiated from the iris process, which are normal structures. Neovascularization at the angle, they usually present as arborizing network of vessels in the trabecular meshwork and scleral spar. They have to be differentiated from the blood in the Slem's canal, which can occur in presence of hypotony or CCF or inadvertent compression. There could be many reasons of hyperpigmentation in the angle. This is a patient of pigment dispersion syndrome, which is the gonioscopy is showing Sampaulosis line, the upper arrow, then heavily pigmented trabecular meshwork with a concave iris. The same patient, Krukenbach spindle, was seen on slit lamp. In cases of trauma, we can find angle recession areas which are irregular widening of the ciliary body band, which has to be always compared with the other eye. We can find a cyclodialysis cleft, we can find an angle foreign body. Some post-surgical events can also be seen on gonioscopy. Trabeculectomy stoma, very important. Sometimes we need to know whether it is patent or blocked or scarred. AGV tube opening or silicone oil in the angle can also be seen. Posterior embryotoxin and high iris insertion can be seen in case of Axenfeld-Rieger syndrome. Now the common errors at gonioscopy, some of these I have already discussed: mistaking iris process for pus, diagnosing angle recession without comparing the other eye, blood in the Slem's canal versus NVA, inadvertent compression can level a closed angle as open, misinterpreting the pigment of Sampaulosis line as the pigmented TM, or leveling an open angle as closed in case of lightly pigmented trabecular meshwork. So how to alleviate the last two complications, the last two errors? We can take the help of corneal wedge. When we are making an oblique slit with the help of slit lamp at the angle, we can find two lines, one from the outer surface, one from the inner surface of cornea, which meet at the Schwalbe's line and form the corneal wedge. So once we can identify the Schwalbe's line, we can identify the angle recess structures very easily. The contraindication, we have to remember 4 absolute contraindications: hyphema, globe rupture, ocular surface infection, and corneal epithelial defect. Last and not the least, cleaning procedure of goniolens include alcohol swabs, 2% glutaraldehyde, 1:10 household bleach for 5 minutes, followed by thorough water rinse. So my take-home messages are only 2. No glaucoma diagnosis or management without gonioscopy, and practice makes us perfect. So the more we do, the better we perform. Thank you.
Madam, the topic was tips to master gonioscopy. Suppose I am a comprehensive ophthalmologist. You have to provide me tips so that I can master gonioscopy. It is not the slides. What is your take on your routine gonioscopy versus NIDEC GS1 automated system?
I just want to ask Kodijit or anybody who does everyday gonioscopy, how you clean your gonioscopy lens? I mean...
When I was a student at Arvind, what we used to do was just use soap and water after each and every case.
Yeah.
Now what we do at Disha is we use the disposable alcohol wipes. Although if you look at Ocular and Volk, both companies on the case itself, it mentions never to use alcohol wipes because it harms the glass and it's going to create scratches and over time it's going to. But we've been using it, I mean, I've been attached to Disha for around 8.5, 9 years and we've been using it for these 8.5, 9 years. Nothing seems to happen apparently. But ideally, it is not recommended. If you look at the Volk or the Ocular cases, it's mentioned on the case itself never to use alcohol to wipe it. So ideal thing would be to use soap and water. That's the ideal
I
thing.
normally do that, so I think for Disha you have a huge pressure. So
We just wipe it with the alcohol swab, keep it out to dry before we use it in the next patient.
And regarding Sampolicy line, this is almost the indication of occasionally you have the attack of angle closure.
Sorry, you're asking about the Sampolicy's line.
Sampolicy line. It's almost, I mean, because GC and they, I think, or someone, I think they have already, they have papered that this is an indication of occasional.
No, basically Sampolicy's line is just pigmentation on that ridge. You have a Schwalbe's line.
Yeah.
The Schwalbe's line is actually the termination of the Descemet's membrane where the cornea and the so-called other structures, there's a demarcation. It's a small ridge there, something like a shelf. So pigments tend to fall on that and deposit as the patient gets older. So pigmented Schwalbe's line is basically Sampolicy's line. That's what my understanding. There is no real cause or pathology attributed to the Sampolicy line itself. What we always say is when you see Sampolicy's line, which is very prominent and pigmented, you sometimes mistake it for the trabecular meshwork. So that's a standard teaching. When you see Sampolicy's line, you make sure you're not mistaking it for trabecular meshwork. It's basically a ridge with pigment. You can get it in so many conditions, even after a turbulent cataract surgery and you have a lot of inflammation and turbulence in the eye, you can get pigmentation on the Schwalbe's line. So the Sampolicy's line per se is not a pathognomonic of anything in particular.
But
you may
then
find
why-
it in certain diseases, but I don't really think you should teach it that way.
Actually, always when we do the gonioscopy, we always mention that this is no over-pigmented line over in front of Schwalbe's line.
True,
So just
your
to
observation.
exclude anything,
Sometimes
or
what
just
happens is your judgment versus mine may be different. So what I say could be different from what you are saying. So what we do is we document the picture. So take a good picture and keep that as a record, and nobody can dispute the picture, like a photograph or an angle picture. Then you see what is there, and you can somebody else can, after you seeing the same picture, you objectively say this is this and this is that. And if the uniform pigmentation you're seeing all around, it's more suggestive of a pigment dispersion kind of thing. If you're seeing patchy pigmentation, it could be something else.
this is blotchy pigment. What is the typical term? Is the blotchy pigmentation?
Blotchy pigment is the term which we use for angle closures and apposition of the trabecular meshwork to the angle. The Sampolicy line is totally different. Anyone else wants to add to that? There's nothing, you can't really put a diagnosis or a pathognomonic event related to the presence of a Sampolicy's line.
Good morning. So we have next Dr. Murali Ariga sir. If I start speaking about Dr. Murali Ariga sir, it will take a huge time. Sir is an ophthalmic practitioner in Chennai. Sir presently holds director and senior consultant post at Swami Eye Clinic, Chennai, Glaucoma Foundation. Head of the department, Sundaram Medical Foundation. Director Research and Head Glaucoma Services, MN High Hospital. DNB faculty and teacher, MN College of Optometry. And member scientist, MN Eye Hospital Institutional Ethics Committee. Sir has presented, more than 30 publications in peer-reviewed journals. He has written so many chapters in so many books. So I am not going into details. Over to you, sir. Sir will be discussing on pedimetry pitfalls.
Yeah, thank you for your kind introduction, and thanks to Manish, and thanks to the Ophthalmic Society of West Bengal for this invitation to participate, and the wonderful hospitality. We have been enjoying the hospitality since yesterday night. Yeah, first about what am I going to talk about today is some pitfalls and some pearls with regards to our use of perimetry in our practice. I'm not going to lecture to you about what is perimetry or how you use it or how you interpret it and so on. So first, my first picture will tell you that all of these is important. You can see how the patient is placed on the machine. Is this the way we do perimetry? Obviously not. So you must have a look at how the patient is placed and seated on the perimeter. You must also make sure you have a machine which is periodically calibrated and maintained well. You must instruct the patient as to how the perimetry is. We usually give a teaching instruction video to demonstrate to the patients to how the field test should be done. Arvind has excellent videos on teaching in different vernacular languages. You can teach the patients how to do a demo, do an instruction to the patient. It saves you and the patient a lot of time and frustration. So teach, instruct, make sure the machine is in good condition, get your UPS connected, make sure that all this is understood well by the person doing the test. And the person who's doing the test, the perimetrist, or optometrist, or technician, should be encouraging. You should not have somebody with a mobile phone in hand, a coffee cup in the other, seat the patient there and say you start the test, and they start looking at their mobile and having a cup of tea or something like that. So make sure the perimetrist is encouraged. It's a difficult test. All of you, I'm sure if you have all undergone the test yourself, it's an uncomfortable test and it's not easy to do, and patient is anxious about what can come out of the test. The anxiety is always there. So first time people are doing the test, you must instruct, be encouraging, and finally your interpretation comes. And your interpretation comes only when you have the printout in hand. Make sure you're seeing the correct printout of the correct patient in a busy practice, and also make sure you're interpreting systematically. Don't go randomly straight away, look at the grayscale and say, yes, this is advanced glaucoma, this is double arcuate scotoma, and so on. Interpret systematically, and finally, of course, correlate with the patient and the patient's eye. So the checklist, of course, you all know how to go through the systematic interpretation. The age and ID is very, very important. Reliability is important for perimetry, because unless the patient fixates, unless the patient looks into the center, unless you have a reliable field, you can't obviously interpret very well. Pupil size is important. You need to have a good pupil size over 3.5 or more for you to do perimetry. If you have very small pupils, you can dilate provided there is no contraindication. Get your refraction and near correction done properly. And of course, I understand that everything has a learning curve. The patient is doing it for the first time. Discard that field, use it as a demo kind of test, use the second or the third field as the starting baseline field for you to watch for progression and so on. And of course, interpret systematically, as I already said. Is it statistically abnormal? Is it abnormal first? Is it clinically, is it glaucoma or not? For you, that interpretation is very important. An abnormal field is not necessarily glaucoma. So systematic interpretation of your Humphrey type of perimeters, you look at the patient data, you look at the test parameters, look at the reliability indices, the grayscale and the numeric data, you look at actual thresholds, the probability symbols, you look at the GHT and the MD, and now the VFA also has come in. You look at the gaze graph at the bottom, just a quick eyeballing of the field, and interpret always systematically. Even though if you are experienced, also take some time in looking at all of this. And for a glaucoma patient, you'd probably look more at the pattern deviation. Glaucoma specialist, you'd probably look at the pattern deviation more than anything else. The grayscale is useful to explain to the patient, especially the attenders, this much of field loss is there, patient is seeing like this. You can actually explain to the patient. From our point of view, the pattern deviation, the VFI, and things like the other data, looking at the actual thresholds is probably more important. This is the octopus for you, comes in color if you like. And of course, you have slightly different nomenclature. You have something called grayscale, you can get it in color. Get the comparison is the total deviation, the corrected comparison is the pattern deviation. Probability plots a similar interpretation. You have the defect curve, which can actually show you the tested points. We test 59 points in the octopus. 59 test points are ranked from 0 to 59. The least deviated point is on the left, the most deviated point is on the right. If it comes into this confidence interval of normality, then you will find the entire patient's test result is within that curve. So if it comes down, completely down, it's generalized depression. If it's a sharp down dip, it's a scotoma as well. So all that is easy to interpret. But mind you, the BB curve is not specific for glaucoma. It looks at points all over the visual field. It is not like the glaucoma ME field test. It's not specific for glaucoma. The refraction is important. You have these kind of perimeters in the octopus kind of perimeters in which you don't have even a chin rest. You can have the patient leaning forward. This is ergonomic and nice. It doesn't need a near correction because there is not ball perimeters. The ball perimeters like the Humphrey requires near correction. So near correction not needed for the octopus kind of perimeters. So that you should remember. And if you're going to do very, very high powers like -8, -10, high myopes and so on, FX, it's better to use a contact lens. You put in a drop of anesthetic, make the patient comfortable, use a contact lens. The field actually comes out much, much better if you're using a contact lens. Very high powers. And of course, the new fancy HFA3 with the Zeiss liquid lens technology is really fancy. I don't really think it's important, but the technology is available in which you have the liquid lens, in which the patient's power actually comes into the liquid lens and so on. Not really important. But the trial lens placement is very important. Make sure the patient is positioned properly, not leaning forward. This kind of scotoma can come from the decentration of the trial lens, which has to be full aperture lens. And make sure all these scotomas and artifacts are interpreted as lens artifacts. The lens artifacts can actually confuse you if you don't understand it properly. As I said, the pupil size is important. Every time you do a different kind of a pupil size, the thresholds can actually vary. So make sure you have about 3.5 or more as a pupil. In some centers, institutions, routinely a dilated pupil perimetry is done. There's nothing wrong with that, but make sure the follow-up exams are also dilated. You can't compare undilated with dilated perimetry and so on. Myotics, patient is on pilocarpine for some reason, you can actually dilate the patient and then do perimetry. All this myotic related depression will go away. Eyelid artifacts, ptosis, blepharoptosis, eyelid anomalies, deep set eyes, all these things you can correct by taping the eyelid and doing it. You can tape the upper eyelid and then do the perimetry. There's always a confusion as to what test to do to which patient. So there's again the confusion of 30-2 or 24-2 most of the time. So for glaucoma, generally we use 24-2 as a default, CETA standard maybe. Sometimes you also do 30-2. In our center we do 24-2 for the want of time. It saves a little time in doing 24-2. And some centers insist on 30-2. CETA standard is the default. And for neurological diseases also the same thing happens, except that when you have a small central scotoma suspected in optic neuritis, you probably do a 10-2. And retinal diseases, you look at, very rarely we do glaucoma with a perimetry for retinal diseases. If you're really doing it, think about peripheral field. So don't ever do full field 60-2, 60-4 or whatever perimetry is available. Don't waste time, extraordinary amount of time is wasted. The reason for that is this. The central 30 degrees covers about 66% of your ganglion cells and corresponds to about 83% of the visual cortex. You want some information about glaucoma, you want some information about the neuroophthalmic status, this will suffice. For us to know what the patient is actually experiencing, you can actually do a 30-2 for almost everything in ophthalmology. You don't really need anything more than that. Occasionally you need to go more, but most of the time even a 24-2 is enough for follow-ups. So there is a difference between 30-2 and 24-2. You will know that we are always taught about the Anderson's criteria about abnormality, saying edge points, non-edge points and so on. Non-edge points are probably not important in the 30-2. Whereas edge points are important in the 24. See this example where you see the GHT is borderline. We are seeing an RNFL defect in the patient, but your 30-2 is looking apparently normal. There's nothing really going on. These are looking like edge points. So if you ignore this and what happens now is this is 24-2. So if you do a 30-2 on the same patient, you will probably, this becomes clearly scotoma and this becomes clearly GHT outside normal limits. So don't ignore edge points on 24-2, whereas you can afford to do that in 30-2. So make sure you understand that concept of you're testing less in 24-2, therefore pay more attention to the edge points as well. So when you have something in the central visual field like this, the defect is close to fixation, what should you do? You want to zoom up and look at the field a little more in the center, then you do a 10-2. So why is the 10-2 important? Because you are testing 6 points apart in these kind of 24-2 and 30-2. Whereas in the 10-2, you are testing 68 points, the 2-degree separation between points. You're actually looking at it closer. So if you really want for further tests for these patients should be maybe followed up with the 10-2 because you're zooming into the center. You're actually looking at what is actually happening in the center. This is what we need to know as far as the patient's visual function, visual status is concerned. Very rarely you will find you have a classic notch in the neural rim, you have an RNFL defect, you have the pressure of 24 and 20. You know this is glaucoma for sure. You do the field will come out normal. So what do you do? Why is that? Because you're not really testing all the points which is actually showing up with the structural change. So you can follow it up by doing a 10-2 or even a swap and whatever you like. So 10-2 is there. So what has now happened is, this is another example of how you interpret. So you will find that very often this kind of an advanced glaucoma with the patient with 6/9 vision, you'll end up with a field like this. What do you do with this kind of field? Nothing more you can interpret. So what you can do is you can change the stimulus size. You change it to a stimulus 5 like this, you will get some more information on what is actually happening. So size 5 stimulus, this is more like a custom test, it's not a default test. You can choose a size 5 stimulus. So testing strategies as far as perimetry is concerned, you have so many on the machine called suprathreshold, threshold related, full threshold and efficient threshold. So all of us use only this now. We don't use any of these. For glaucoma, for neuroophthalmology, we don't need suprathreshold, we don't need threshold related, we don't need full threshold. Because we have gone through all of that. The machine by default will do only CETA now. And CETA standard is the so-called gold standard as far as your default test is concerned. Occasionally, of course, the equivalent in the octopus is called the dynamic. Who has an octopus machine? I use both, so the dynamic is also the equivalent of the CETA standard. Whereas the CETA fast is a quick test, it is not actually a screening test. For people who do perimetry well, for them CETA fast is good. A screening test ideally should be CETA standard. Don't use CETA fast for screening because you tend to miss many things. A screening test should be CETA standard, whereas CETA fast can be done for people who are already perimetry sort of experienced with perimetry. They do it often. So therefore, you can use the CETA fast for comparison subsequently once you understand how the field test is done. Don't use the CETA fast for screening. Same thing happens with the top as well. Don't use it for screening. The dynamic is ideal, the CETA standard is better. So use that for subsequent comparisons. Use only the efficient threshold testing. It uses a little bit of intuitive, maybe you can even call it AI, some kind of artificial intelligence, in which all points are not tested. For example, for the top, I'll show you an example. And this is the time sequence of how much time it takes. For example, the full threshold takes 14 minutes and 24-30-2, 8 minutes for the 30-2 of the CETA standard. Whereas the CETA standard 24-2 will take 4 minutes and about 3 minutes for the CETA bar. This is just rough average for a normal patient who undergoes these tests. So you can imagine, suppose you subject an elderly patient to a 15-minute, 14-minute test in each eye. The patient is fatigued. You will get thresholds which are depressed all the time. So fatigue is a very important phenomenon for perimetry. The quicker we do the test, the better it is for the patient. That is why all these efficient threshold tests are doing it faster and quicker and quicker. The octopus top can sometimes do the field test in less than a minute. So you can really quicken the test, and patient is so comfortable doing the test, you get much more from the patient than simply torturing them, 90-year-olds and 80-year-olds who are doing 30-2 full threshold. You're done. Patient will never come back to you and you say, I don't like the test. So make sure it's comfortable for the patient. Do what is appropriate for the patient and choose the time according to the age and mental capacity and physical capacity of the patient. This is the top for you. It's a 2 to 3 minute test, screening, only one test question per location. Simple answer influences the value of 8 neighboring points. Neighboring points are interpolated, extrapolated, and every point is not tested. And therefore, the light stimulus is, of course, the standard size 3 Goldman. Only one phase, you can do it in multiple phases and so on. And there is no short-term fluctuation. A lot of time is saved by all of these strategies. The top really does it well. It's really a top test. So I think you might have heard of what is evolving in perimetry now. You had the CETA standard, you had the CETA fast, you also have now the CETA faster. So one may ask, what's next? CETA fastest is going to come. So maybe. So we're going to have tests which are becoming faster and faster purely because we want the test to be done optimally. We want the test to be done as quickly as possible. And we want the best information from the patient in the least amount of time. You want to look at the central field, you want to look at the minimum amount of information and get the maximum output out of the patient. No point in doing a 60-degree or a 120-degree field for 2 hours. You will get an extraordinary perimetry result. But what do you do with that information? So this 24-2 is the new concept in which the 24-2 is there. We have added some points from the 10-2 on to the 24-2. So about 8 points, I think, 8 or 10, 9 points are added to that. So once these are added, you get little more information. Instead of doing a 10-2 for the patient in whom 24-2 was normal, like the example I showed you, you can do the 24-2C. This test, but for how many of you are octopus users here? No one. Okay, that's interesting for me because the octopus is a fantastic machine. It's leap years ahead of the Humphrey. I always say that. And there's so much of technology. This kind of 24-2C test was being done in the G program of the octopus for the last 10 years. I've been using the G program of the octopus, which actually covers all of these. So which is already there in the octopus for more than 10 years. I'm surprised Zeiss took 10 years for them to even come out of the 24-2C. And still this is not as good as the G program, which is specific for glaucoma, whereas the 24-2 and 30-2 is not specific for glaucoma. So as I mentioned, there's a reliability indices and of course a learning curve. You must make sure the patient must understand the test and make sure once you get something like this, don't tell the patient you're unreliable. In English, if we say somebody is unreliable, it implies that patient is not unreliable in various, whatever method you want to say. Patient has not done the test properly, and this is a statistical abnormality. The patient is not unreliable. Like the optometrist come back, put the file on my table and say, sir, patient unreliable. So what does it mean? So patient is taken aback. Say, I am coming to you for a diagnosis of glaucoma. You are telling me I am unreliable. So they don't understand what is unreliability or unreliability. It's on perimetry. So don't use that word and make sure the patient is saying you've done the test for the first time. There may be some learning difficulty in the way you understood the test and so on, and repeat the test after a day or two. You will find sometimes your optometrist will torture your patient and do it. I have done it 6 times today. I have done the field test 8 times today. Proudly they will say, done 8 times. So never torture a patient like that. Or do it maybe once, maybe occasionally twice. Give a break between one eye and the other eye. Let them go around, come back. There's no need to do both at the same time. You can do one today, you can do one tomorrow. You can do one today and do the repeat after a week. There's no need. Glaucoma is not going to blind the patient in a week's time. So you have time for most patients. So don't torture the patient, get useful information by doing proper perimetry. And this is the kind of thing is what you must actually avoid. You see this patient, for some reason, underwent a field test. She was explained to look into the center, the light will come, keep looking at it, all these are random, it's going to come, some lights will be, stimuli will be bright and dim and so on. She sat through the whole test very meticulously. You look at the fixation, perfect fixation, no false positives. See the false negatives, 99%. So what's wrong with this? The patient was not told to press the button. She kept seeing through, fixated perfectly, looked at everything, all the lights she was seeing, but she was not told to press the button. She said, nobody told me to press the button. You sat through the entire 5-minute test without pressing the button, then you get 100% false negatives. So again, make sure you understand the test, understand the patient, and again repeat the instruction. But not all false negatives are actually abnormal. Most of these advanced glaucomas, you will find false negatives are quite high. So don't discard a field report as being unreliable when you have only false negatives being high. So look at this, for example, very advanced glaucoma, very small field which is actually present. So false negatives are more than 33%. So this is not an unreliable field. The disease per se is known for these kind of variations in testing. So a false negative alone per se does not make the field unreliable. So for you to understand various aspects of, this pointer is not working, understand the various aspects of, say, reliability in a visual field, white scotomas, impossibly high sensitivity, you get 42, 45, those kind of sensitivity you won't get in normal human beings. High fixation loss rate, elevated false positives, then you get these kind of impossibly high positive deviations. And then you have the GST showing very high sensitivity, highly positive MD. Then you have the pattern deviation worse than total deviation plot. All of these are indicators there's something not okay with the way the patient has done the test or responded. Better to repeat with proper instruction. So I usually instruct the patient myself if this kind of thing I see. I say cover one eye, look at the fixation spot. We are trying to look around as what you're seeing around fixation. Make sure you see the lights which are dim as well as bright. All the dim lights you must respond. Sometimes the patient thinks that dim lights they won't respond. Sometimes they don't blink between the stimuli. Always ask them to blink and make sure as they press the button you blink. No stimuli appears when the button is being pressed. So blinking, very often people are scared that the stimuli is going to come. They keep on staring and they don't blink. So the blinking, the fixation, and explaining to them that even dim stimuli, even if they think they've seen a dim stimuli, you press the button. That's actually improving your false negative and false positive, improving all of those tests. You must also know that myopia is a big problem as far as perimetry is concerned. You preferably use a good refractive correction, maybe even use a contact lens. You will find these are all the common visual defects in myopia, which look typically like glaucoma. All of these are myopic defects and they may not progress. Sometimes it is told that by standard teaching that all myopic discs are assumed to be glaucomatous unless proven otherwise. So if you look at myopia, you can look at enlarged blind spot, you can look at arcuate-like field defect, you can have nasal step, early arcuate, advanced arcuate, all kinds of typical glaucomatous defects you will get. This is from the Zongshan ophthalmic study, which is from the high myopia registry, in which fields was done for all of these patients. So high myopia is a problem as far as perimetry is concerned. If you are doing fields for a high myope, do it properly, establish the first to the second field as a baseline. Keep following up at least once in a year. That's when you can actually compare. So what is glaucoma? Glaucoma is basically progression. If things get worse without treatment, that's what you're looking at glaucoma. So ideally you should do multiple tests over time. There is a learning curve, and myopia also makes sure you understand the myopia and the field defect. So lastly, is it an abnormal field? This is the Anderson's criteria. I'm not going to bore you with the theory of this. Cluster of 3 or more non-edge points, the PSD being less than 5%, and GHT abnormal. Not all of these has to be present. You can take any one or two, but mind you, these things must be repeatable. You must have it done again. It should not be just a one-time field test which is showing you this. The field defect or the field abnormality should be repeatable. So is it glaucoma or not? This is for us to understand. Does it follow an arcuate pattern? Does it follow an arcuate pattern corresponding to the nerve fiber layer loss? Is it asymmetrical? Is it located in the mid-periphery? Is it 5 to 25 degrees from fixation? Is it reproducible and no other pathology? And of course, clustered defects should correlate to the appearance of the optic nerve head and does not affect the vision. Does any glaucoma patient come to tell you that he can't see? He'll bump into objects, he'll walk into your room, bump into all the furniture around, but still he will not tell you that he can't see. It's not a positive scotoma, it's a negative scotoma-like thing. So invariably the patient will not tell you. So central vision will be 6'6", 6'9", 6'12" most of the time, and you will get double arcuate, you will get scotomas close to fixation and so on. So generally it doesn't affect the vision unless you have total glaucomatous optic atrophy in temporal island. That's when the vision goes. So correlate clinically, make sure a field defect is there. You must have an RNF field defect. You must have a defect on the red free also. What is non-glaucomatous? I think this is straightforward MBBS level field defect. Anybody sees this, they will tell you it's neuroophthalmia. Straight away go for an imaging and so on. AON also is pretty straightforward. You don't really need this information for you to be told as ophthalmologist. But where the importance comes for neuroophthalmology is this. You look at the field defect of both the fields, you find a symmetrical kind of bilateral symmetrical field loss. That is when you suspect there's something going on in the visual pathway, and the intraocular pressure is 12 or 14, you have field defects. So the teaching here is that look at both the fields, keep them side by side. Again, the octopus will score over the Humphrey in this regard because you get something what is called as a 2-on-1 printout. You can print both the fields on the same page side by side. It will give you this kind of a symmetry analysis. If you compare both and you suspect something like it doesn't look like glaucoma, straight away start think of imaging. Otherwise, you will miss this, put Travatan in this patient and keep following up for many years. You will find nothing is happening. Patient will end up with a huge pituitary tumor or some other SOL in the nervous system. Lastly, about the so-called pre-perimetric glaucoma. Sometimes we are told that structural changes will always precede functional changes. Sometimes we see functional changes will actually precede structural changes. Not always true that we will get changes in the disc or RNFL before fields. Many studies like the OAT study has shown that you can actually get functional tests before structural tests and so on. So there's no rule, but we always teach our students and PGs that structural tests always come first and the functional test comes. So it's like the chicken and egg phenomenon. Which came first? The chicken came first, the egg came first. So if you look at this example, you see this normal looking disc, normal looking RNFL, normal pattern deviation. Here you see something going on the disc and the RNFL. You still don't see it on the field. You see the notch, you see the classic RNFL, you see it on pattern deviation. And lastly, you start seeing it on the field defect. This is how supposed to be, very easy to teach and so on. So where does this change actually happen? For a structural change to happen, so something like you get an RNFL defect, a notch in the rim, somewhere some kind of a loss on the, which is visible on the disc or the RNFL, and you start seeing it on the perimetry. So this is what is called as a tipping point. So this has been described long ago, many years ago, and I use this example to teach our students that using the standard technology like this was done using the Zeiss Ceres OCT, spectral OCT, done using the 24-2 CETA standard. If you look at the temporal, the mean, the superior, if you look at how much RNFL loss must happen for it to show on perimetry, it is said it's about 17%. Not like our traditional teaching is a 40% of RGC is lost and 50% is lost and so on. So 17% of the RGCs or 17% of the RNFL loss, which is measurable on OCT, should actually happen for you to have a measurable defect on the visual field because our field testing methods are not efficient. If you look at the 24-2, it is a lot of defects in the way we are testing 24-2. You're not testing in between, you're only testing 24 degrees. You're testing so many areas which are actually important in the arcuate area, but we're not testing them. So your limitations to perimetry, it is not because the patient is not showing it, our methods are not sensitive enough to pick up the change. So therefore you look at OCT and you look at the field also, and both should be combined. So in glaucoma diagnosis, in the early stages, you look at structural tests. And for screening and diagnosis and follow-up, you use perimetry and structural tests. For advanced glaucoma, don't use OCT. You will invariably find the floor effect will confound you. You will find that you reach 40, 35, 36 measurement. Thereafter, you reach the bottom of the ocean. You can't go deeper than that. You can't measure more than that. So this is an example of a floor effect in which you're already having a very, very thin RNFL. No point in following up these patients with OCTs. You don't need OCT for advanced glaucoma. Somebody has an intraocular pressure of 60 with a 0.9 cupping and you're having a glaucoma staring at you on the face. You don't need OCT for that. So OCT has got its own indications, but don't use it for advanced glaucomas. So example of the octopus again, which shows you the cluster analysis shows you each cluster the thresholds can be estimated. For those of you, you can enjoy the octopus perimetry if you have buy one. Next perimeter you should buy is the octopus. I have no interest though, financial interest. So this is the octopus clustering analysis. You also have what is called as polar from the octopus again. You can actually turn things around in the octopus perimeter. It will tell you where the RNFL defect, where the structural loss is going to come. You can actually correlate the OCT. So this kind of structure function correlation is there. With this example, I will stop. So this is, okay. Does anybody know what I have put on the title? Deliberately, I put it as an acronym. What is this CSFI? So we are all looking at structure separately. We are looking at function separately. So we can combine both. It's called the Combined Structure Function Index. So, and people have been talking about this for many years. It has now come in, and probably it will come into the future. you can actually have an estimate of the RGC like how we estimate the corneal endothelium. You can actually estimate the RGC count and then look at the RNFL defect and look at the perimetry and put all together into an index. You look at this example in which you have an RNFL of say 82 and 61 RNFL loss. Here you can see the example there. But you find the perimetry is almost looking similar. Whereas you find the RNFL loss of 60 and 60 there, you'll find the index is totally different. So you will find that exact correlation between RNFL loss and perimetry is not always there. So this index actually goes closer to integrating both structure and function. So in our practice, make sure that you're integrating structural evaluation, integrating a functional test for the patient. Certain patients do certain things well, certain patients one thing comes ahead of the other. So use both with your clinical judgment. You are the prime clinician. You are the prime treatment clinician for the patient. The patient is trusting you. Look at all of this overall picture and then decide which patient has glaucoma, which patient needs treatment, which patient is progressing and so on. These are some of our publications with many chapters on perimetry and different aspects of imaging and mostly about perimetry. So you can look up many of these chapters. So thank you for shooting over the time.
Thank you
Again,
so much,
I
sir.
leave you with this picture of remembering that perimetry is a functional test, subjective test of vision function. Make sure all of this is in place before you start doing and enjoying your perimetry. Thank you.
Thank you so much, sir. Thank you for that wonderful presentation. I'm sure there will be a lot of questions, but we'll take the questions later after this session. I would like to ask Dr. Rotish Pal, sir, and Dr. Pushpita Shahu, ma'am, to felicitate, sir. Sir, please. So I'd like to invite Dr. Pallavi Raj next, Senior Glaucoma Consultant, Shankarnetra, Kolkata. She will be speaking on detecting progression on OCT.
Very good morning to all my colleagues. First of all, I would like to thank OSWB for giving me the opportunity to present in front of this esteemed audience. So my topic is monitoring glaucoma progression with OCT. So glaucoma is a progressive disease. We need reliable tools to monitor it over time. Before OCT, determination was glaucoma progression was clinical with disc photos and the visual field analysis. But it is quite subjective and qualitative. So is it reliable? So we have shifted to spectral domain OCT now, and the machines commonly used are Cirrus, Spectralis, and RTView. So these are the differences this is present in this table. But I would just like to highlight that RTView is the one that shows a thicker peripapillary RNFL thickness in comparison to the other two. So there may be a misdiagnosis of glaucoma progression imaged initially on an RTView device but subsequently imaged with any other device. Each device has its own normative database. So coming to retinal nerve fiber layer thickness, it represents the ganglion cells before they enter the optic nerve. The loss of RNFL can be picked up on the red-free photos and is quantified with OCT. The peripapillary RNFL thickness is the most popular OCT parameters, and we all know that the color codes, that is green is normal, yellow is borderline, and red is abnormal. So the most clinically relevant RNFL parameters for diagnosis and progression is the average RNFL thickness and the RNFL thickness in the inferior quadrant. RNFL thinning may be valuable in early diagnosis of glaucoma, as it may precede visual field loss. As we can see in this picture, there is some inferior rim thinning which is not very well picked up on the HVF. But the RNFL is clearly showing thinning in the inferior quadrant and also in the macular analysis. If there is an inter-eye difference of more than 9 micrometers of average RNFL thickness, this also suggests an early glaucomatous damage. So progression and structure function correlates. To assess for progression with RNFL thickness obtained by OCT, we need to be aware of a few factors, like thinning due to normal aging, the floor effect, thinning suggestive of glaucoma progression both globally and within a sector, and correlation of RNFL loss with visual field loss. So coming to RNFL thinning, the RNFL undergoes attrition with age in healthy eyes at a mean rate of around 0.48 in the Cirrus, machine and around minus 0.6 micrometer per year in the spectralist machine. But when glaucoma progression is seen, it has a faster rate of RNFL thinning, and this comes to around 0.98 micrometers per year for the Cirrus and minus 2.12 micrometer per year for the spectralis. All these are Western data. So next we move on to the floor effect. As glaucoma advances, the RNFL measurement continues to decrease, but it does not go to zero. That is because of the architectural support, that is the Muller cells, astroglia, microglia, and the blood vessels, which do not degenerate completely. Once the RNFL thickness reaches the floor, progression can still occur, but it can't be detected by RNFL OCT. We have to use the macular OCT or the HVF 10-2. So the average RNFL floor values in different machines like spectralis is 49, the Cirrus is 57, and the ArchView is 64, which we have to keep in mind while interpreting the scans. So moving to progression analysis, it can be event-based analysis. It measures the difference between a baseline and a follow-up measurement. If a decrease of more than 5 micrometer is there in the average RNFL thickness, it is suspicious for glaucomatous progression. If there is decrease of 7 to 8 micrometer or more in a sector of RNFL thickness, this also suggests progression. This is for sector. Next, we move on to trend-based analysis. This identifies progression by monitoring the slope of RNFL thickness over time. Next, we move to the guided progression analysis for the RNFL. So this is the full picture, and I'll discuss in detail in the next slide. So this is a deviation map which shows areas of change that is statistically significant for the first time. And that is an orange color, if you can see. And if in the subsequent areas where another statistically significant change is there, it can be red. So for the first time is orange and the second time is red. So here we can see the different graphs that shows the average RNFL, the superior RNFL, the inferior RNFL, and the average CD ratio. Again, the first statistical significant change is seen as an orange dot, and the next one is the red dot. So these are trend analysis as opposed to the event analysis, which was shown earlier. The average CD ratio graph indicates whether there is statistically significant increase in the cup-disc ratio. Increase in the cup-disc ratio. So if the RNFL is decreasing and the cup-to-disc ratio is increasing, both are good evidence, corroboratory evidence to suggest that the change measured is real. Now here we have the GP analysis, that is the RNFL thickness profile where the baseline is B1 and B2, and then the current, that is today's visit, is shown as the C, which is the, and we can compare the RNFL thickness at different locations. So finally, the table of RNFL and optic nerve head. Here we can see that the average RNFL is decreasing, and it is suspicious first, and then it becomes red. There is confirmed progression, and this is happening in the inferior and the superior quadrant. So we should keep the artifacts in mind while interpreting the OCTs. There can be segmentation errors which incorrectly identifies the anterior and posterior RNFL borders. So it can be a false decrease in the RNFL due to media opacities like corneal haze, cataracts, or vitreous debris, and a false increase can be because of myelinated RNFL, ERMs, or swelling of the optic nerve head. The artifacts can also be because of decentration. We should also keep myopia in mind. Next, we move on to the macular scan. Approximately half of the retinal ganglion cells are located in the macular region. So glaucoma can cause thinning of the macula in this disease, especially the inferior macula, from where the retinal ganglion cells project to the infratemporal region of the disc. So imaging of retinal thickness in the macula is a sensitive measure for early detection of glaucoma. So different machines have different protocols. The Cirrus has the GC IPL, and the other machines also have their own protocols, but we generally see the Cirrus one. So here we have to keep some points in mind, like average GC IPL thickness is around 82. It is thickest in the supranasal and thinnest in the inferior. We have to keep in mind that normal attrition with aging is around minus 0.3, and average GC IPL thickness is around 75 in early, 64 in moderate, and 55 in advanced glaucoma. An average GC IPL thickness more than 4 micrometer is suggestive of progression. Thickness change is a suggestive progression. So some factors which may influence macular retinal thickness are age, gender, CCT, axial length, and RNFL thickness. Generally, the changes are visible as an arcuate defect on the thickness and progression map. And for macular parameters, the floor effect is generally seen at 45 micrometer. In advanced glaucoma, when RNFL thickness is below 55, change in GC-IPL thickness can still correlate with functional damage measured by 10-2 visual field. This is particularly true for average GC-IPL and inferior sector. So artifacts in macular OCT scans can also be segmentation errors, decentration, and any measurement that is below 40 micrometer should also alert the clinician to the presence of an artifact. Besides all the retinal pathologies like ARMD, ERM, CME, etc. should be kept in mind, and this scans should not be used to monitor glaucoma. So next we move on to the optic nerve head scan. This is not widely accepted because of the variability in optic disc size, tilt, peripapillary atrophy, and other potential artifacts. So Cirrus and RTView generally use an arbitrary reference plane. Spectralis use the FOBMO axis, and the BMO MRW has a diagnostic capability comparable to RNFL and macular OCT. So to summarize, I would say that monitoring progression by OCT has proven to be qualitative and reliable tool to be used in conjunction with clinical evaluation and visual field testing. In early glaucoma, OCT of the RNFL and macula may be important. In moderate glaucoma, the correlation between OCT and visual field helps us to confirm progression, and advanced glaucoma, it is the 10-2 visual field and OCT. For now, when monitoring glaucoma progression, we should combine a clinical evaluation paying special attention to the presence of a disc hemorrhage with a visual field assessment and a good understanding of OCT and its limitations. So these are my references. Thank you for your attention.
Thank you, Dr. Pallavi. So our next speaker, Dr. Arijit Mitro, Senior Glaucoma Consultant in Dishai Hospital, and he will be speaking on the OCT angiography.
A very good morning to everyone. Thanks to OSWB for giving me this opportunity to present this particular talk. So I'll be talking on OCTA, which is something new, a new concept as we can say. So it's a recently developed imaging technique. It's not so recent now because it was around 2013-14 that it really started to take grip. So it is a technology which allows a non-invasive visualization and assessment of the microcirculation of the optic nerve head, the peripapillary retina, and the macula. So basically what OCTA is doing is, you have these OCT scans which you normally see. So it uses a software to analyze these scans, and basically since you have these cross sections, it uses the software to create an en-face image, which is a head-on image. So basically you're using the normal OCT scans, you're using a software to get an en-face image. So it's a non-invasive rapid test, takes around 2 to 3 seconds, and it's got a very high repeatability and a very high reproducibility. So all the major players, they have their own versions. For example, Zeiss has the Angioplex, Topcon has the Maestro 2, and Heidelberg has their own OCTA module. What we are using is the OptoView Solix. The older version is the AngioView, which is again from OptoView. So all the major players have now an OCTA module. Now, how did this revolution, this change come about? It came about because of these things, the SSADA and the OMAG. Now, what are these? So these are all algorithms. So it's basically just a play of software. So the algorithms, like the SSADA, which is a split spectrum amplitude decorrelation angiography for the OptoView, or the OMAG, which is the OCT-based microangiography from Zeiss, these algorithms, they were the game changers. So basically, you just have this algorithm, and you need a Fourier domain OCT, or a HD OCT. That makes OCTA possible. So it's just a software which is enhancing the capability of the machine. So what are you actually seeing? So what are you seeing are, two parameters, the vascular density and the flow index around the optic nerve head. So that's something that you're seeing around the optic nerve head itself. B, the vascular density in the peripapillary retina. And C, the vascular density around the macula. So you're basically seeing two things. One is something called the flow, the other is something called the vascular density. It is either around the optic nerve head or around the macula. So what happens is, in glaucomatous eyes, there is a significant reduction in the blood flow, the capillary diameter, and the vascular density in glaucomatous eyes. Now, there is a problem with octa. Since octa senses motion, it is susceptible to artifacts which are produced by bulk eye movements. For example, microsaccades, ocular pulsations, ocular drifts. So you get these line artifacts, motion artifacts, which are much higher in octa than in the normal OCT. So therefore, what it has done is, it has introduced these high-speed active eye tracking systems. The image registration and post-processing has been enhanced, and bulk motion subtraction algorithms have been added. So you can see these untracked images. You see a lot of these lines. You see that the blood vessels are not continuous. So these things are to be taken care of. If you track the images, you remove the invalid B scans and they are again rescanned. And once they are removed, you see the line artifacts have gone and the blood vessels, they become continuous. So anything static is neuronal, anything which is moving is blood. So that's the basic concept of octa. So like I said, there are two things that you measure. One is the flow index. Now there's a problem with the flow index because reproducibility of these flow measurements are poor. For example, if I do an octa now and I go out, I run a mile and I do an octa, the values will be very different because the flow is going to be different because it changes according to the patient's physiologic state. Therefore, oxygen concentration of the inhaled gas mixture, any visual stimulation and many other factors affect blood flow. Therefore, flow index is not considered such a strong parameter. Basically, if you have a lower flow, you'll have these cooler colors. This is the retinal flow. And if you have a higher flow, like in the choroid, you have these colors, which are either orange or red. But like I said, flow index is not a major parameter. What is a major parameter is something called vessel density or vascular density. So it is basically the percentage area occupied by the vascular pixels, which are the pixels which have higher flow signal relative to the non-vascular background, which you get in the en-face angio. Now what you measure is this vessel density around the optic nerve head, which is the peripapillary scan, which is around 4.5 into 4.5. And around the macula, they tried a 4 into 4, they tried a 4.5 into 4.5, but what they found was that the diagnostic accuracy around the macula was poor if you have a smaller scan. So now the standard is a 6 into 6 mm scan around the macula because glaucoma is going to affect the periphery of the macula first. So the macula, you need a bigger scan. So what you get as a printout is something which is referred to as the angioanalytics of the ONH and the peripapillary retina. Problem with the ONH is it is not an ideal image target because there's something called shadowing of the neural tissue due to the numerous blood vessels which are there and because of the highly variable geometry of the disc, rim and vessels. Therefore, what you actually read in the angioanalytics of the ONH and peripapillary retina is the peripapillary retinal scan. And obviously, the angioanalytics around the macula is very, very important. You divide it into the central part, which is the foveal zone, and 4 other zones around the macula itself. So what are you actually measuring? You're getting these en-face images. So there are these two complexes, the superficial vascular complex and the deep vascular complex. The superficial vascular complex is again divided into the nerve fiber layer plexus. So this is one layer. Below that is the ganglion cell layer plexus. So that's part of one complex. The other complex, which is the deep vascular complex, which has the intermediate capillary plexus and the deep capillary plexus. I know it sounds very confusing, but what you're really interested in glaucoma is A, the nerve fiber layer plexus, which is a part of the superficial vascular complex around the disc, and the whole of the superficial vascular complex, which is the nerve fiber layer plexus, as well as the ganglion cell layer plexus around the macula. So you're basically interested in the superficial complex. The deeper complexes, the value really doesn't hold much importance in case of glaucoma. So this is the kind of printout that we are now giving at Disha. So what you have is a SLO image, you have a vitreoretinal interface image, you have a ILM NFL image, and you have a choroidal image. Now, all these images, all these layers are, like I said, processed, and you get the normal OCT parameters on the left. So this is the normal OCT, the RNFL parameters here, and you get the thickness map here. And you get the color-coded vascular density here. And you have the parameters, which are the vascular density parameters here. So basically, you can correlate both the RNFL parameters and the vascular density parameters in the same scan. So you get the best of both worlds in the same scan. And around the macula also, you get the parafoveal region, which is the RNFL thickness and vascular density percentage around the fovea. And you get a grid-based, that is the superior, temporal, inferior, and nasal scans. Now, this is a very interesting chart, and I wanted to put it out there, because look at the number of publications on OCTA. So these are just OCTA peer-reviewed publications, and they really took off after 14, 15. And even though there was a dip in 21 post-COVID, again in 22, it's again shot up. So there's a huge interest in this particular imaging technique. So I just want to focus on a few studies which will answer a lot of questions as to what this particular machine can do. A, regarding optic disc perfusion. Is there a correlation with glaucomatous severity? Answer is yes. This particular study done by Wong et al. Showed that the entire optic disc blood flow was significantly lower in the glaucoma group than in the control eyes. The more severe the glaucoma, the lower was the entire optic disc blood flow. B, in the OCTA vessel map, is there a reduced perfusion in glaucomatous versus non-glaucomatous eyes? This was a very beautiful study done by Chen et al., where he showed that both the vascular density and the capillary density, they are grossly reduced in glaucomatous eyes compared to normal eyes. Now, OCTA vessel density, is it of similar diagnostic accuracy to RNFL thickness? All of us will be interested in this question. So this study by Yar Mohammadi et al. In 2016 showed that the vessel density had similar diagnostic accuracy to RNFL thickness. The next question becomes, is there a correlation between OCTA, RNFL, and visual fields? And the answer to that is yes, extremely good correlation is there between OCTA, OCT RNFL, and visual fields. Is OCTA and GCC correlated? The answer is yes. So even at the micro level, there is a good correlation between OCTA and the GCC of the normal OCT. Now, this is a very interesting thing. Can OCTA detect pre-perimetric glaucoma better? And the answer to that is yes. Now, why? Because OCTA detects both the dysfunctional, that is the sick cells, and the already lost or the dead ganglion cells, whereas structural OCT only detects the lost ganglion cells. So in very early glaucoma, dysfunctional ganglion cells, which have a lower metabolism, so they lead to a reduced capillary density and perfusion. Now, does OCTA correlate better with visual field parameters than OCT? And the answer to that is yes, especially in advanced glaucoma, because like it was already mentioned by Dr. Pallavi, that there is something called a floor effect. So normal OCT, it reaches a floor effect in moderate to advanced glaucoma, whereas OCTA reaches a floor effect later. So OCTA can monitor advanced glaucoma better. Now, can OCTA be used for progression? Yes, this study by Lee et al. Showed a number of examples where they showed that it can be used for progression. Now, is the opposite true? Can it detect increased vascular density? So these two studies by He et al. And Kim et al. Showed that there was an increased vascular density after TRAB or suturolysis. And this is something in the domain of AI, etc., where can OCTA simulate the actual visual field results? So it has been, it's a known fact that it's very difficult to do an HFA. Whereas if you do an OCTA, it takes just a couple of seconds. So there are patients who cannot do an HFA. So what this particular algorithm does is, it takes an OCTA scan and it creates an OCTA-based simulated visual field. So the patient is not doing a visual field, there is a simulated visual field based on the OCTA results. So actually that can help a lot in patients who cannot do visual fields. And again, I'm going into the domain of Prasanna. Prasanna will obviously enlighten us a lot more. So with AI, machine learning, deep learning, Okta can open up a whole new world in glaucoma diagnostics. Thank you so much.
Thank you, Odijita, for discussing that extensively, the Okta. Now I would like to request Dr. Jayashree to present on who needs neuroimaging. Dr. Jayashree is a consultant glaucoma services, Shankar Nethralaya, Kolkata.
So here we are going to discuss briefly on who needs neuroimaging while we are treating for glaucoma. So this is just to give an idea when should we consider neuroimaging in a glaucoma patient. So we all know optic neuropathy can be glaucomatous or non-glaucomatous. So there is some overlap of sign and symptoms among both of these entities, and if we will not be careful, it will lead to misdiagnosis in few cases and also wrong treatment. So we need to consider a few points with which we can differentiate between glaucomatous and non-glaucomatous disc changes. So sometimes some of the non-glaucomatous optic neuropathy can also mimic symptoms of glaucoma, like patient can present with scotoma, like non-seeing area in the visual field. So in this condition, both the conditions should be considered. IOP is one of the known risk factor for glaucoma, and this can be a misleading factor in if there is a disc cupping with normal IOP. So we should consider both the scenario if IOP is normal and the patient is with changes suggestive of glaucoma. Disc cupping can also be seen in non-glaucomatous optic neuropathies like compressive optic neuropathy, retrobulbar neuritis, and all these causes. So, disc cupping is not always glaucoma. We should consider both the entities while examining the optic disc. Visual field changes can be present in both the cases. So, we will see one by one how we can get clues from clinical examination and clinical test to differentiate between these two entities. So neuroimaging we consider when we suspect there is a non-glaucomatous cause for optic disc changes. So if we start from history and clinical examination, younger age group, if they present with disc changes, it goes in favor of non-glaucomatous optic neuropathy, because glaucoma is usually seen in elderly population. It can be present in younger age group, but it is usually a disease of elderly population. So in young age, we should keep in mind that it can be a non-glaucomatous optic neuropathy. If patient present with sign and symptoms of other neurological features, then we should consider neuroimaging. Like patient can present with severe unilateral headache or headache as like generalized headache or ocular pain. Patient may complain of diplopia, or patient may present with restricted ocular motility. These all are signs of a neurological deficit, so it will point towards a non-glaucomatous cause of the optic neuropathy. RAPD in a glaucoma patient can be seen in a asymmetric case with severe glaucomatous cupping in one eye. If with minimal cupping RAPD is present, it will point more towards a non-glaucomatous cause. And color vision is a very good predictor of neuropathy that other than glaucomatous optic neuropathy. So these clinical examination will help us to differentiate between glaucomatous and non-glaucomatous optic neuropathy. When we examine the optic disc, the neuroretinal rim condition is very important, because in glaucoma there will be a central pallor, but in case of neurological causes, the remaining neuroretinal rim will show some pallor. So if there is a pallor of neuroretinal rim, it will point towards a glaucomatous cause, and it will, we should consider doing neuroimaging if neuroretinal rim pallor is there. In some of the non-glaucomatous cupping, isolated temporal thinning can be seen. So this also should guide towards the neuroimaging of that patient. So when we, in glaucoma, vision is preserved till very last. The central vision is preserved till very last. So if the patient first of all comes with the visual loss, then it will go in favor of non-glaucomatous cupping. And if the visual loss is out of proportion of the cupping, then also it indicate a non-glaucomatous cause rather than a glaucomatous cupping. If we see a unilateral disc change, other eye is totally normal, then also we should think about some neurological causes. There might be some SOL or a tumor which will be pressing over one nerve. So these findings, if present in the optic nerve, they will indicate that the patient needs neuroimaging. Visual field defect will be present in both the patients, glaucomatous and non-glaucomatous. So features in the visual field which will indicate that the neuropathy is non-glaucomatous if the visual field is respecting a vertical meridian. So it will not cross the vertical meridian. I'm sorry for the image is not present here. It is not showing here. In visual field, the scotoma will not cross the vertical meridian. Then it is more in favor of non-glaucomatous optic neuropathy. A central or centrocecal scotoma is more in favor of non-glaucomatous optic neuropathy. It can be seen in normal tension glaucoma also. So we need to pay attention to other findings also when we are saying central or centrocecal scotoma. If the scotoma is with very sharp border, like one point is severely depressed and the next point to it is totally normal, it is mostly a neurological cause, because in glaucoma the adjacent points also are relatively depressed. So if a known glaucoma patient with a visual field defect present with a sudden progression with all the parameters in control, normal IOP, then we should suspect that some neurological cause can be there for such a sudden progression. So in that case, rather than increasing the medication and all, we should consider doing neuroimaging in those patients. Some non-glaucomatous defects also, they mimic glaucomatous disc changes, like in NOIN and AION. There will be an inferior altitudinal defect if we don't pay much attention on the disc changes and other findings, then it will give an impression of inferior arcuate. So we should be careful. So what the neuroimaging modalities we use? We usually use MRI, brain and orbit, but in all cases it should not be used because there is a cost effective, we need to consider cost effectiveness also. So if with the above points we get some doubts, then only we can order a neuroimaging. Recently, they are doing neuroimaging in glaucoma patients. Like by histopathology, it has been proven that there is a volume reduction in lateral geniculate nucleus and visual cortex in glaucoma patient, because glaucoma is also a neuropathy. So by using neuroimaging, what they are doing, they are actually quantifying that loss, how much is lost in glaucoma patients. So this is still under research stage. So to summarize, if glaucoma is associated usually with older patients, usually with female gender, and the visual acuity is preserved in till very last, and the neuroretinal rim is usually pink in color, and there is a central para, there will be a focal or diffuse loss of the neuroretinal rim, and there will be associated peripapillary atrophy. Whereas in non-glaucomatous cupping, the patient is usually of younger age, less than 50 years, and disc pallor is very important, and paying attention to the pattern of visual field is very important. Thank you.
Thank you, Jayashree. Manas sir, sir, your comment on neuroimaging while treating a glaucoma, any comment regarding that?
When there is a confusion, we go for neuroimaging. If the case is already established as glaucoma, I do not order neuroimaging, but she said that there is a research going on for the possibility of structural loss in the lateral geniculate body and other things. But still it has not come in the clinical review. We go for clinical, the neuroimaging for all those, when your symptoms and signs are not matching and all those atypical things are present, which he elaborately mentioned. I think those are the indications.
Thank you, sir. Next, I would like to ask Dr. Alokesh Ganguly, sir, Senior Consultant, Priyamada Eye Hospital. And he will be talking on revisiting SLT, emerging role in glaucoma management.
A very good morning to all. So today I will be speaking on selective laser trabeculoplasty and the emerging role in glaucoma. Though I must confess at the very outset that my experience with SLT is about 3 years ago and not more than about 100 cases, about a quarter of which were a part of a study which we did for treating with SLT secondary glaucoma post-PKP cases. So we all know that IOP reduction is the primary goal in the treatment of glaucoma, and selective laser trabeculoplasty is definitely having a special role in this armamentarium. So what is the mechanism? It is delivered by light energy which is provided by a specially designed Q-switched frequency doubled Nd:YAG laser which operates in the green spectrum around 532 nanometers with an output from 0.3 to 1.5 millijoules. The underlying mechanism is a selective photothermolysis which enables the laser to precisely target intracellular meninal granules while not disturbing the adjacent non-pigmented cells. These in turn release cytokines which trigger a targeted macrophage response which reduces the outflow resistance and thereby lowers the intraocular pressure. Now, if you compare with argon laser trabeculoplasty, the electron microscopy of the trabecular meshwork after SLT on your left-hand side and on the right-hand side, that after ALT shows greater destruction of the architecture and greater fibrosis and damage to the trabecular meshwork. Now, as opposed to argon laser trabeculoplasty, it is not necessarily in SLT to have a small spot size or precisely target a site. It is a large 400 micron spot which can be easily directed into the trabecular meshwork with a specially developed gonio lens. And unlike ALT, the focus is not critical because the depth of focus is far greater than the 50 microns ALT spot. Normally, preoperatively, careful gonioscopy has to be done to visualize the trabecular meshwork to plan the treatment area. Patients on prostaglandins we had planned to shift before 2 weeks of doing the SLT, and preoperative medications were 1 drop of brimonidine in topical anesthesia. And the treatment can be done 180 degrees or 360 degrees depending on that, the burst mode and placement of 100 plus minus 5 or 50 plus minus 5 contiguous spots, 400 micrometer laser along 360 to 180 degrees. Bubble formation is monitored with each pulse and accordingly we can decrease the power. Nagar et al. Had randomized patients for the degrees of trabecular meshwork treated, and although there was no statistically significant difference in outcomes after 180 degree or 360 degree, success rates were better with 360 degree. So this is how it looks, the focused beam on the trabecular meshwork. We can share as you can see here, the SLT beam is focused and the pulses are fired, and you can perhaps make out the small air bubbles which are released into the aqueous chamber. So after laser treatment, nepafenec eye drops had been used by us and other anti-glaucoma medications were continued and gradually tapered. Now there are many studies on SLT, and I think this particular study, which is a systematic review and meta-analysis of several random controlled trials of SLT treatment has a value that it shows that SLT is non-inferior to ALT and medication in IOP reduction and has achieved treatment success. So, we did not do many cases, but unfortunately we did not have the full data analysis. So my dear friend and colleague, Dr. Ganesh Raman from Coimbatore, Arvind Eye Hospital, was gracious enough to share his data with me. They had studied the primary effect of SLT in ocular hypertension and primary open-angle glaucoma at 1 year, and they compared the results in OHT and POAG, and the effect of SLT in treated as well as treatment-naive patients. These were the inclusion criteria, the data collected. These were the baseline demographics. I will not go into details of it for the interests of time. And what significant point came out of their study was this, that in a multivariate model, they found that there was no significant difference associated in the results on SCT in glaucoma with age, gender, CCT, or the status of the ocular hypertension. The mean IOP reduction was from 22.43 millimeters of mercury to 17.53 at 1 year, and the IOP reduction was observed to be around 23.23% in the OHT group and a little lesser, but around 17% in the primary open-angle group at 6 months. And these data significantly correlate with the many studies which were done all over the world. The most important part is this, and which I lay stress on, is that the mean number of medications in their study reduced from 0.76 to 0.004. In the OHT group, it was 0.6 to 0.02. In the primary open-angle group, from 1.22 to 0.09. And this, I think, bears a lot of significance in our scenario. And they also found that SLT works equally well in treated as well as treatment-naive eyes. It was a study which had its own limitations. So I will just briefly share our result, the data which we have of doing SLT in secondary open-angle glaucoma post-PKP eyes. Now, the problem of post-PKP glaucoma is manifold. There are many mechanisms which can contribute to it, and there has been case reports of selective laser trabeculoplasty tried in glaucoma after penetrating keratoplasty. Now, we had eyes of 22 patients who had undergone PKP and developed quite severe secondary open-angle glaucoma. And the problem which we faced actually was visualization of the trabecular meshwork and focusing of the beam because of the distortion to a certain extent created by the graft-host junction. But nonetheless, as you can see in this slide, we could manage to visualize the trabecular meshwork. So we did not find any statistically significant differences in the intraocular pressure measured up to 6 months. This was not a study which was longer than 6 months. But however, the mean number of medications were significantly reduced, and that in post-PKP eyes, I think, holds a lot of value. And we did not note any pass formation, and the decreased drug requirement was of primary importance in the outcome from our study. These were our references. Thank you. And just a note to share from one of our friends and colleagues, Dr. Amit Porwal. Please do support him at the IOS. Thank you.
So our next eminent national speaker, Dr. George V. Putharan, graduated in medicine from Government Medical College, Kottayam, and completed his MS in ophthalmology from Arvind Eye Hospital and Postgraduate Institute of Ophthalmology, Madurai. He joined Arvind Eye Hospital, Madurai as a full-time consultant in 1999 and currently heads the Department of Glaucoma there. He is actively involved in teaching and training residents, fellows and practicing ophthalmologists. His areas of research interest is use of glaucoma dentist devices in refractory glaucoma. He worked closely with an Orolab, the manufacturing wing of Arvind Eye Care Systems, in the evolution and widespread use of affordable aqueous dentist implants, and has extensively published on its safety and efficacy outcome. So he will be talking on pediatric glaucoma, management of pediatric glaucoma. Thank you, sir.
Thank you. Good morning, everybody, and thank you, OSWB, Surojit, and Manish for this kind invitation. It's my privilege to be here. So I will just have just discuss some broad guidelines in the management of childhood glaucoma. So the World Glaucoma Association has published a series of reports that covers different aspects of glaucoma, and the consensus series 9 is dedicated to childhood glaucoma, and I would strongly recommend this publication for any pediatric or glaucoma surgeon interested in taking care of childhood glaucoma. So the definition of childhood glaucoma and the classification of childhood glaucoma in this WGA publication is from the Childhood Glaucoma Research Network. And definition of glaucoma is in the childhood group is any two or more of these factors. Intraocular pressure more than 21 millimeters of mercury, optic disc cupping, corneal findings like Harv's striae edema, a corneal diameter of 11 millimeter or more in newborn, more than 12 millimeter in a child who is less than 1 year of age, or more than 13 millimeters at any age is highly suspicious of glaucoma. Progressive myopia or myopic shift, and a reproducible visual field defect. The classification is also from the CGRN group. It's classified as primary childhood and secondary childhood. Primary congenital glaucoma and juvenile open-angle glaucoma are primary childhood glaucomas. And again, secondary childhood glaucoma is also beautifully classified in this publication. It's as glaucoma associated with non-acquired ocular anomalies. These are basically ocular abnormalities present at birth, may or may not be associated with systemic anomalies. Aniridia, accent field rigor, congenital ectropia on uvea, Peters syndrome are all belongs to this group. The next is glaucoma associated with non-acquired systemic disease or syndrome. These are children who are born with systemic anomalies, may or may not have associated ocular findings. This involved the phacomatoses, the Sturge-Weber syndrome is a major part. Even other metabolic disorders, connective tissue disorders, metabolic disorders like mucopolysaccharidosis, connective tissue disorders like Weil-Marchesani, microspherophakia, these are all come under this group. Next is the glaucoma associated with an acquired condition. Here the acquired condition has been diagnosed and treated before the glaucoma develops. Uveitic, post-trauma, steroid-induced, any surgery other than cataract surgery. In the CGRN classification, glaucoma following cataract surgery has been given a separate category just to highlight its frequency. It is one of the most common causes of secondary childhood glaucoma. So this classification is what peer reviewers expect in their peer review process. Coming to determining glaucoma progression, the key features to monitor intraocular pressure, the Goldman, the applanation remains the gold standard, either a Goldman or a Perkins. Eye care is gaining more and more important, especially as an office assessment of intraocular pressure. Optic disc changes remain the hallmark for diagnosing and determining progression. Corneal features I've already mentioned. Edema, Harv's striae, extremely important to document corneal diameter in all children undergoing cataract surgery. Again, refraction, progressive myopic shift, increase in axial length. Corneal diameters can increase up to the age of 2 years. Axial lengths can increase up to the age of 7 years. Visual fields might be challenging. Ultrasound and ultrasound biomicroscopy are also useful tools to diagnose and determine progression. A single slide on central corneal thickness. Even though, the role of central corneal thickness in pediatric glaucoma care has not yet been well established, we should not be adjusting the intraocular pressure just like how we do with the adult population. And despite the theoretical overestimation of intraocular pressure, children with aphakia develop glaucoma, and optic disc assessment remains the most important feature, again for diagnosis and progression. This is the protocol our anesthetists follow. For an examination under anesthesia, child is between 3 and 12 years. It is with intravenous propofol plus either fentanyl or ketamine. And less than 2 years, it's always intravenous ketamine, very rarely inhalational sevoflurane. But again, we should keep in mind that inhalational sevoflurane can profoundly and dramatically reduce intraocular pressure. And if you have to continue with the surgery after the EUA, the induction is usually done with thiopenton sodium, which is for newborn to 3 years of age. Again, intravenous propofol for 3 years and above. Muscle relaxant is either a succinylcholine, a vercuronium, or an atracurium. And it's very important to measure the intraocular pressure as soon as the induction is over. And then the intubation comes, which is maintained with laryngeal mask airway, and maintenance mask is with nitrous oxide, oxygen, and sevoflurane. Medications alone rarely show sustained efficacy as primary treatment for glaucoma in infants and young children, but it's frequently needed as a temporizing IOP lowering treatment before surgery, as adjuvant therapy after partially successful surgical procedures in childhood glaucoma. Glaucoma surgery is the critical component of management of childhood glaucoma, and I'm absolutely convinced now the first chance is the best chance for long-term success in childhood glaucoma. You need to prepare the patient and parents or caregivers for lifelong follow-up and possible future surgeries, and preferably be done by trained surgeons in centers with sufficient volume to ensure surgical experience and skill, and also to ensure safe anesthesia. These are the surgical procedures which are available for us: a goniotomy, a trabeculotomy, which can be a conventional or a suture trabeculotomy, combined trabeculotomy, trabeculectomy with mitomycin, aqueous drainage implants, and cyclodestruction. See, there are very few randomized surgical trials for pediatric glaucoma, and in such a situation, consensus becomes very important for us to decide on the line of management in these children. And I've taken some perspective from the largest ever worldwide surgical pediatric glaucoma consensus survey conducted by the World Glaucoma Association. And out of the experts surveyed in primary congenital glaucoma, 28% of experts would opt for a goniotomy as their first procedure of choice in PCG, trabeculotomy by 41% of experts. That is the conventional probe, 28%, and circumferential, 13%. And only 14% of the experts chose CTT, that is combined trabeculotomy, trabeculectomy. We need to have a fine balance between increased efficacy and decreased complications, and surgeons' training and experience significantly influence their choice of surgery, geographic location, and also facilities and equipments available there. Very early in my career, I was exposed to children with cloudy corneas. Somehow, we didn't have an option of goniotomy in many of these children. And even now, a conventional 90 to 110 degree harms trabeculotomy, conventional trabeculotomy is what works best in our hands. We don't combine it with a trabeculectomy with mitomycin. No anti-metabolite is used. It is a fornix-based conjunctival flap. We prefer to have a rectangular scleral flap, a partial thickness rectangular scleral flap, which is very carefully, the sclera is much thinner here because of limbal enlargement or stretching here, and carefully and meticulously the rectangular scleral flap is dissected towards the limbus. So the most important aspect here is to identify the Schlemm's canal. It lies in the corneoscleral sulcus, that is the junction between the gray to the white transition from the cornea to the sclera. And a radial incision is done. Actually, if you can really, under very high magnification, if you can focus at that corneoscleral sulcus, sometimes you will even be able to appreciate droplets of aqueous percolating above the Schlemm's canal. A radial incision 2 millimeters made at this corneoscleral sulcus. It is deepened very carefully till as soon as the outer wall of the Schlemm's canal is dissected, is cut, a little bit of aqueous and blood tinge can be seen. So this is your Harm's trabeculotomy, which is inserted into the Schlemm's canal, and once completely inserted, it can be passed anteriorly, cutting across whatever trabecular tissue is there into the anterior chamber. Sometimes after your one half of the trabeculotomy is done, the anterior chamber might collapse, but you could still go ahead, insert viscoelastics, and proceed with the other half of the trabeculotomy. And 90 to 110 degrees is what we target. And as I was mentioning earlier, suppose I am not able to identify the Schlemm's canal. Literature says up to 15% of trabeculotomies, we may not be able to identify the Schlemm's canal. And that is one of the most difficult, disappointing days. If I could do a 90 to 110 harms trabeculotomy for a primary congenital glaucoma, that is still what works in our hands. And we try and do bilateral trabeculotomies in the same sitting. This is child, I had primary PCG in the other eye, as long as the anesthetist allows us to do. I have mentioned all this. A very little role for trabeculectomy with mitomycin in childhood glaucoma. Coming to glaucoma drainage devices, preferred primary operation for 44% of experts in glaucoma in aphakia, in glaucoma following congenital cataract surgery. And this is our, if an angle surgery fails, our plan of management is to repeat the angle surgery, and then if that too fails, go in for your GDD. Surprisingly, 63% of the surgeons surveyed here opted for the Ahmed, 41% the Bawel, 92% of the experts thought better drainage devices were needed for childhood glaucoma. Just a few points about GDD in children. The tendency for the Ahmed glaucoma for bleb encapsulation and tenonsis is much more with the valved implant like the Ahmed, and the barbelled or the Orolab aqueous drainage implant seems to be working better in the pediatric age group. We prefer to have the tube embedded in the patient's own sclera in a sufficiently adequate length and depth of the track. A 23 gauge needle track is generated 4 millimeter posterior to the limbus. I'll be covering a part of this in the next talk, so I will skip this. But embedding the tube in the patient's own sclera is what is working very well in our hands. We used to have a lot of tube exposures were a major problem in the pediatric age group. With this technique, we still have tube retractions, we still have tube lens touch, tube corneal touch, but tube exposures have been dramatically taken out of the equation in pediatric glaucoma. Cyclodistraction, very little role, difficult to titrate. Most clinicians reserve cyclodistraction until other treatments have failed. But again, what is surprising is 15% of experts in this survey advocated it early in the treatment regime, especially in very high-risk patients who have a high tendency for hypotony and suprachoroidal hemorrhage to intraocular surgeries. They prefer to have a diode or a micropulse before actually going in for your intraocular surgery. The cornea and the glaucoma have an intimate relationship. Always try to address the corneal edema, the raised intraocular pressure, before any kind of corneal surgery is planned. And this is my last slide. It's extremely important, once you have your intraocular pressure control, extremely important to address the emetropia. Amblyopia is a major reason for suboptimal vision in pediatric age group. You need to refer these children with low vision to visual rehabilitation and low vision aid services, and patients and caregivers' quality of life is becoming a very, very important part of pediatric glaucoma care. Thank you very much.
Thank you, sir. I would like to ask Dr. Kajal sir and Parak sir to felicitate Dr. George sir. With this, we conclude the first session. I would like to hand over to Dr. Urjit Mitra sir for moderation of the next session.
Very good morning to everybody. I'll be taking care of the second session, and I'm sure it's going to be as interesting as the first one. So I want to introduce a fresh face to people probably who do not attend GSI or they've not seen Prasanna in action at AIOC. So I'm just going to present a slide, and I'm going to introduce Dr. George, Dr. Muli again, because we love slides so much. So I'm just going to give a brief introduction of Dr. Prasanna. He did his glaucoma fellowship under Dr. Satyen sir, and he's currently the glaucoma medical officer and research director at Mahatma Eye Hospital Private Limited at Trichy in Tamil Nadu. He has published 4 chapters, and look at the number of publications. It's around 120 manuscripts in various journals, 65 of them in the IGO. He is the assistant editor of the glaucoma section and an editorial board member 23-24 for the IGO. He is an associate editor, the editorial board member 22-24 for the TNOA journal. The total number of scientific ophthalmic presentations, again, the numbers are mind-boggling, around 256. He's been a chief instructor at TNOA, GSI, AIOS, and APAO. He's a recipient of various prestigious awards at all the national and international conferences. In fact, at the GSI, he's making a clean sweep every year. His interest in areas of research deserves a special mention because he's interested in glaucoma imaging, MIGS, ophthalmic moving images, augmented reality, extended reality, artificial intelligence, and 3D printing. He's a part of the app developing an academic filmmaking committee in the TNOA, and he's an executive member of YOSI. So I could have had a long presentation. I left out a lot of things to make it short. So I would like to invite Prasanna to give his talk on AI. So this is something which he has been working on, and a lot of these youngsters, Prasanna, John, they are working and doing amazing job. So over to you, Prasanna.
Thank you, sir, for the sweet introduction, and without wasting much time, let us move into the topic. So artificial intelligence and glaucoma. For the next few minutes, I'll just take you into a different world, but which is also very important. So AI and AR, we talk on artificial intelligence, augmented reality. Is it just the hype? When somebody talks on AI, is it just the hype or is it something real? Yes, my dear friends, it is something which is very real and happening, and it has revolutionized our lifestyle. So how it has revolutionized our lifestyle? We all have our smartphone. We use the face recognition tool to unlock the 2D or 3D smartphone that we use daily. Don't we use it to unlock? We use the fingerprint, the iris, the finger vein pattern recognition. Without our knowledge, slow and steadily the AI has actually penetrated into our lifestyle. We don't know these are AI, or we cognitively think these are not AI, but these are things that have slowly come into the lifestyle of ours. So this is one of the first unmanned car that has recently been launched with a LiDAR sensor, which I have also used in one of my innovations, where you can see it knows where to stop, where to start, if there is a traffic, how it has to navigate. And slowly but surely, even the NASA's first unmanned aeroplane where there is no pilot. So it is slowly coming into the lifestyle, and it has entered ophthalmology and glaucoma. Why glaucoma is? Because it's an image recognition field. There are a lot of imaging. We saw visual fields, the OCT, the OCTA. Since it's having a lot of imaging, the fundus photography for that matter. So I'll just take you through one of my publications, an original article of mine, where we have used human in the loop machine learning. It's not only AI, it's human intelligence with AI and how it is slightly different. So I always compare AI to the human anatomy, where you can see we are made up of a lot of central nervous system and peripheral nervous system. Similarly, if you see the AI intelligence algorithm neural network, they are also made of the same CNS or the PNS that we are also made of. So I always say that it's just like a baby. We need to teach it. We need to make sure it evolves into a full mature algorithm or a mature human. So how did we go about creating our AI? So we use the product of annotations, because as I told you, there is something called annotations where we need to mark the image and teach the image, because we need to break the black box dilemma. The black box dilemma is why the AI predicts the way it predicts, if this is glaucoma or this is not glaucoma. That is something that is not clearly understood even till date. Unless we want to understand or create an explainable AI, we need to break the black box dilemma. So what we did was, for example, if we take a fundus image, we annotate by human interface. The humans will have an interface, they annotate. it goes into the data set. We collab with a company called Sandstone AI, and then the predictions were made. Again, the predictions had a human validation. So the humans again validated. Humans being we ophthalmologists or glaucoma specialists. So we validate, and then the image is predicted as correct or incorrect. If it is incorrect, again it goes into the training protocol. So this was our methodology, and we not only took the image, we annotated different aspects of the image. So the disc was annotated separately, the cup was annotated separately, the macula, the vessels, and each findings that we took 26 intricate findings. As I showed you, the increased vertical cupping here was annotated. And to label a few, even the RNFL defects, we use confocal images. So even if there are two slit RNFL or arcuate RNFL defect, they were annotated separately. Bionetting signs which were non-specific, the splinter hemorrhages. So the more we teach the machine, that the more the human intelligence that we started using, the peripapillary atrophy, as you can see, the tilted disc, we can label a few. A single image is taught so many different points like this. You can see the so much of clusters that the human has actually annotated. Again, an example of another image. You can see the cup, the disc, the peripapillary atrophy, the RNFL defect, and again another RNFL defect. The two defects were separately annotated, and the overall annotation. So the more we annotate, what happens is the machine's objectness loss. So what is the objectness loss? The object marked wrongly by the AI, that tends to come down, which is actually good for us because the machine is now improving. Again, the classification loss. What is that? That is wrong classification by the AI. That also comes down, which actually happened with our model that we innovated. So it comes down, thus giving us a thumbs up sign that the precision is improving, the recall is improving, and the mean average precision. I'll not go into the terminology of AI, but these are all thumbs up signs that we are moving in the right direction. So if you show an image like this, not only a glaucoma diagnosis is made, but you also get even every intricate findings of the cup. The cup is separately annotated along with the predictions, because more data we fed, now the more output that we are getting. Even in this you can see, if this image is fed into our model, we also get the RNFL defect. So thus, it's an explainable AI. We want an explainable AI because we don't want an AI which is not explainable, which is very scary. Again, these are some examples where we are seeing the predictions. So we have worked an explainable AI with good sensitivity and specificity. Now it's about improving a multimodal model. A multimodal AI being, as my previous speaker was also telling, even the OCT, OCTA, the visual fields, all has to be integrated together so that we process and segment in a single patient. Every data can be processed together, and we specialize in human in the loop training where we use human intelligence along with the artificial intelligence. So again, this is one of another publications of mine where we are now doing the AI for the angles. So this is the process that we follow. We always go into the basics, my dear friends. Always detect the scleral spur. I'll just show you the image now. You can see that the yellow dot here is the scleral spur, because humans, we never get replaced. We are always there. So we detect the scleral spur. Then measure the trabecular meshwork, which is 500 meters anterior to the scleral spur. You can see that the green dot is what we have placed 500 meters anterior to the scleral spur. Then now let us see how we created the angle protractor. This is a video just depicting the protractor that we created. So once the scleral spur was identified, then the trabecular meshwork, then a perpendicular drawn to the trabecular meshwork to the iris, then you have the apex, and then you get the triangle. A triangle is now completed. So now we have innovated a protractor which measures the anterior chamber angle, where you can see that this is a protractor that we have innovated. We keep the two arms of the protractor on the two sides of the triangle, and once you do that, you can see that the angles is now obtained. So this is where we bring in the human element. The human intelligence will always be there to monitor the AI, and with that the results are more explainable. So this is the protractor of ours which we recently innovated. This can be used in UBM imaging annotation. All the parameters that are already known to us is now being taught to the AI by humans. The lens wall, the pupillary diameter, ARA. This is a schematic plan with which we are working on the anterior chamber AI. And this UBM, not only UBM, we can also use it for anterior images, ASOCT images, and sheen plug images. These are all images of ours, and we are working currently on a multimodal AI for anterior chamber angle assessment. So as I was pointing to you, the growth of the AI model has to undergo the same phase as the baby or as how we are growing, because it's not just a stop short or a shortcut. It has to undergo the processes, and we make sure that with the human in the loop training, we take it easily one step at a time forward. And this is the models that we have made. All this is my own literature. You can always go back and see this. We are also now currently working on blockchain technology to integrate artificial intelligence, because AI is more of data. How can we decentralize the data under a common roof? And that is one thing that we are also working with, so much of data that we have. And this is again the models that we are creating. So feel free to go back and see all these references. And to also give another dimension on the AR part that we are doing, which I also feel will be the future of e-glaucoma. So these are two innovations of ours, my dear friends. You can always take a screenshot of this and get your own app downloaded if you have an Android or an iOS phone at the end of the day. So you can see that just with a simple smartphone, currently what we are doing is we are trying to work on simulators as well. Just with your smartphone, between the smartphone and this piece of paper, you can see the eyeball model will just appear, and with the smartphone you can have a three-dimensional cognitive overlay just like a simulation. It's a cost-effective simulation, zero cost, the app's free of cost, and today you can have real images. We have used real images, and you can see this is a teaching module class that my friend here is demonstrating, where you can move through it, navigate through it, and have teaching module classes. Not only teaching, even surgery is also possible. I'll just show you that video. We have used real fundus images, real angle images. As you can see, we have taken real angle images and constructed the AR models so that it gives us a much better way. Even for counseling, as you can see, this is the model of just a phone recording of my smartphone recording, and I'm just shown it here. Even for a YAC BA counseling or an SLT counseling, ALT, any procedure for that matter, we can beautifully explain the patient that what we are currently doing. And even when we have the defects of RNFL defect or a splinter hemorrhage, this is an example of a splinter hemorrhage AR 3D model, and this is an example of an RNFL model, which is also very useful to highlight it. So this is simulative glaucoma learning, which I feel will be the future, where again we also invented a 4D technology. You can see my friend here on the right. He's as if he's moving through thin space, but he is actually holding the case sheet of the patient. This can be an EMR also in the future, where he's examining the case of that particular patient, how the defect is, and even the OCT can also be pulled out of it. That is something that we are currently working on. The slices of the OCT can be pulled out of it. I'll just show that video too. So this is something which is very fascinating. It's no more science fiction, my dear friends. It's a science-based reality. I do have the demo with me. I'll demonstrate to you maybe after the session or so. So this is all possible, and currently we are doing this in our center at Trichy, Tamil Nadu, and we are trying to outsource this as soon as possible. Again, this is an RNFL defect that you can see that my friend here, what he's seeing through his eye is what you see on the left side of the image. So what Tony Stark, the Iron Man, he did in Avengers, right? It is no more a science fiction. It's science-based reality. We are trying to make it as science-based as possible. And this is also there in the literature. We have published extensively on this too. So this is again an MIGS simulator that we have created. You can see my friend here. His hands are coded in the metaverse. So you can see he's moving his hands. So this is how it looks in the metaverse. And now you can see that he's clicking, he's just checking how, okay, now he's taking the eyeball here. And the eye stent inject, where we have the two eye stents, which is not possible to have a demo. We went and made the simulator for this. So when he correctly injects the eye stent into the trabecular meshwork, this turns green, saying that he is in the right plane. So all this gives us a good spatial orientation. So just like the pilots who have a lot of simulators, we too can have a simulation and then go in for our real surgery, where it really benefits a lot for developing our 3D skills. It's patent protected technology of ours. So these are some of my literatures, extensive literatures. Even in the European journal, we had an issue published on augmented reality. As I told you, not only fundus, we are trying to integrate it as much as possible and trying to create an EMR as well with this, where not only we get the fundus, we can also extrapolate the OCT out of it. So with these kind of technologies, teaching, counseling, even diagnostics also can be revolutionized. Even patients counseling before treatment, after treatment, 4D telemedicine, 4D multimodal imaging. So my dear friends, to summarize, it's always not an arm wrestling between the doctor and AI, because we always are on top. We will always monitor it. During the inception, I too thought it's going to be arm wrestling between the doctor and the AI, but today I feel it's more about doctor and the technology working together, because we all have a common goal towards the community. So we all want to bring in something to help the community or our fellow neophyte surgeons for simulations and other things. So with this, I thank I thank the Ophthalmology Society of West Bengal for giving me this opportunity to present my talk on AI and AR. Thank you.
Thank you so much, Prasanna. For people like me who have heard him before, it still seems as amazing as I'm hearing it for the first time. And for people who've heard it for the first time, I'm sure you're left wanting for more. Because every talk that Prasanna gives, there's something new. And within a span of 6 months, I mean, he's way ahead of what I had heard him 6 months ago. So it's amazing. And at this year's GSI, he had shown the simulation on stage.
Yes, sir.
So, you know, a person with the headset, etc. So it's something amazing. It's a new world. This was just a peek into this world. And I'm sure Prasanna will be called for a number of more talks
I'll
in the
definitely
future.
do a demo during the free time. I have my phone with me.
Yeah, so feel
whenever
free to.
free, yeah. Thank
so
you,
I'm
sir.
sure everybody is wide awake now. I'd like to call Shekhar sir and Muhammad Yasin sir to please felicitate Prasanna.
Yes, sir. It's okay.
Okay, so let's move on to the next topic. So this session has really turned out to be interesting, and the audience can enjoy a cup of coffee along with the talks. But I'm sure after Prasanna's talks, everybody is just wide awake. Wow, what's this? The eyes are wide open. So I'll just introduce Murli sir again, because I've seen sir from the time that I was there at Arvind, and I'm still in awe of whatever he does. So Dr. Murli sir is the director and the senior consultant at Swami Eye Clinic and Chennai Glaucoma Foundation. He is the head Department of Ophthalmology, Sundaram Medical Foundation. He is the director, research and head Glaucoma Services, MN Eye Hospitals, Chennai. He is the DNB faculty and teacher at MN College of Optometry in Chennai. He is a member scientist of the MN Eye Hospitals Institutional Ethics Committee. Dr. Murli has been mentored by stalwarts like Dr. Ravi Thomas and Professor Robert Rich. He has more than 30 publications in peer-reviewed journals, and he has written a number of chapters in various textbooks, which sir has already shown. He has CDs on automated perimetry and videos on trabeculectomy. He has edited a book called Practical Perimetry, and I would advise everybody to read it. In fact, whatever I know about octopus is because of Murli sir, because he's been talking about octopus for years and years. He received the Best Scientific Presentation Award for Pharmacoeconomics in Glaucoma Medications at GSI Chandigarh 2008. He has been a member scientific committee of the SROC and the TNOA. He was the treasurer of the GSI from 2008 to 2010. And he is also on the expert panel glaucoma of the AIOS Scientific Committee Group in 2013. And he has been the project leader of the TNOA ARC program in glaucoma from 2012 to 2013. I had to keep on reducing Murli sir's photograph, so it's turned out to be this small. So don't blame me if his achievements overshadow his photo. So over to you, Murli sir, please.
I'm still recovering from Prasanna's talk. So Prasanna has been an amazing presentation. I think Arijit and others, all the speakers have been amazing and wonderful talks in the morning. I think each of us has something to convey and a lot of take-home messages as well. So coming back to reality, I think I realized I pinched myself to say I'm in Marriott Hotel in Kolkata now, coming back from the virtual and augmented reality of the presentations. So back to work, back to normal. So we need to understand how to manage glaucoma. So some practical tips and maybe a systematic stepwise approach to how I treat my patients. This is not the only way to manage glaucoma. You have your own, of course, options, and you have the guidelines, and you have so many of your personal experiences and your practicality of how you can apply it to your own practices. A systematic approach to managing glaucoma patients medically is to first get the diagnosis right. Then categorize the risk of a particular patient having a risk of getting worse over time, and then set a target IOP range. Mark the word range. It's not just one single number. It's a target IOP range. You just set a range. Say, I want between 14 and 18. I want 16 and 18. Some range you can set for the patient. Then once you have this in mind, you choose the medication. What drug is going to choose which patient and which eye of the patient. Then lastly, once you've done all this, you have to monitor and see is the patient getting worse or not. If the patient is getting worse, you need to scale up, modify, alter the treatment depending on tolerance and so on. So keep this as the basic systematic way as to how you would approach medically a glaucoma patient. I think this is from the IGO, the patient with suspected glaucoma. This is possibly leading on to a diagnosis of either ocular hypertension, so-called pre-perimetric glaucoma, in which you don't see changes in the visual field, but you see changes in the structure. You have the classic open-angle glaucoma with all of these findings. And of course, you have the corneal thickness, a normal, so-called normal tension glaucoma. You need to look at central corneal thickness. You have to do a diurnal variation, all of these aspects. Make sure you get the diagnosis right. You have an NTG, you have an OHT, you have so-called standard established POAG, and make sure you got everything right before you start. Have a good evaluation of the patient before you start to, there is no hurry to rush in and start treating every patient you see today or in the afternoon. Today you're seeing somebody with glaucoma, you can re-evaluate the field next week. You can do an OCT after a month. You can reassess the pressure in a different time of the day. Don't be in a hurry. Glaucoma doesn't blind the patient in a week. You have time, you need to wait, you can assess and reassess, get a proper perspective before you start treating. The same thing applies with our angle closure scenario as well. I think the simple classification of angle closure spectrum, as it is called, is PSCS, PSC and PSCG. We need to, of course, do the gonioscopy, do whatever imaging you like, do establish the optic nerve changes, any method of establishing the field loss. Look at all of this, and of course in the spectrum of angle closure disease, if it is PSC and PSCG, you would start off first with a YAG-PA. Don't forget to do a YAG-PA before treating medically, which means that the gonioscopy is the key element in managing glaucoma, to distinguish between open angle and angle closure, to distinguish between various aspects of the spectrum of angle closure disease. You need a gonioscopy. So gonioscopy is a key element. Without a gonioscope, don't start your glaucoma practice or any ophthalmic practice. Keep your gonioscope, keep your 78-90D lens on the slit lamp, and don't put it in drawers and lock it up. Many centers where we go for examiners and for approving centers, we find the lenses are locked up in cupboards. You need to get the key from somebody and so on. Keep it on the table, don't hesitate. The threshold to use a gonio lens or a 78 or a 90 lens should be nil. Use it on everybody, every presbyopia patient, every kind of patient whom you have been seeing initially. Do the gonioscope. Gonioscopy, as the speaker mentioned in the morning, is a visual science. You need to keep on doing gonioscopy for you to understand various aspects of the angle, the pigmentation, the different aspects of abnormality and so on. So don't hesitate, diagnose, do the YAG-PA. PACS, obviously we would not do YAG-PAs for all of them because the prevalence of PACS is quite high. Approximately between 5 to 10% of our population has PACS. So you would not do YAG-PA for all the suspects. But for PSC and PSCG, you would definitely start with an iridotomy and then go on to medical management if necessary. So studies have shown us that lowering the intraocular pressure actually helps in all types of glaucoma. So be it open angle, be it angle closure, be it ocular hypertension, be it normal tension glaucoma, any kind of glaucoma, you lower the intraocular pressure. That is the basic thing in management of glaucoma. So how would we lower it? We have to first decide what is the risk of this particular patient getting worse or the glaucoma getting worse. Second is, of course, we need to know what target intraocular pressure you're going to set for a given situation. And then, of course, you choose an appropriate medication depending on whatever is available to us and what the patient can tolerate, what the patient can afford, and so on. And then, of course, you monitor and see what's happening. So how do you categorize this risk of any patient getting worse over time? I borrowed some examples, some scenarios from different guidelines. This is from the Asia Pacific. It tells us that somebody with a very high 5-year risk for progression are patients with moderate advanced glaucoma and field loss, a very rapid rate of progression, a very high initial IOP, bilateral field loss, pseudo-exfoliation in pigmentary glaucomas, fixation threat like this going close to fixation, young patients with very advanced disease, and angle closure glaucoma. Angle closure glaucoma is said to progress a little more quicker or faster than the POAG patients. So keep all this in mind and say, yes, your antenna is up and say, this is a high-risk patient. You're going to probably set a different kind of target pressure. And similarly, you look at the moderate 5-year risk for vision loss. You look at mild glaucomatous loss, mild field loss, not coming into the central 5 or 10 degrees. You have moderate glaucoma with a low IOP of 14, 16, 17, and so on. And PSC with high IOP and PS, not yet. You don't see changes in the optic disc as yet. these are all probably the moderate risk for vision loss. Who are the ones who are less likely to lose vision over the next 5 years? Is ocular hypertension. Most of our colleagues I would find are aggressively treating ocular hypertension. 21 pressure, 22 pressure on non-contact tonometry, everybody is on prostaglandin, everybody is on Combigan and so on. So don't over-treat ocular hypertension. You have a time frame for which the glaucoma can develop. You have enough time. And you also don't have to treat the risk according to the ocular treatment Oath study which showed the corneal thickness data versus the risk of developing glaucoma. You can even do risk calculation and see. You will find that generally if you don't have to treat between 21 and 26 and even 28, equivocally you would treat anybody over 30. So between 28 and 30 is your call. But less than say 21, 22, 23 with normal disc and normal fields and say open angles and so on, no other secondary cause, you don't have to really treat every ocular hypertensive. Similarly, very, very elderly patients, a 90-year-old or an 85-year-old with a borderline pressure of 24 and 26, you don't have to treat all of these patients. PSCS. PSCS just observe annual gonioscopy, periodic gonioscopy and so on. Pigment dispersion is a normal IOP. Don't treat initially unless you're really sure. Not every pigment dispersion becomes glaucoma. One eye may have, one eye may not have. Similarly, steroid responders, once you've identified the cause and stopped the steroid, these patients are not going to really worsen over time unless you of course have to monitor them. So these are just a few examples. This is not exhaustive. The list is not exhaustive. There's so many more examples which I can cite. So how do you decide once you have a risk of somebody getting worse quickly and as to somebody getting maybe a mild risk for getting worse for the next few years, how do you set the target intraocular pressure? So we need a higher target pressure and a lower target pressure depending on the stage of the glaucoma damage. Is it severe? Is it early or advanced damage? The life expectancy of the patient, the level of the untreated intraocular pressure, additional risk factors which I will come to a little later, and the rate of progression. So I'm sure all of you will be considering all of these when you even see the patient subconsciously, involuntarily. You also look at the age, you look at the life expectancy, you know the untreated IOP, you need the risk factors and so on. But the rate of progression is something which you all don't look at. So I'll come to that in the next few slides. These factors have to be considered, and also keep in mind the corneal thickness. I think somebody did mention about in the morning about corneal thickness. If you have 600 plus corneas and you have thick corneas, you can be less aggressive in treatment than somebody who has a 490 or a 500 cornea and so on, 500 thick cornea. So setting target pressure depends. It's a complex. We need a lot of inputs like this to decide what is the target pressure. So despite all of this, as I already said, you have the glaucoma damage, the rate of progression, the expectancy, the risk factors, the symptomatic life vision loss. You should also keep in mind the status of the other eye. Most of us don't remember that. So keep the status of the other eye, one-eyed and monocular and so on. You should also keep the patient's preference in mind. Most of us don't consider the patient as an entity in your treatment. You decide, you are God. You decide this patient, right eye decides, you do the treatment. You have to discuss with the attender, you have to discuss with the patient. The patient may not like to apply drops. The patient may not be able to apply the drops. The patient may not like laser treatment. The patient may want surgery. The patient may not be available for follow-up. So keep the patient preference in mind when you're managing glaucoma patients. The patient, you are not the ultimate treating authority. You are only a guide in the management. You offer treatment options to the patient. The patient can decide to take it or not, and be friendly and discuss this several times before you start treating everybody with what you think is right. Then, what about the initial target IOP range? These are all available in literature. The acceptable target range for a mild glaucoma is between 16 to 21. For a moderate glaucoma, a 30% IOP lowering, 14 to 18. For somebody with severe glaucoma, you would go much lower and a 35% IOP lowering. For suspects also, if you really want to treat, you can keep it in this range and a 20% IOP lowering and so on. And NTGs also, you would lower the intraocular pressure, maybe even up to a third or so. Keep the IOP low. And I'll come to choice of medication a little later. The APGS has a slightly different way of looking at the target IOP range, Asia-Pacific glaucoma guidelines. The glaucoma with a very high risk for progression, 40% IOP reduction or 1 to 2 standard deviations below the mean if achievable safely. Look at the word of if achievable safely. Don't go on doing an aggressive trabeculectomy with a 5-minute mitomycin and hope to get a 50% drop in pressures. So glaucoma with a moderate risk of progression, 30% IOP reduction of the population mean, and a low risk of progression at 20% IOP. For suspects, you just monitor. So keep this range of intraocular pressure in mind, categorize the risk and keep this IOP range in mind. So how do you choose the medicine then? You need to keep all of this again, multiple factors again. The ocular tolerability of the drug, the long-term IOP control. How long will this particular drug? Are you using a beta blocker? You expect it to wear off in a few years' time. And what about the efficacy of the drug? You're going to start off with dorsolaamide as a first-line drug. You should know its IOP lowering efficacy. you should look at how long the patient can be using these drugs. And of course, the cost and whether what you have prescribed, you're giving pilocarpine 4 times a day, will the patient stick to your regimen of adherence and compliance and so on? And of course, the cost is a very important factor in the management. So my most commonly prescribed drugs, or most of us would commonly prescribe these drugs, the first line or first choice drugs. First line drugs are what the guidelines give you, suggest. First choice is what you would prefer to treat in your practice. That's the difference. So first line drugs are usually prostaglandins, single drug, or beta blockers, and of course the others come in the list. So most often it is prostaglandin today. Some of us still continue to use beta blocker in certain situations for various reasons. But we do have the low cost generic branded prostaglandins. So there's no real excuse unless there's some contraindication to using the PGAs remain the first line choice of drug for most of the glaucomas. Then for second line, you want to add drugs. You would consider, if you already started a prostaglandin, you add a beta blocker and vice versa. You also can also add the alpha agonists, the topical CA inhibitors. Now we have the ROCK inhibitors. And of course, don't forget pilocarpine. Pilocarpine is still a useful drug. I still continue to use pilocarpine in many of our patients. We still do have companies which make timolol with pilocarpine combination, which can be used in a BD dosage as well. So the drugs which have been offered to us have evolved over time, and we have lots of drugs now. This is just an old timeline which actually stops at 2014. We've had many more drugs and many more combinations since then. But why I put this up is to show you that after the prostaglandin was introduced, the surgical rates for glaucoma for all of us have dropped. We were all very happy with the efficacy of the prostaglandin. The prostaglandins are wonder drugs. They really reduce the intraocular pressure to the extent we all wanted. Ideally, you should treat with only one drug. You have one disease, you treat only with one drug. The monotherapy with the PGA can provide maybe up to 30, sometimes occasionally 40% IOP lowering. Monotherapy will reduce the risk of adverse events, drug interactions, and good for compliance as well. So one drop once a day is ideal. But of course, we don't live in an ideal world. We need to keep adding drugs. We will have moderate glaucoma, advanced glaucoma. We need lower target pressures and so on. But the PGAs are efficacious. They lack serious systemic side effects. And their compliance is better because it's a once a day dosage. And they work over 24 hours. They can also work over the long term. So these are all the plus points for the PGAs. But you must keep this in mind regarding the peak and trough effect of all the medication which you have available today. And you will know that, for example, the prostaglandins can lower the intraocular pressure between 30 and 35%. The trough is also about the same. Whereas, look at timolol, look at brimonidine, look at brinzolamide, CA inhibitors and so on. Keep this in mind. Suppose you want somebody with a 30% lowering intraocular pressure and you're going to give dorzolamide, and obviously it's not going to work. So you need somebody with a 30% drop in IOP. You probably start off with a prostaglandin. If you have somebody you need a 50% lowering of IOP, you can straight away think of adding one drug, seeing its efficacy, and adding the second drug very shortly after that. So this is how you look at when the target IOP is not reached, you add a second drug. And if it is reached, you continue down verifying endpoints like fields, disc, quality of life, and so on. If the target IOP is not reached with the first drug itself, you can actually switch the monotherapy and consider other options. I usually offer SLT quite early in the management itself. SLT is a very good option when you are not able to tolerate or not reaching target IOP with one drug. You can also, of course, once your target IOP is not reached, but the initial drug is effective, make sure that the drug which you are first giving, the prostaglandin which you are first giving, has to work for that particular patient. We have something called as a non-responder. Suppose you put in a drug, it becomes, let us say, 2 millimeter drop or a 1 millimeter drop of intraocular pressure after a month, which means the drug is not working. Don't persist with the drug. Don't keep adding drug when the first drug was not effective. So make sure the drug is effective, the drug is tolerated, and you are having a lowering intraocular pressure which is expected. Then think of adding the drug. By adding the drug, we can actually, of course, see if you're again reaching what we want as a target pressure. If you're not reaching the target pressure with the second drug, you substitute the second drug and verify the efficacy and tolerability. Each drug you keep evaluating to see. Don't start off with combination therapy generally as a first line kind of drug. You need to evaluate each drug separately to see what is happening. Ideally, you should start off with single drug. So very rarely we do start with combinations. And always keep in mind that basically you are a surgeon, you are an ophthalmologist. So you can consider a laser as an option. You can consider a surgery as an option. Don't keep adding drugs beyond the patient's capacity to buy or apply drops. We have patients applying 6 drops and 4 drops and 5 bottles and so on. Don't make the regimen complex by applying too many medications. Most often, maximal medication generally is not more than 3 drugs, including one in a fixed combination. That is the practicality of life. People have other diseases, they have diabetes, they have cholesterol, they have some other disease for which they're taking medication. You're adding 3 more bottles and 5 more bottles to their life. It doesn't make it simple. So make sure that your maximum medication is generally not more than 2 bottles, and one of them at least is a fixed combination. Now we can actually give 4 drugs in 2 bottles and so on. Fixed combinations actually improve compliance. They reduce the preservative exposure. There's a dosing compromise because, for example, you're giving timolol with prostaglandin. There's a dosing compromise when to apply in the night or in the morning. Does it work best in the morning dosage? Once a day timolol, is it enough and so on? For example, in the US, the FDA has not really approved completely about something like Zalacom, Travacom. They're not really, still not gotten to the full approval because they don't really believe that this combination is better than the prostaglandin itself. And most of them have timolol. So all that you should remember. Suppose timolol cannot be given, you cannot consider these kind of fixed combinations. I think somebody is going to talk about fixed combinations in preservative medication, preservative-free medication. So when to start earlier use of combination therapy? When you have very advanced glaucoma in a one-eyed patient, you're having a 40, 50 intraocular pressure with a near total cup, you don't want to start this trial of I'm going to give one drug and see, I'll wait for 3 months and again wait for 6 months, add the second drug and so on. So straight away hit the target and they directly go on to combination therapy. Here you have to hesitate. In younger patients, higher rates of change and progression and very, very high IOP with very severe field defects. So don't hesitate. There's nothing dogmatic in medicine like never say never and never say always. You can have these exceptions where you can start off combination therapy in glaucoma. So how do you estimate progression? Once you started treating the patient, you need to look at is the patient getting worse or not. Of course, you have the intraocular pressure, you have the structural change in the optic disc and the nerve fiber layer. You need to look at the rate of progression. All of you, I'm sure, have a field machine. You must incorporate the software in which you look at this event and trend analysis. The trend is probably more useful. This is the octopus way of looking at the mean defect and looking at the worsening over time. And this is the Humphreys VFI, which will show you the projected loss over 5 years, what's actually happening to the patient and so on. This will give you a rate of progression. If you have a rapid progressor, you have to step up your treatment. If you have somebody who is relatively stable as compared to a glaucoma population, you can actually sort of relax a little bit and their target pressures can be what you initially wanted it to be. So rate of progression is very, very important in your practice. Make sure you recognize, of course, intraocular pressure, the structural changes in the optic disc, and the visual field. How many of you use progression analysis in your practices now? Oh, that's really heartening to see. Really, very, very useful tool. Make sure that almost, I see only about 50% the hands went up. So make sure that this becomes an, because once you have a perimeter, there's absolutely no reason why you should not use the progression software. Do multiple fields over time. You can probably have, say, you don't really have to do it every 6 months like the guidelines tell. You can even do it once in a year. Have a baseline of the second or the third field. Compare subsequent fields. You must have at least about 3 to 5 fields for you to compare and get the rate of progression. Once you get that, then you really know where your patient is headed. So you look at this very interesting graph from Andersheil, which shows that the common rate of progression in a clinical population with glaucoma is about 0.6 decibels per year. Whereas if you look at the normal visual decay of about 0.07 decibels per year, the glaucoma population is actually worsening 10 times worse as compared to normal population. There is a normal decay even in normal individuals, the decay of the decibel loss per year. This is 10 times worse in glaucoma. If you can get this graph up a little bit and stop the progression, you can look at the number of the age of the patient and how many so-called vision years you can save for the patient by simple thing like altering the intraocular pressure. You stop the patient from getting worse and the visual quality improves. So this is how you look at the vision quality, you look at the thresholds, you look at the age, and you see how you can actually get the field up back to normal. You don't want the patient to become completely normal. You're not God. You're not going to restore retinal ganglion cell function. You're only trying to get back to the normal decay and see if you can get this back to the rate of progression, which is what is happening in the normal population. So to summarize again, IOP management should be stepwise, categorize the risk, set a target IOP range, choose a medication appropriate to the patient and the eye, and monitor for progression. We have the World Glaucoma Wheel around the corner, and these are some of the activities which we have been doing in Chennai for the last about 10 years. We wish to share some of the pictures. I'm sure all of you are at it with various aspects of increasing awareness in our community. Thank you all for listening.
Thank you so much, Murli sir. And as usual, crisp, lucid, and extremely informative. So I would just like a quick comment from our panelists. So, Anindita ma'am, a quick question or a comment on AI, the talk which Prasanna gave, anything that you would like to say?
I would like to add that AI is coming into recent scenario, and it will help especially those patients to diagnose the risk factors who are at the risk of developing glaucoma. I think that AI should be fed in with proper information about these risk factors that cause glaucoma in patients, so that before the patient can develop glaucoma, we are able to diagnose a part of it and help the patient and let the patient know that it can always come into the progress.
Thank you, ma'am. Prasanna, are you working on it, or is it already been worked on?
Yes, ma'am. We are trying to work on that also. It's not something that we have cracked yet, but we are trying to work on that also, before the patient develops.
By the next time you land in Calcutta, I hope you'll be talking on how to diagnose pre-perimetric.
I'll try my best, sir.
Thank you so much.
Arijit, actually, there is a company which is actually looking at fundus pictures, and there's a company which has come out with a commercial model. I just spoke to Dr. Venkatesh in Arvind Hospital. They actually have worked with them, and there's a way of looking at the fundus photograph and screening and really telling you, the AI will tell you, is it suspicious of glaucoma, like how we look at the glaucoma and tell the disc is looking suspicious. The machine actually gives you a very clear objective method, and it has been proven in a pilot study. So we already have an AI model for disc, and we are actually working with AI and OCT right now. So I think I was talking to Prasanna today. So we're actually looking at the use of OCT and AI. It looks very promising, I can tell you that.
So it's been a great learning experience, something that's really new, cutting edge. So coming back to something more basic, Chandan sir, your comments or any question to Murli sir on his talk?
Thank you, Dr. Murli, for giving a practical, pinpointed guideline for medical management. From working in a government hospital for a long period, I should request everybody to keep in mind the cost of the medicine and cost of the treatment, because it's a lifeline treatment. We have seen a lot of patients discontinue treatment due to the cost. He has also mentioned this, but we should keep in mind that depending on the economical, socio-economic status of the patient, the choice of the drug.
I think just a quick comment on that. So yes, I would entirely agree with you that cost is really a big problem. One of the biggest barriers to compliance adherence is the cost. I think you're all aware of the government's initiative called the Jan Aushadhi scheme. I think a few days ago was the Jan Aushadhi Day. It came out in all the newspapers. The government has started generic cologne pharmacy, in which you get generic drugs in these pharmacies, and they're limited in every state, every city. In Chennai, I think we have about 15, 16 of this. We refer out a patient who can't afford to identify cost as an issue. The cost of, for example, travoprost is 40 rupees. Cost of pilocarpine is some 12 or 15 rupees. So with the real low-cost generic drugs are available with the government initiative, and this is available in many of the Jan Aushadhi stores. I'm sure you'll be having some in your neighborhood as well. If cost is a problem as far as usage is concerned, you can consider the true generics available through this chain of pharmacies. The quality remains an issue, the efficacy remains another issue, but again, that's still available.
Thank you, Chandan sir. Thank you, Murli sir, for your comments. So I would like to introduce Dr. George again. So someone who's very dear to me. So Dr. George graduated in medicine from Government Medical College, Kottayam, and he completed his MS in ophthalmology from Arvind Eye Hospital, Madurai. And he joined there, Arvind Eye Hospital, Madurai, as a full-time consultant in 1999, and he currently heads the Department of Glaucoma there. He is actively involved in teaching and training residents, fellows, and practicing ophthalmologists. His area of research interest is in the use of glaucoma drainage devices in refractory glaucoma, something which all of us have come to know by now. He's working, and he's already worked with Aurolab in manufacturing the wing of Arvind Eye Care System in the evolution and widespread use of an affordable aqueous drainage implant, which we have come to know as RD, and is extensively published on its safety and efficacy outcomes. I had asked George sir for a short CV. So this is his short CV because his long CV is going to run into pages. So I would like to invite George sir to talk on something which is his forte. So there are people who have their own fortes. So this is George sir's forte. He's going to talk about these trabs and tubes.
Thank you very much, Arjit, for the kind words. I am also extremely proud of you. So I thought I will just go through a surgical video of glaucoma drainage device implantation. And we have edited it, but tried to keep as much of important steps as possible. So this is a failed trabeculectomy planned for a aqueous drainage implant surgery. It's extremely important. I will also try to discuss some pearls along the way. It's extremely important to get into the quadrant where you have planned to implant the episcleral plate of the aqueous drainage implant. So now here we have planned for a supratemporal quadrant, which is the most preferred choice for an aqueous drainage implantation. So initial dissection, nowadays I find it's extremely useful to initial dissection of the conjunctiva is a little separate from the tenons. First the conjunctiva is incised and then the tenons. And these relaxing incisions on either side of the supratemporal quadrant is extremely useful for exposure. Try to preserve as much of tenons as possible. If you get into the center of this particular quadrant with blunt dissection, you are rest assured that you are going to come out with your adjacent rectus muscles. So this is the superior rectus. As glaucoma surgeons, we have had very, very limited or absolutely no experience identifying and isolating rectus muscles. So if you can get into the center of this quadrant, you get the superior rectus and the lateral rectus, and you use a second muscle hook to create adequate space beneath the rectus muscles. It's again vital to ensure that there is no additions there. Even little minimal additions of tenons or conjunctiva to the sclera will be a definite impediment for the episcleral plate to snugly fit into that quadrant. The same thing is repeated beneath the lateral rectus muscles. So if you are planning to implant an Ahmed glaucoma valve, I would still identify the muscles, but I wouldn't create space beneath the muscles, because it's again very important to have the Ahmed in between the rectus muscles, and you don't want it over a muscle. So this is the state of art. This is the Orolab aqueous drainage implant, the 350 millimeter square episcleral plate, which was made to resemble the Bawel glaucoma implant. And I'm also very happy to convey that Orolab has also finally succeeded in manufacturing the supramid suture, which has really changed the safety profile of your RD implantation. So the supramid goes in. This is multi-filament nylon, and one of the vicryl ties, this is 6-0 vicryl to completely occlude the tube. One of the vicryl ties is placed over the supramid at the part of the tube where there is supramid. So again, ensure that there's complete, see, this is also a telltale sign. You can have those bubbles at your at the part of the cannula. You can also look for air column going in the tube to make sure that it's totally occluded. It has to be a watertight closure. You cannot afford to have leaks. So what we prefer is a 2-1-1-1 knot, an extra one. The fourth knot is just to ensure that the vicryl is still snug, because you're going to have a lot of manipulation now placing the episcleral plate beneath the muscles. Even, see, this is a very crucial part, a very important pearl in glaucoma drainage devices for a non-valved implant, complete watertight temporary closure of the tube. So now the superior wing of the RD goes beneath the superior rectus muscle. See, even though the plate looks daunting, that it's a huge plate, it is contoured and it's very flexible, contoured to the shape of the globe. It snugly fits in, and once you see the tube bending there, that is again a sign that the tube has hit the superior rectus muscle, and that is where we stop. And now the second wing, that is the lateral wing of the RD, is inserted underneath the lateral rectus muscle. Again, if you have good assistance to hold, every time we handle tissue, we should ensure that we are handling the tenons rather than the conjunctiva. So the second wing And this design, which Professor George Bardwell has bequeathed to the Glaucoma Society, to the glaucoma community, it's really beautiful that it just shaped to the contour of the globe, and it snugly fits there. It's a much more low profile than your Ahmed glaucoma valve. Again, one important pearl is once you have positioned this plate beneath the rectus muscles, it nicely slides to and fro, that is on sideways, and it can even go posteriorly, but it doesn't come anteriorly. So anterior movement of the episcleral plate in non-valved implant is taken out of the equation, unlike in an Ahmed glaucoma valve where you can have anterior positioning of the AGB plate. This is another step which we found very, very useful. Placing the 7/0 silk which we use for corneal traction, the same 7/0 silk can be used in the posterior tenons so that the exposure is good. You don't depend on your assistant to hold the conjunctiva while you fix the plate to the sclera. So on either, the posterior tenons corresponding to the anterior positioning holes on either side, you could use these traction sutures. We fixed the plate of the RD or the Ahmed with 9/0 nylon non-absorbable suture. Again, very important, we are playing with very thin areas of the sclera posteriorly. We need to see the suture and the needle while we pass it through the sclera. Because if it becomes deep, you could inadvertently damage the choroid and the retina. Again, the suture knots are rotated into the positioning holes to make sure that to further minimize the risk. So this is what I was saying. You need to see the suture, just see the suture through the sclera. Again, the second knot is also buried into the positioning hole. So this is another important pearl. The anterior edge of the episcleral plate has to be 9 to 10 millimeter posterior to the limbus. Most of the complications of glaucoma drainage devices like plate exposure, tube exposures are mostly because the plate is much more anteriorly than desired. You have to have it 9 to millimeter. So that was just a tube stabilizing suture. Once we stabilize the suture with the tube with a box suture, the tube nicely obeys the contour of the globe. So the second vicryl goes in just anterior to the supramid. Again, all these, it's a 2-1-1 knot, and see the kink at the tube. That is another telltale sign that the tube is completely occluded. So all these have been from trial and error and from past experience. We had a supramid exposing inadvertently at 4 weeks post-op, and we know that at that time if we pull it out, if both the vicryl sutures are above the supramid, the risk of hypotony is very high. And this is a critical part of implanting of your aqueous drainage implant. As I was mentioning earlier, we tried to bury the tube in the patient's own sclera to minimize the risk of tube exposures. We have found that burying the tube in the patient's own sclera, that is with a track of adequate length and depth, is a lot of insurance against tube exposures. Most of the tube exposures in GDDs we have found are at the first 4 millimeters from the limbus. Tubes rarely expose beyond that. So this is a 23 gauge, and there is some mental calculation involved. I will mention that, so this is initial movement of the 23 gauge needle is parallel to the sclera. And at a particular prejudged point, we don't advance any further. It's a direct dip into the anterior chamber, just like how you would make a keratome entry into the anterior chamber for your SICS incision. There are ways in which you could maximize the distance of the tube from the endothelium and minimize the distance from the iris. You need to have a tube which is as close to the iris as possible and as far away from endothelium for maximum long-term survival of the cornea. And with some measurements which we have been trying to, with lot of trial and error, with lot of past experiences, we have found that trimming the tube 2 millimeter anterior to the limbus in the primary position and then routing it, if it's the right eye or the left eye, you route it medially and you get an adequate 2 millimeter length of tube in the anterior chamber. Because at the straight position, it lies over the cornea. If you insert it like this, you get about 3.54. And over the years, we have also found a lot of advantages with this technique. Both in the right eye and the left eye, I was saying it's medial. So literature says any tubes that enter the anterior chamber close to the 12 o'clock position, there's the minimal contact of eyelid at that particular point, at the 12 o'clock, and this again minimizes the risk of tube exposure. We have also found that in case we require a tube repositioning for a tube retraction, for a tube corneal touch, tube retraction, we have found that tube extenders have been totally taken out of the equation in our hands because we have adequate length of the tube still available to either reposition it straight or reposition it laterally. And the Supramate suture has done wonders to the safety. I'm sure a lot of you are going to use this, and you will find that this is going to be as safe as an Ahmed glaucoma valve implantation. The reason why everybody prefers a valved implant rather than a non-valved implant is because of the risk of hypotony. Many of our Supramates just remain there. Once the ligature suture dissolves, there is no sudden decompression. Earlier, we were always used to be worried at the 6 weeks post-op, 5 to 6 weeks, you could have a sudden decompression. There's a Professor Keith Barton from Moorfields has an animation which says the eyeball just shrinks at that time. That is a risk of suprachoroidal hemorrhage, and that is totally taken out of the equation. And for any other glaucoma surgery, one thing I want to stress here is there is so much of variation in doing a trabeculectomy in our institute. Every surgeon has different ways to do a trabeculectomy, but each step in a glaucoma drainage device implantation in our institute, each step is standardized. This is just one slide, just to show that can I have a pointer? So this is, we have found that this is 2.8 and this is 3, and this area is where we play around depending on the pre-existing anterior chamber depth to maximize the distance from the endothelium. Very important that the distance between the iris and the tube is very minimum, and you maximize the distance from the cornea to the tube. Thank you very much once again.
Thank you so much, George sir. George sir has gone pan-India, either with presentation or with live surgeries on this. So since I think 2014, sir has been on this mission. But what is amazing is every time sir gives a talk, there is something new. In this case, the Supramate and newer techniques, just newer modifications. So it's really amazing. Thank you so much, sir. George sir will be moving off, I think. So any quick question or comments? Shurujit, anything you would like to say?
I would like to know from George sir is what are the choices of quadrants? I mean, the supratemporal is the first one. Would you go for the nasal as the second, or the inferotemporal as the second choice? And next is
Surajit, I'll take that question first, otherwise I'll forget the first question. The traditional teaching has been that the supratemporal and infronasal don't have the oblique muscle tendon complexes. The supratemporal and the infronasal don't have the tendon complexes, and that is why you first prefer the supranasal and then the infronasal to minimize the risk of diplopia. But over the years, we have published that we have found that our infronasal quadrant implantation with adults are comparable to the supratemporal implantation, but in children, we have found more exposures, more failures due to raised pressures in the infronasal implantation. So we have now moved, first is the supratemporal, for some reason we don't have the supratemporal quadrant, we go supranasally. Now the second preferred quadrant is supranasal. We have not been seeing much of diplopia. Third preferred is the infronasal, and hardly ever, it might be very surprising for you, infrotemporal is hardly ever done, mainly because you have the inferior oblique muscle complex there. Again, the cosmesis is a major issue with infrotemporal.
So second one is pars plana versus anterior chamber or behind the iris implantation. Pars plana tube insertion versus, when do you go for a pars plana insertion? Like in post-PKP cases, it's a much safer thing. For example, I want to listen some more about this.
Surajit, even now, I try to maximize, I try to have all my tubes in the anterior chamber. I try to maximize the distance from the corneal endothelium. The indication for sulcus placement is many of these PKPs will have a very anterior PAS to the cornea. So that's very easy to place it in the sulcus. You post uveitis, any condition where you have anterior pass, neovascular glaucoma, some of these congenital cataract surgeries, uveitic, that is where the sulcus placement comes in. Pars plana is reserved only when there is absolutely no space in the anterior chamber or the sulcus. And one of the most important prerequisites for a pars plana tube insertion is to have a complete vitrectomy. You need access to a very good vitreoretinal surgeon who will shave off the entire vitreous base. Otherwise, some amount of vitreous just comes in and blocks the tube. And indications for pars plana tube insertion in our hands mostly are associated with some concomitant vitreoretinal surgery, mainly silicone oil removal. Some of these children have lot of vitreous compromising the anterior chamber, and very rarely an iridocorneal an IC syndrome in a phakic eye where there is absolutely no other go, absolutely flat AC. Our vitreoretinal surgeon does a lens sparing vitrectomy and then we insert the pars plana tube.
The last one is long scleral tunnel for a tube insertion versus a scleral patch graft to cover the tube. Which one do you prefer?
Initially, it was very difficult to convince people not to use the patch graft, but truly, believe me, nowadays I'm worried if I have to keep a patch graft. I'm telling you, the conjunctival transition at the limbus between the conjunctiva and the cornea is as natural as possible without a patch graft, it's provided you have an adequate scleral tract. It is as natural as possible. The tear film is as normal as possible. Tube exposures, believe me, are near zero with this patchless. But it might sound a little dramatic for many glaucoma surgeons who routinely use the patch graft. But usual tube exposures, as I was mentioning, was within the 4 millimeter from the limbus.
It's just one thing I wanted to ask you. Is this that for pediatric cases, when you're implanting the ADIs, what is the lowest, earliest you have implanted? And what is the success of the ADI model for the pediatric age group in your hands?
Alakesh, ours is a referral center and we have a failed angle surgery even as early as 6 months of age. And I have been implanting this Orolab aqueous drainage implant even right from 6 months is probably the earliest I have implanted. But taking adequate precautions to make sure that each step is picture perfect, probably instead of 4 millimeter, you could even have 4.55 millimeter. And now with supraumbilical in place, I'm all the more confident of implanting. And just one point, the Ahmed naturally has much more of bleb encapsulation and tenon cyst in the pediatric age group compared to the adult group.
So this is the 250, the size. They're asking the size of them in the pediatric age group.
No, size is the same 350 millimeter. We have the 250 millimeter square. We haven't yet published the results because I was very comfortable with the 350. I've spoken to many of the glaucoma surgeons who have been guiding us from abroad, especially Professor Paul Pomberg, and they have been saying that 350 is the size to go. But I think now there is a school of thought which is slowly shifting to the 250 Ahmed clear path.
I was just going to ask you the same thing. Is there a real difference between 350 and 250, and why not you switch to the 250? It's a lot easier to do in terms of implantation and so on. Do we really need to get behind the muzzle and so on? And
I agree,
we don't
Murli.
have the...
Yeah, I agree, Murli, but once I have the wing behind the rectus muscles, I know that it is not going to come forward anteriorly. And the 250, somehow I was not very happy with the design. Have you seen the Orolab 250 design? The anteroposterior diameter is also much larger, and I'm not a big fan of it. But I think but there is a lot of literature coming in saying that 250 Ahmed clear path works as well as the 350 Bawelt.
Yeah, I just did my first Ahmed clear path last week, and I found it amazingly easy to do given the difficulty we have with the Ahmed valve itself. The ACP, the Ahmed clear path, It's so much easier to implant. It's got those rabbit ear like forward projections. So much easier to suture the flat contour. Your implant is already flat contoured. So I'm just wondering why not we innovate into a similar kind of a easier to implant device, whether it will work equally well. The ACP seems to be giving 250, seems to be giving quite good results with the 250 itself.
I am retiring, Murli, because this patent issues are a major thing.
10 years of RD is enough.
I'm sure that the patent for Ahmed Clearpath is going to be there for another 4-5 years. So the patent issue was not there with the Barwell, and Professor George Barwell was very much willing to give us this design, and then knowing very well that it's going to benefit much more of the community.
I'm sure there are a lot of questions for George sir, but we'll end with one quick question from Shushanda ma'am.
Dr. George, I have been doing quite a lot of ADI, and Dr. Ganesh is my online mentor, and I keep posting issues to him. One thing I would like to know, when do you remove the supramed, in what indications and how?
Ma'am, as long as the intraocular pressure is normal and the supramed is very well buried in the conjunctiva, there are some signs which say that the tube has started functioning. This anterior edge of the episcleral plate will be very prominent over the conjunctiva if there is no flow. The conjunctiva will be flat over the plate, the anterior edge will be very prominent. You can just appreciate that just before the time the Weichel suture dissolves and after and just before that. Till about 4 weeks, that plate is going to be very prominent, that ridge. Once the Weichel suture dissolves, there's going to be a good bleb over the plate. If you find that the pressures are normal, we have children almost 2 years, supramed in place, pressures very well controlled. It's always better to have that. But having said that, suppose the supramed exposes, that is a definite indication to pull it out. After 6 weeks, probably after 7 weeks post-operatively, pressures are very high on medicines, you pull out the supramed.
How you do it? Transconjunctival?
Yeah, you saw that the supramed was buried just it's never at the slit lamp. In the OT, make a small nick. You reach the supramed, it easily comes out. There's not much of additions. It's pseudo monofilament nylon.
Thank you.
Thank you so much. Thank you so much, George sir.
Thank you, Arjit. Thank you once again.
We learnt a lot. We really learnt a lot. So we'll move on to our next speaker, Dr. Debashish Chakraborty. Debashish is a senior consultant attached to Center for Sight in Kolkata. So Debashish has this interesting talk about newer medications in glaucoma. So over to you, Debashish sir. For the others, if you want to enjoy a cup of coffee along with the talk, you're more than welcome to do so. We won't be having the break at the end of this session. So we'll just keep on and move ahead. So if you want a cup of coffee, you can more than welcome to have it.
Good morning, everybody. Thanks to OSWB for giving me this opportunity. So the scientists are always in the lookout of newer drugs in glaucoma management, and we always hope that there is something new for our patients to control their intraocular pressure. So the history of anti-glaucoma medication started as far back as 1876, but you can see that from 1996, when the PG analogs were introduced, and 1995, the topical carbonic anhydrase inhibitors were introduced, there was a gap of 2 decades since any new glaucoma medication came up. So then we had a revolution of sorts when the Rho kinase inhibitors were introduced. So in November 2017, 3 new drugs were approved by the US FDA. These were the Vyzulta, which is latanoprostene bunode, which is not yet available in India. Then the Ropressa, that is Netarsudil, which is now available in India by many Indian companies. And then we have Roclatan, which is the fixed dose combination of Netarsudil and latanoprost. That is not yet available in India, but I was just talking to the Sun Pharma representative. Probably by the end of this year, they will be able to launch this product. So as you can see, apart from the medicines which are already in use, the new drugs coming up like the Ripasudil and the Netarsudil and the latanoprostene bunode, there are a number of other drugs which have ongoing clinical trials, and some other medications which have some preclinical trials. So we will not discuss the mechanism of action of the anti-glaucoma medications. As we all know, it's either by the reduction of the aqueous humor or by the outflow of the aqueous humor by the trabecular pathway or by the uveoscleral pathway. So we will first touch upon the Rho kinase inhibitors. So as we know, the Rho kinase inhibitors, the main mechanism of action is that they have a novel mechanism of action. One is that they can act on the trabecular meshwork and the Schlemm's canal cells, and this sort of modifies the cytoskeleton and increases the aqueous humor outflow, thereby resulting the lowering intraocular pressure. It can also have some additive effect on the optic nerve and provide some sort of neuroprotection. And the third thing is that it can also act on the tenon fibroblast, and this can reduce the scarring of the bleb. So once we have done a glaucoma filtration surgery and the IOP starts going up after a few years, maybe the first drug we can introduce is a Rho kinase inhibitor. So we have two such molecules available in India already, the ripasudil. So it was the first ROCK inhibitor that got approval, and it's used in a concentration of 0.4%. It is to be used twice daily. The main adverse effects that we should be aware of, and we should always make our patients aware, is that there is a risk of conjunctival hyperemia, but usually it comes down after use of a few weeks. Some patients do get allergic conjunctivitis and blepharitis. Then netasudil also has a similar mechanism of action, but in addition, it might reduce aqueous production. It can also decrease the episcleral venous pressure, because it is not only a ROCK inhibitor, but it also is a norepinephrine transport inhibitor. And the dosage is that it has to be used in a concentration of 0.02%, and while you are using ripasudil twice daily, it has to be applied once daily, preferably at bedtime. And the bottles must be refrigerated like the prostaglandin analogs. However, once used, the open bottle can be used at room temperature for 6 weeks. So what are the common side effects? Hyperemia, subconjunctival hemorrhages, microhemorrhages, typically perilimbal, that also we should know. Then a peculiar side effect is the corneal verticillata. Some patients do get erythema of the eyelids, blurred vision, and increased lacrimation. Now, this is something that has been reported in Western literature, and also some of us have experienced this. There's a peculiar honeycomb or reticular corneal edema. Both netasudil and ripasudil have shown that some patients do get this sort of edema. But however, these can develop 1 week after initiating the drop, but usually they resolve after cessation of the treatment. So these are all the studies. We'll not go into the details. What are the usual clinical scenarios where the ROCK inhibitors are effective? I think when the patient is on maximal medical therapy and we are contemplating surgery, then this can be a useful addition. Then patients with normal tension glaucoma, because it's very difficult to reduce the pressures in a normal tension glaucoma. So these might be helpful. Then initial drug while restarting anti-glaucoma medications in post-trabeculectomy patients. Patients who have combined glaucoma and some corneal endothelial disease, or patients who have some combined glaucoma and diabetic retinopathy or some other retinopathy. So then latanoprostene bunode, the Vyzulta was a prototype drug that was approved by FDA. It is a once daily administration, and the basic mechanism of action is that it has two active metabolites. One is the latanoprost, and there is a nitric oxide. Whereas latanoprost enhances the uveoscleral outflow, the nitric oxide causes vasodilatation, smooth muscle relaxation, and increases the trabecular outflow. So again, a large number of studies are available. The side effects are similar to the PG analogs. Then this is a combination of netasudil and latanoprost. This rocklatan was a prototype drug, and we do not have it in India as well. Apart from these new drops, the other significant advancement that has been happening is the way the medications are delivered, because we know that medication non-compliance is a significant challenge for glaucoma physicians and glaucoma patients. So a number of new sustained drug delivery systems are now being investigated, which can reduce the number of instillations. So we can classify them into various categories, like we have the surface implants like the bimatoprost ring, the gel forming drops like the solid drop, intrascleral implants like the ophthalmic micropump, intracameral implants like the bimatoprost sustained release, the injectable drugs the subconjunctival implants, and the punctal plugs. So all of these are being investigated, and I'm sure that in future we'll have it for our patients as well. So the gel forming drops, I'll just touch upon this because these are not really available. So the gel forming drops, basically what happens is that when the drop comes into contact with the ocular surface, heat causes it to become a viscous gel, so that has a longer duration of action. Then there is something called a topical ophthalmic drug delivery device. Again, you can put multiple medications in this, and this will release the drug slowly over a period of time. Then we have this called bimatoprost ocular ring called the Helios. That was, I think, being investigated by Allergan, but probably they have discontinued its use. So it's a sort of ring that you have to that the patient has to wear, and it will release the drug slowly. Then the punctal plugs are an important modality. So drug-eluting punctal plugs, they're more comfortable than the surface implants. Okay, I'll just go through the others. Then we have the subconjunctival implants, which can release drugs like latanoprost. And then we have the injectables, where we can inject the drug directly. So we can have the intracameral implants. So this new drug is already being investigated in many centers. So it's a bimatoprost implant called the Durista. It's a sustained release biodegradable implant that uses the Novadu drug delivery system for intracameral use. Then we have this travoprost releasing device, which is called the iDose, that is being developed by Glaukos. And then we have the intrascleral implants. We have the novel technology of the nanotechnology. So where the nanoparticles, which have a size of between 1 to 100 nanometer in size, with medications piggybacked on these nanoparticles, they can have a novel mechanism of action. Then we have this drug, which is called the trabodenosone, which is an adenosine receptor agonist. And then we have totally novel technologies, the small interference RNA and the gene therapy. They're also being investigated, and the stem cell therapy. So to conclude, the past few decades have opened up multiple new horizons in glaucoma treatment. And with these new medicines that are coming up and with these new drug delivery systems, we can always be optimistic, and we can say that hope is being able to see that there is light despite all the darkness. Thank you very much.
Thank you so much, Debashis, for this wonderful talk. I don't think 7 minutes will do justice to a huge topic like this, but thank you for covering it so beautifully. Due to lack of time, we are skipping the questions. So I would like to invite the next speaker, Dr. Shurojit, who's a senior glaucoma consultant attached to Netralayam Super Speciality Eye Care Center in Kolkata. Over to you, Shurojit. He'll be talking on something which is very interesting, which is about preservative-free glaucoma medications.
Good afternoon, everyone. I would like to thank OSWB for giving me this opportunity to present here today. I'll discuss on this topic, preservative-free medications in glaucoma management. I don't have any financial interest. As we all know, the glaucoma is a multifactorial chronic progressive optic neuropathy which is characterized by the optic nerve damage with characteristic visual field defects, which ultimately leads to the loss of visual function. It is the commonest cause of irreversible blindness with global prevalence approximately 3.54%. In India, at least 12 million people are affected with glaucoma and nearly 1.2 million people are blind from this disease. A sight-threatening condition like glaucoma requires long-term, usually lifelong treatment. The goal of glaucoma treatment is to maintain patient visual function and to maintain patient's quality of life. There are various factors that might affect patient's quality of life, which may be increased side effects from the medications, increased therapy cost, and also the inconvenience of the treatment. Ocular surface disease is very commonly seen in glaucoma patients. It was seen that approximately 60% of medically treated glaucoma patients report ocular surface disease symptoms, which has major impact in quality of life and which influences the compliance and adherence to the treatment. Glaucoma patients are at high risk of developing OSD disease because of glaucoma is a chronic condition which requires lifelong treatment. Both glaucoma and OSD incidence increases with the age, and more importantly, the use of preservative-containing pressure-lowering eye drops. Coming to the preservatives are used in eye drops to prevent microbial growth in multidose vials. It also has role in penetration of drug through the cornea, which increases the bioavailability of the drug. Most commonly used preservative is the benzalkonium chloride. It's almost 60 to 70% eye drops contain this molecule. It is a quaternary ammonium molecule which acts through detergent-like action which dissolves the cell walls and cell membrane. It was soon noticed that the benzalkonium chloride has the deleterious effect on the ocular surface. So after that, the relatively softer preservatives like polyquaternary stabilized oxychlor compound, sodium perborate, other molecules were developed, which once comes in contact with the ocular surface, it turns out in a non-toxic substances. So what are the disadvantages of preservatives in glaucoma medication? It can accumulate in the ocular tissues and can affect the cornea, conjunctiva and the tear film. In cornea, it can cause a corneal epithelial damage which alters the corneal permeability, slows down the healing process, and in conjunctiva, it causes the goblet cell destruction, thus altering the tear film composition. It decreases the cell number and viability, and it increases the conjunctival inflammatory cells. It has effect on tear film also. It interferes with the integrity of the superficial lipid layer of the tear film, which reduces the tear film breakup time, which ultimately leads to the tear film instability and leads to dry eye. The common symptoms of OSD are grittiness, foreign body sensation, burning, itchiness, tinging, sore and tired eyes, fluctuation of vision, and light sensitivity. The signs are superficial punctate erosion, conjunctival hyperemia, reduced tear volume, shortened tear film breakup time, tear film debris, low Shermer's test score, viscous precorneal tear film, and thickened lid margins. One more important point is that the preservatives may cause inflammatory changes in the conjunctiva, which causes the increased number of activity of lymphocyte, monocyte, fibroblast, and conjunctival goblet cell, which ultimately can cause the failure of the glaucoma filtration surgeries. So what could be the solution? There should be strategies to reduce the exposure to preservatives, which might be done by reducing the number of drugs, using more fixed dose combinations, using preserved formulation not containing benzalkonium chloride, and or the possibility of use the preservative-free formulations. The European Glaucoma Society now recommends preservative-free products for use by patients who have severe dry eye or ocular surface diseases. But does it help in reducing OSD? In a questionnaire-based study, almost on 10,000 patients, it was seen that patients on preservative-free eye drops had less pain, discomfort during installation, foreign body sensation, stinging, or burning compared to the patients on eye drops with preservatives. And another study also, it was seen when the patients were using preservative added or preservative-free latanoprost, it was seen that there was 35% reduction in incidence of conjunctival hyperemia. In the same study, it was documented that preservative-free therapy caused a significant reduction in symptom score on installation of the eye drops. And another study on more than 2,000 glaucoma patients who are already using some glaucoma medications with benzalkonium chloride, it was seen almost 61% patients suffered from local intolerance of the preservative benzalkonium chloride contained in previously used glaucoma medication. Once they were switched to the preservative-free dorzolamide timolol combination, it was seen almost 84% patients improved tolerability and their previous glaucoma therapy. So does the preservative-free and preserved glaucoma medication have the same efficacy? There are various studies who have proved that there is no difference in their efficacy. It was checked in the fixed dose combination of brimonidine timolol combination, showed similar IOP drop. It was checked in bimatoprost also. It has shown similar efficacy, and the fixed dose combination of dorzolamide timolol combination also. So we can say that there is no loss of efficacy and there may be improved tolerability. These are the commonly used preservative-free bottles available in India. There are two types of bottle. First one is the ophthalmic squeeze dispenser, which is the FDA approved. It has a mechanical tip seal which prevents the backflow of the eye drop, and it has a sterile filter which helps filtering the incoming air. And more commonly used bottles is the Nemera Novelia bottle, which has a peer flow technology, allows the air to diffuse but not the micros, and it has silver ion in the cap to protect the remaining drop. So we can conclude that the preservative-free eye drop should be considered in patients with moderate to severe ocular surface disease. The tolerability of the glaucoma medications are better with preservative-free eye drops. There is no difference in efficacy of preserved and preservative-free eye drops. Thank you.
Thank you so much, Shuruji. That was an extremely informative talk. Again, I'm sure there are a lot of questions, but we are running a bit late. So we'll just proceed to the next session directly. And I would like to hand over the floor to Shurajit as well as Shuchanda ma'am. Ma'am, please, the next session.
Thank you, Arijita. We'll proceed to our next session. I would like to request our panelists if they could come forward. Dr. Sumit Chaudhary sir, Dr. Nilay Bojumdar sir, and Dr. Rituparna ma'am. And I'd like to call upon stage the first speaker of this session, Dr. Shumona Chatterjee. She is the senior cornea consultant in Netralam Super Specialty Eye Hospital.
Thank you, Shurajit. And you have made my work simpler by giving the talk on non-preservative anti-glaucoma medications. So a very good afternoon to all of you. I want to thank Dr. Manish Singh and West WB for giving me the opportunity to talk on this esteemed podium. So my topic today is management of dry eyes in glaucoma patients. So first, let us see the common scenarios we face in OPD. The first is quite straightforward. If a dry eye patient develops glaucoma, so the onus is more on the cornea person. The glaucoma approach from the beginning only will be a preservative-free anti-glaucoma medications and the decision regarding the early surgery. But the most important problem is when a glaucoma patient develops dry eye. And ocular surface inflammation may manifest as early as 3 months after initiation of the AGM, and it definitely worsens with a greater number of medications. So the mechanism of action is actually a variety of hypersensitivity. It may be a type 1 hypersensitivity, it may be a type 4 hypersensitivity, it may be a non-specific irritative or toxic conjunctivitis, which is very common. It is an immunological or toxic irritation to factors such as pH, tonicity, preservatives, and the drugs themselves. And the most dreaded one, the drug-induced cicatrizing conjunctivitis. So what we see commonly in OPDs is superficial punctate keratitis, tear film instability, allergy, vortex keratopathy, and reticular edema for particular drugs, dry eyes, and pseudopemphigoid. The prostaglandins are known for the conjunctival hyperemia, timolol is known for the punctate keratitis, brimonidine is a culprit for the allergic conjunctivitis, as well as dorzolamide and brinzolamide, just less with brinzolamide, but punctate keratopathy do happen, and netersudil has typical complications. So the pathophysiology is actually immunological and inflammatory both. We see increased expression of the inflammatory markers HLA-DR and interleukin-6, which may lead to subconjunctival fibrosis, limbal stem cell deficiency, fornicial shortening, disrupted tear lipid layer, decreased mucin due to damaged goblet cells, and thinning of the precorneal tear film. So the most common, the first we see are the toxic follicles. It can be caused by the drug itself or the preservatives. Beta blockers and topical brimonidine are well known for causing this complication, and they can present to us with hyperemia, chemosis, lid edema, etc. The second most common scenarios that we see is this, the superficial punctate keratitis. So what we do for these cases, the drug of choice is preservative-free 1% carboxymethyl cellulose in frequent doses. So there are two guiding principles of management. First one, minimize the effect of glaucoma therapy on the ocular surface. So withdrawal of the AGM for the time being. Second is to recognize and treat the ocular surface disease as early as possible. If we switch to the preservative-free glaucoma medication, we may decrease the need for the ocular lubrication. But the topical non-preserved AGM should be avoided in the acute phase. The initial phase should be withdrawal of the medication, because as soon as the topical medication are withdrawn, eyes becomes rapidly asymptomatic. So IOP managed temporarily by using the oral CAIs when these are tolerated. Once resolution is complete, then we can introduce the preservative-free AGM one at a time. But what happens in those cases which are still symptomatic and cannot tolerate oral carbonic anhydrase inhibitors? then stepwise withdrawal of existing medication and substitution of new preserved AGM. Patient reacting to non-preservative AGM are very uncommon, but they still occur. So some may have granulomatous inflammation also that resolves with the addition of topical steroids. Here we come to the role of topical cyclosporin. In the long-term effect, topical cyclosporin do show improvement in Sharma scores, ocular surface staining, ocular surface disease index, corneal sensation, and increased central corneal subbasal nerve density. So we have to use this drug in our dry eye armamentarium. So the papers say that long-term use of anti-glaucoma medication cause permanent changes in the meibomian glands with long-term use. So for the other dry eye case, we do consider punctal occlusion, but in patients with active MGD, it increases the retention of toxic secretion. It can exacerbate the evaporative dry eye disease, and it can also increase the potency of preservatives and likely represents a poor option for management in the glaucoma patients. So when glaucoma patients develop dry eye, we do not consider punctal occlusion. Coming to the most dreaded variety of drug-induced conjunctival cicatrization, the beta blockers, alpha agonists, myotics, all of them are typical culprits for this. And the fibrotic changes are typically seen in inferior fornix and medial canthi, including lacrimal punctal edema, ulceration, occlusion. And this indicates damage to the areas of the ocular surface that come in maximal contact with the medication as it is cleared from the eye. I will show you some pictures. The LV Prasad people have done a research on these manifestations. See how the medial canthal fibrosis is there, punctal edema, the skin changes, the keratinizations, the thickened lid margin, and the shortening of the fornices. So once cicatrization develops, it is rarely reversible. Managing the IOP is probably the most difficult part in this drug-induced cicatrizing conjunctivitis. So if the patient cannot tolerate the oral anti-glaucoma medication, then the surgery is advisable. Conjunctival cicatrization or inflammation renders trabeculectomy at high risk of failure. So use of antifibrotic and short course of topical steroids before surgery from our part. In severe conjunctival fibrosis, in whom filtration surgery failure rates are high, you choose for the glaucoma drainage device or tube shunts. But when conjunctival incision surgery also is not possible due to severe fibrotic changes, endocyclophotocoagulation would be a better option compared to a transscleral one, as the transscleral variety causes significant inflammation. So the mainstay of treatment being drug withdrawal, lubrication with or without topical steroid, as the case may be. We do use scleral contact lenses for mild to moderate keratopathy, and if the surface is relatively wet and patient can tolerate systemic immunosuppression and patient is not improving with maximum possible dry eye medications and not tolerating scleral contact lens, then we can also do the allogenic limbal stem cell transplant for them. And if the eye is completely dry, with disorganized anterior segments, we do have keratoprosthesis implantation. So the future is not very bleak. We have hope, but definitely it's a difficult situation. Thank you so much for your patient hearing.
Thank you, Shumona, for your very informative and on-time presentation. For lack of time, we will keep the questions for the end of the session. I would now request Dr. Shreyoshi Ghosh, PGT RIO, to present her case on AGV in eye syndrome. Shreyoshi, please.
Good afternoon, everyone. I'm Dr. Shreyoshi Ghosh, and today I'll be presenting a case of iridocorneal endothelial syndrome. So we had a patient, 45-year-old female, who presented with sudden onset pain in the right eye for the past 2 weeks. She had complained of dimness of vision in the right eye for 1 year, but there was no such complaint in the left eye. She had no history of trauma or any ocular surgery in any of the eyes. However, she gave us a treatment history of the usage of these IOP-lowering drugs in the right eye only for the past 1 year. So she was on maximal medical therapy. Her systemic examination revealed nothing of significance. Everything was within normal limit. Coming to ocular examination, right eye, her visual acuity was 6 by 60, left eye was 6 by 6. Pupil, as is shown in the picture, showed polychoria in the right eye. Lid, adnexa, conjunctiva were within normal limits. However, the cornea was edematous, left eye was clear. Iris in the right eye showed atrophy with multiple holes. Lens was clear. In fundus, we see the disc was VCDR showing 0.7. IOP was 28 on presentation in the right eye. Left eye was 16. Gonioscopy in the right eye revealed pass in all the quadrants. Left eye, there was open angle. CCT in the right eye was 600 microns, while left eye was 552. Then coming to investigations, in the right eye, OCT RNFL revealed thinning of the inferior NRR, and perimetry also showed advanced field effects in the right eye. Then we went for a specular microscopy of the right eye, where we see a reduced endothelial cell count, high pleomorphism and polymegathism, and loss of the typical hexagonal shape of the cells. Thus, we made a diagnosis of ICE syndrome. Then we moving on to the management. We admitted the patient, and after completing the baseline investigations of sugar, urea, creatinine, serology, and cardiofitness, we decided to go for the MF glaucoma valve surgery, and preoperatively we gave her intravenous mannitol. I shall show you a small video of the surgery which was performed. So after creation of the scleral pocket with proper conjunctival peritomy and cautery in the superotemporal quadrant, the AGV was inserted into the quadrant, and it had to be secured to the sclera with the help of 290 MFN sutures. The footplate of the implant is placed approximately 8 to 10 millimeters away from the limbus. And as we know, this step is a very crucial one to prevent any migration of the valve. Next, we have to trim the tube of the valve, that is approximately kept 2 millimeters into the anterior chamber. Length of the tube is measured and is trimmed. Then before we enter the tube into the AC, the anterior chamber is filled with viscoelastic substance and is formed. Next, we shall proceed on to the step of the creation of the corneoscleral tunnel, and entry is made using a wide bore needle. So a path is being made for the tube, and the tube is being inserted into the anterior chamber. Next, we have to secure the tube to the sclera. That is done using 90 MFN sutures. A mattress suture is done. And finally, we close the we place the scleral patch graft over the tube, and that is secured with 410 MFN sutures on 4 borders to prevent any tube erosion in the future. And finally, the conjunctiva has to be closed over the scleral patch graft, and that is done using 80 vicryl sutures. So after we have done this, we follow up the patient post-operatively. In day 1, there is no change in visual acuity. However, her IOP lowered to 22. She was kept on topical and oral antibiotics, cycloplegics, and oral steroids. She was not on any anti-glaucoma medication. And further, in post-op day 7, her IOP lowered to 18, and she has been under our follow-up for the past 2 weeks. Thank you. This is my case.
Thank you, Shreyoshi, for a good presentation and a good video, where it was very clear how the surgery was done. And I would now request Dr. Shumit Chaudhary, a well-known glaucoma practitioner, senior glaucoma practitioner, to share his experience regarding management of these cases, because in eyes, the glaucoma is usually intractable in the patients who do develop glaucoma, because there is this formation of membrane across the angle by the endothelial cells, which have been transformed into epithelial cell-like quality, and they migrate. So they keep migrating. So any sort of management has a risk of failure. So what surgery to choose primarily, whether it should be a valve at the first go. The specular count was 616. So what is the risk of the cornea decompensating? Is it enhanced with the help of an AGV implantation? and what would be the other opinions regarding managing this case?
Thank you, Sujanda, and thank you for a good presentation. The video was quite good, and it seems to be very easy. You are lucky because one thing is that for the IC syndrome, to do a valve is quite, that's a choice. That's a choice. Because in trap, it won't work. But the problem, it comes to the tip of the tube. That is very important. Where to place the tip? Because once you go towards the iris, there is endothelial proliferation that to get closer. And if you come to the little closer towards the cornea will get damaged. Already, this is the compromised cornea. There's a chance of cornea get damaged, and the future DMEC or DSEC is necessary in these types of cases. It seems from the picture, the tube is well placed and there is a gap between the iris and also the cornea in the middle. And one more thing, the tip should be a little longer than normal AG valve what you're putting in the other cases. That's it. You are lucky, it will stay, I hope. And if the cornea needs to be changed, we have to put it in the cornea specialist. Number two, I want to say one thing. For IC syndrome, placing the valve and there's a regular checkup is needed, and it has to go for the institutional practice where there is a composite of cornea specialist, glaucoma specialist, and also the retina specialist. So far, it's good. I hope it will stay. If it doesn't stay, what's the next step? That's the important.
Thank you, Shumita. So the basic take-home message is a regular follow-up and to keep on getting into different sort of treatments according to the needs of the patient. And just one question to Dr. Rituparna De regarding the role of ROCK inhibitors, if any. Is it an add-on in medical management of ICE cases?
Thank you, Shuchandadi. So far, when I searched for the studies, it shows that one case was there of IC which was put on netarsodil, and the outcome was favorable. And in fact, I have one patient of ICE who is on ripasudil. So he is also doing well, and I had to take him off from his primodidine because he had developed an allergy to it, and substituted ripasudil considering both the factors, and the outcome is okay. He's maintaining his pressures, and his discs are also not progressing. He's one night with ice. In that setup, actually, I was not able to monitor with the specular, but his vision is stable and his cornea clinically looks okay. It's the same. And he had developed, he did not develop those side effects. Usually. Usually, that's what, but since the patient is stable and he's maintaining his vision, and initially he had a little edema, but that cleared up later.
Thank you, Rituparna. This would have been a very interesting case discussion with so many experienced glaucoma specialists here, but unfortunately, again, for constraints of time, we shall move on to the next case.
Our next case will be presented by Dr. Amrita. She is the fellow in glaucoma department in the Shankar Netralaya, Kolkata. She will be presenting a case of a overfiltering bleb, shallow AC in overfiltering bleb.
A very good afternoon to my respected teachers and dear colleagues. And I'm very grateful to OSWB for giving me this prestigious opportunity. So a 50 years old male presented to us in December 22 with the chief complaints of diminution of vision in both eyes, right eye more than that of the left eye. There was no history of pain, redness or colored halos. The patient didn't have an history of ocular surgery in the past. There was no significant family history of glaucoma or history of any steroid abuse. The patient was a known diabetic and was under medications since a period of 5 years. General examination was within normal limit. Coming to the ocular examination part, both eyes were orthophoric. EOM was free full for both the eyes. Right eye showed RUPD. Left eye pupil was reacting normally to light. BCVA for the right eye was 6/18 and for the left eye was 6/9. Lid and adnexia was normal for both the eyes. Conjunctiva was quiet for both the eyes. Cornea was clear. Anterior chamber was also quiet for both the eyes. Both eyes had IMSC. IOP in the right eye was 30 mm Ag, and this was without any IOP lowering agent. In the left eye, it was 14. On gonioscopy, 360-degree closed angles was opening to scleral spur on indentation. However, there was no pass. Gonioscopic findings were similar for both the eyes. Optic nerve hit of the right eye showed near total cupping, and for the left eye, Visidia was 0.5 and NRR was healthy. So my impression was, right eye was a case of PSEG advanced stage and left eye was a case of PSCS. So the right eye was immediately started on eye drop Timolol Marriott and PAC PI was done for both the eyes. This is the HVF. The right eye showed advanced field defect. The left eye showed few depressed points both superiorly and inferiorly. CCT for the right eye was 493 microns and for the left eye was 509 microns respectively. The surgical advice that was given was phacotrabeculectomy with IOL under LA. For the right eye, as there was an advanced field damage, there was a thin pachymetry, as well as there was a poor adherence to AGM. And this was a glaucoma trainee case. So a fornix-based conjunctival flap was made. The scleral triangular flap that was dissected was seen to be thin. Phaco and IL was completed by going on a deeper plane. Stoma and PI was completed. Partial scleral flap dehiscence in the apical half was encountered while suturing. So the remaining scleral flap was sutured with 3 fixed sutures. At case closure, the AC was deep, firm, and there was air bubble left in AC. So coming to my post-operative day 1 finding, AC was shallow, IOP was non-recordable, there was no leak or no choroidal detachment noted. So apart from the normal topical antibiotics and steroids, atropine was added for 3 times per day, a pressure bandage was given, and we decided to observe the patient for next 24 hours. On the next day, AC continued to be shallow. There was IOL and cornea touch inferiorly. IOP was still non-recordable. However, there was no signs of choroidal detachment yet. So we decided to take the patient for scleral patch graft under local anesthesia. This is the picture following a scleral patch graft. This is a post-operative day 1 after scleral patch graft has been done. What we observe here, the AC was still shallow, IOP was still non-recordable, and patient now had signs of choroidal detachment. CD was seen superiorly. I would like to add here, we wanted to start the patient on oral steroids, but since the patient was a known diabetic and he had deranged PPVS values, we weren't able to do so. So what we did, we boosted up our topical pred-acetate dose and we asked the patient to come on close follow-up. However, the patient reported to us after a period of 30 days. This was his findings. The AC was deep, IOP was 14 mm Ag, and the choroidal detachment had resolved completely. This is the ASOCT section through the bleb and scleral patch graft. So now, since we are already observing World Glaucoma Week, so my aims of discussion will be challenges faced during training of glaucoma surgeries and to improve glaucomal surgical training. The primary area of challenges are scleral flap making and suturing as in the presented case, assessment of stoma creation, conjunctival handling and suturing. So the training modalities available worldwide are surgical simulators, wet lab training for cadaver models, synthetic simulation models, and direct supervised training on patients. Challenges faced are cost of simulators, cost and tissue availability for wet lab setups, and the risks that might be involved in direct training on the patient eyes. One of the largest studies of trainee surgery from UK was analyzed, and it has shown that for 300 cases, the supervised trainee trabeculectomy outcomes were compared favorably with those of consultants in terms of qualified and unqualified success rates. These are the patent's 4 stages of approach of teaching. First being demonstration, where the trainer performs the skill in real life without any commentary. Deconstruction, the trainer performs each step slowly with an added commentary and explanation. Comprehension, trainer performs each step while the student describes each and every step. And execution, here the trainee performs the skill step by step while simultaneously providing commentary. So Kolb's experiential learning theory says that concrete experiences are required initially in order to allow time for reflection and abstract thinking to occur so that we can actively experiment with the concepts. And ways to minimize challenges: observation of surgeries by trainee, live and recorded, practicing suture techniques, discussion of surgical steps with the trainer before as well as after the surgery, and learning is a continuous process. And the new ways ahead are assessing competence of practical skills of trainees using specific competency-based systems, also known as the Ophthalmology Surgical Competency Assessment Rubrics, or the OSCRs. Thank you so much.
Thank you, Dr. Amrita. I would like to ask our panelist, Dr. Neela Majumdar sir, who is the senior consultant in Shushruth Eye Hospital. This is a kind of open and shut case. This is the thin sclera and had to be taken for sterile patch graft. But we encounter very commonly in our day-to-day practice the shallow IC because of overfiltration in those cases. What is your stepwise management for those cases?
Glaucoma filtration surgery is a non-physiological surgery, where we have to balance between overfiltration and keeping the stoma patent. So far as overfiltration is concerned, there are a few things we have to take into consideration. The first is the grade of the shallowness of the antechamber, whether it's grade 1, that means peripheral iridocorneal touch, grade 2, where there is only central clearance between the lens and the cornea, and grade 3 when there is actual lenticulocorneal touch. So as such, this overfiltration is not very rare in the first few days of glaucoma surgery. If it is a grade 1 shallow antechamber, or maybe grade 2 also, then initial conservative management, give cycloplegics, stop the anti-glaucoma medications, reduce the dose of steroid, and see for progression. If it is progressing, on close follow-up maybe on the next day or maybe 2 days, then we have to go for other modalities or other steps like doing a patch, maybe a torpedo patch. But doing torpedo patch is a bit difficult in day-to-day practice, because sometimes the torpedo slips and may press on the cornea itself. We can use aqueous suppressants. If the IOP is not too low, aqueous suppressants may help. And I haven't used those shells, or they have theoretical advantages. I haven't used them. But if it is a grade 3 shallow antechamber, then you have to take the patient to the OT and re-explore the area and see. Most of the cases, the cause is probably a loose suture, inadequate suture, or as shown in the case, the too thin scleral graft, or maybe scleral melting if too much of anti-metabolite has been used. So then it is surgery. And in long-term cases, sometimes compression sutures may have a role. I haven't used them. Probably in 1 or 2 cases I will use them. So these are the modalities, these are stepwise approaches.
Sir, what about leaving a visco or Hilon in the AC to form the AC and observing?
first post-op day, during surgery. AC deformation, yeah. If the AC is shallow, definitely. AC deformation we have made with air or maybe viscoelastics, definitely. But viscoelastics may raise the intraocular pressure. That we have to keep in mind also. It is done. It is done because sometimes air doesn't stay. Then we can use viscoelastics. But you have to monitor the IOP more closely.
Next, we will move on to our next speaker, Dr. Manish Singh. Dr. Manish Singh is a senior glaucoma consultant in Netralayam Super Specialty Eye Care Hospital, and he will be talking on intraoperative gonioscopy.
Thank you, Dr. Surajit, and first of all, thanks to OSWB for making me part of the program. I'd also like to thank our esteemed guest faculty, Dr. Murli, Dr. George, and Dr. Prasanna for sparing their valuable time with us and making this program successful. Thank you so much. It's been really a pleasure to host you all. And we are in the Amrit Kal of Indian independence. And as a glaucoma expert, we often feel that gonioscopy is still not a part of routine evaluation. And a large majority of glaucoma is still treated without gonioscopy. And I'm here to talk about intraoperative gonioscopy. So there's something new to learn, and which is slightly more difficult than a routine gonioscopy. And intraoperative gonioscopy basically is an intraoperative viewing of the angle. Now, why it is important? Because we know the minimally invasive glaucoma surgery, the angle surgery is coming up. And if you want to do angle surgery, you want to use the trabectome, you want to do eye stent, and you want to use the Cahock dual blade, then definitely you have to first know how to evaluate the angle, see the angle structure, and then only you can start doing angle surgeries. We started using the intraoperative gonioscopy around 4 years back. That time MIGS was not available in India. The main idea was using it to do goniotomy in pediatric glaucoma patient in cases where the cornea was clear. And also we thought of doing goniosynocolysis in cases of recent acute angle closure where the pressures are uncontrolled. We can go for a cataract surgery along with the goniosynocolysis. So you first do a cataract surgery, and then you tilt the microscope, tilt the head of the patient, use the lens. So we are having the Swan-Jacob lens. And then you can actually visualize the angle, see those synechia, and then using the iris spatula, you can actually release the synechia. So this was our reason of starting using intraop gonioscopy. So in intraoperative gonioscopy, why we need to learn it? One, as a glaucoma expert, whether you like MIGS or you hate it, you cannot ignore it. Because this is now coming up and there are multiple options now available in India. So we have to learn about MIGS, we have to be aware about MIGS. Apart from doing angle surgery, there are a lot of other indications of doing gonioscopy. One can be diagnostic. You are evaluating a patient under anesthesia. You can use these lenses to see the angle, whether the angle is well developed or not, whether there is anterior iris insertion. You can also use this for doing goniotomy, goniosynocolysis, and even internal bleb needling. I'll share you one case. This was a patient where we did needling, and you can see there was extremely fibrous bleb. We were not able to lift the flap. In these cases also, if you are comfortable with gonioscopy, you can fill the eye with viscoelastic material, use the gonio lens, tilt the globe, and you can actually, using the iris spatula, visualize the stoma, and from internally, you can try to lift the flap. So the basic idea what I want to highlight is that using intraop gonioscopy is not only for doing MIGS, but there are many other indications, many other procedures you can perform if you can master intraop gonioscopy. For this, definitely you need a surgical gonio lens. We currently use the Swan-Jacob. There's also the Ahmed gonio lens, which has got 1.5 times magnification. The cheaper version is the Eye Prism S and Eye Prism SX, which can be reused by doing a ETO. They cost around 6,000 to 7,000. Very important thing is the proper tilting of microscope. You should have to sit temporarily. You have to tilt the microscope 30 to 40 degree towards you, and the patient head has to be tilted around 30 to 40 degree away from you. You can see the way we have tilted it. Then only you can get the correct view of the angle. There are certain apps available on iOS and Android where you can tilt the microscope and you can see whether the tilting is 30 degree or 40 degree. You can actually measure it. So first time you can do it. Second time what you can do, you can just mark on the microscope. So the next time when you're tilting the microscope, you know how much tilting has to be done to get the correct view of the angle. Again, very important, you have to first master gonioscopy, then only you can master intraop gonioscopy. So this can also be another indication why we should do more and more gonioscopy, so that we can start doing more and more MIGS and eye stents. In this case, since you're using the non-dominant hand to rotate the eye and move the eye, so you have to slightly practice it initially. You have to take the support of the forehead or the chin, depending on which side you're sitting, and then use the gonio lens and your finger to rotate the eye and get the proper view. Mostly these surgeries can be done under topical. In case the patient is uncooperative, you can always use a peribulbar or a subtenon anesthesia. It's a small video demonstration of intraop gonioscopy where we had planned to do a GAD procedure. So first you put visco on the cornea to get a proper visibility, fill the eye with a sodium hyaluronate. In this case, we are making a small AC entry. Then put your gonio lens, whatever lens you are having. Once you have placed it, you have tilted the head of the patient, tilted the microscope, and then adjust the light and adjust the focus, and then you can see the angle structures properly. Once you can get a good view of the angle structure, you can go for eye stent procedure, Cahoog blade, GAD, whatever procedure you want to do, but doing a good intraop gonioscopy is an essential thing for all these procedures. So to conclude, I'll say mastering intraop gonioscopy is extremely vital in case you want to start using angle surgery. Like any other procedure, practice and perseverance is essential. Once you are comfortable with intraop gonioscopy, it will help you surgeons to perform a new era of glaucoma surgeries. And before I'll conclude, I'll say Glaucoma Society of India this month have released a lot of interesting videos in collaboration with the team of CID. So I think all of us are on Facebook and YouTube. You can search Glaucoma Society of India on Facebook. You can watch those interesting videos and you can share with your patient. I'm sure they will be useful for your patients and your family members. Thank you so much.
Thank you, Doctor. Hello. Thank you, Dr. Manish, for a great presentation. Yes, MIGS is something now that we cannot ignore. Now I will call upon Dr. Chandrima Pal, Senior Glaucoma Practitioner, Director, BBI Foundation, to give us some very valuable tips towards success of trabeculectomy, the most commonly done filtration surgery in our glaucoma patients.
Thank you, Shachandra, and thank you, OSWB, for this invite. So in the next few minutes, I'll take you through trabeculectomy, the tips to enhance the success. So as we all know, trabeculectomy is basically a surgery against nature, and scarring and flow have a very delicate balance. We need scarring for healing, and we need the flow to keep the ostium patent. So trabeculectomy is an excellent procedure if it succeeds, and for that procedure to succeed, we need to be careful of conjunctival buttonholes, over and under filtration, and hemorrhage. I have been comfortable over the past 3 decades doing Moorfield's safe surgery system of trabeculectomy, and whatever you're comfortable with, that's the best thing to do. I have no financial interest here, but a drop of brimonidine instilled in the conjunctival sac would actually help you, because post-trabeculectomy cases are where the patient has been using anti-glaucoma 2, 3, 4 medications for the past, say, years. So that would blanch the vessels and help you see your way. So in the intraoperative procedures, I'll just show you, you need to have non-tooth forceps, and then if you do a small Weck-filled cell fluid dissection, as you see in the swab there, then that would release any conjunctival fibrosis, light fibrosis, which might be there. I generally leave a fringe because that helps in keeping my blebs intact. So that's showing the fringe that is there, small. Next, we move on to mitomycin C. So about using an adjunctive, you can use mitomycin C as I have used here with a sponge, or you can inject. I generally use it with a sponge, or you can use Ologen, which I'll come to a few moments later. That's a no-touch technique, as you all know. And mitomycin C, we generally apply for about 2 minutes, but vary the concentration according to the case. Next, the scleral flap. This is most important because the scleral flap has to be even and it has to be the right thickness for you to have a good bleb. And this is like doing SICS, is rather simple if you're used to doing it. Those are the conjunctival scissors which I've designed, and they help me to reach just short of the limbus so that I have a large surface area for circulation of the aqueous and a good posterior flow. Next is the ostium, punching out the ostium. That's if you're using a trabeculectomy punch. So you can use either a single punch or a double punch depending on how much you actually want to punch out. And I generally use the Kelly's punch. Iridectomy is relatively simple except that it has to be through and through. You have to make sure and not partial. Scleral flap sutures. This is very important because if you do not give a releasable suture, your chances of titrating the intraocular pressure post-operatively would be difficult. So a releasable suture is pretty simple if you just follow the few steps, move in through the limbus, then through the conjunctiva, then you go on to your flap. Here actually I've just tried to do it crisscross just to, change the pattern a little bit. So 4 throws is important, and then you take the loop out through those 4 throws, and then this actually gives you a lot of freedom post-operatively. Conjunctival closure is important because it has to be done with a round-bodied needle so that you do not injure the conjunctiva, and I generally close it with 10-0 nylon. A little bit about Ologen. Ologen actually normalizes wound healing process, randomizes the growth of fibroblasts, regenerating tissue remodeling, and it prevents scar formation. So our published study on Ologen actually inferred that Ologen is more effective in phacotrabeculectomy than in trabeculectomy alone. That's probably because there is automatically a small drop in the intraocular pressure in phacotrabeculectomy. So the per-operative surgical pearls would be, I routinely use injection mannitol 20%, about 100 ml just before surgery in a slow intravenous infusion. I generally use a single site parabulbar anesthesia. You can also use double site if you want to. Never use a tooth forceps, I told you that before for handling the conjunctiva. Aim for a watertight conjunctival closure. Lower high intraocular pressure before you start your surgery, and never leave the operating room with an unclosed leak. So the management of the filtering bleb after surgery, especially the first 3 weeks, is actually as important as the procedure itself. So timing of suture removal is predicted on the intraocular pressure, the appearance of the bleb, and the degree of filtration that is desired for the individual patient. Suture manipulation is avoided during the first post-operative week, if possible. The ideal time to alter the flap sutures is 2 to 3 weeks following surgery, because if you're using mitomycin, that would give you that chance of doing it. And flap suture manipulation after the 4th post-operative week is generally less effective, though response in antifibrotic augmented trabeculectomies may be more vigorous and possibly later in the post-operative course. The early post-operative period pearls would be, digital massage would help in formation of the bleb. You have to show your patient how to do the digital massage, or else ask the patient to come to you every day so that you can do the digital massage. Is really worth it, believe me. Laser suturolysis and releasable sutures are useful techniques. Tackle one suture at a time to avoid hypotony, especially in eyes that have received antimetabolites. Early recognition of signs of scarring and appropriate treatment improves the success rate. Always try conservative treatment with an encapsulated bleb. Aqueous misdirection is a difficult complication to manage. The best approach is to prevent the initiating factor, that is sudden shallowing of the AC in high-risk cases when you're doing your trabeculectomy. And the common causes for serosporoidal detachment is a conjunctival wound leak. Identifying of primary cause and appropriate treatment should be the first step in the management. Late post-operative complications, the pearls would be early post-operative hypotony leads to chronic hypotony, so avoid low IOP, especially in eyes treated with antimetabolites. Patient education is very important. Please speak to your patient to minimize the risk of bleb leak and infection related to it. Failure of bleb can occur at any time. Following surgery, post-surgery follow-up is a must in all patients, and at this stage when the bleb is failing, you can actually do a needling if you recognize it. Tear film disturbances are common cause of symptomatic blebs, so you have a whole lot of artificial tears available in the market. Do use them. That will help your patient and you both. And immediate and aggressive treatment of bleb infection, thus to salvage the eye, is very important. So filtration surgery, I'll just say a few things about angle closure glaucoma, surgery to be performed under whatever anesthesia you perform, perivalvular single or double site. This should have a thicker superficial scleral flap, more than half the thickness. Tighter closure of the scleral flap. Use of releasable tight sutures is important, and AC should be formed by BSS or air in an angle closure case. So standardize your flap, find the smooth plane of the sclera, avoid cutting the edges of the flap too anteriorly, and measure the size of the flap. My choice is 3 by 4 millimeters and 3 millimeter posterior to the proposed punch. So that's the picture that you see out there. This is too anterior, would have a valve effect, and that's too posterior, you have chances of iris prolapse. And I generally use the modified Weiss or the condon suture, which leaves a limbal fringe, which I told you right in the beginning. So MMC and Ologen, you know that, I don't have to go through it, but always use a releasable suture if you're using Ologen. And these are the two bleb comparisons that I can show you. On to your left is the mitomycin bleb, and on to your right is the Ologen bleb. So trabeculectomy still remains the gold standard as the initial treatment for surgery for glaucoma. Technical modifications can help your trabeculectomy to retain your filter longer. The Moorfield safe surgery technique has developed over the years and is a time-tested method of doing trabeculectomy. MMC, if you use it regularly, it would not be a complex operation. Do try using MMC. It would help you in retaining your blebs longer. And do regard trabeculectomy as your first choice for glaucoma surgery before you try anything else. Thank you for your attention.
Thank you, ma'am. I would like to call our next speaker, Dr. Sagar Bhargav, sir. Dr. Sagar Bhargav is a senior glaucoma consultant in Netralam Super Specialty Eye Care Center. He will be talking of management of combined cataract and glaucoma surgery.
Good afternoon, everybody. At the outset, I'd like to thank OSWB for this opportunity. So, talking about managing coexisting cataract and glaucoma, in a routine clinical scenario, you are essentially faced with two scenarios. So, basically, when a glaucoma patient comes with cataract, it's actually a first-time patient to you who has come to you for an opinion for cataract surgery, or this patient is, you are following this patient for a long term for glaucoma management, and now the patient has developed cataract or patient needs some intervention for glaucoma. So let's see how we do it. So in the first scenario, when the patient is coming for the first time, you need to look at the records very carefully, because it will tell you what was the baseline IOP of the patient, because that will help you to understand whether you're dealing with an NTG or whether you're dealing with a high pressure glaucoma. And of course, IOP pressure measurements over the years will tell you how good the long-term control of IOP for that patient was. Next, you would like to look at the visual fields, because it will answer you two important questions: whether the cataract removal will actually help the patient. To explain this, you have two patients with very similar vision, 6 by 60, advanced cataract, advanced cupping, and you have a visual field like this in one of the patient and a visual field like this in the other patient. So obviously the visual field here will definitely, the patient will benefit from cataract surgery. Here the outcome will be guarded. So studying the visual field, past records is very useful coming to the thing. Next, the visual field will tell you whether the patient has a stable or a progressive condition. So this is a visual fields of same patient. The left eye has had a trap done, and you can see the visual field graph, VFI graph, is pretty stable. But look at the other eye, which has not undergone any trabeculectomy, it's just on medical control, and you can see the downsloping of the thing. So this eye will need a phaco trap, whereas the other eye will just phaco would suffice. Next thing which you will consider is the number of medications patient is requires for IOP control. So anything beyond 2, you would basically go towards phaco trap. The second important thing is sometimes you are not sure whether the patient has actually taken being over treated. So a reverse drug trial is something that you can always try and reduce the medication, see what is the level that you can control with minimum medication. That helps in deciding what the patient wants. Look at the clinical, look at the ocular surface. Someone has very nicely talked today. So look at the drug toxicity, look at whether the patient has dry eye. These two situations, you may want to do a trabeculectomy to reduce the ocular load of the medication. Look at the surface inflammation, because that will help you to decide preoperative treatment for the same. Pupil assessment, very important, because you have angle closure patients with people like this, mid-dilated fixed pupil. you want, the IOL selection would actually depend on this. We will come to that in a minute. So once you have done this, what next? Whether you would do a AT gonio or whether you do a biometry. So obviously you will basically do a biometry first before doing an AT gonio, because that will alter your corneal parameters and you will get inaccurate result. And when we are dealing with short eyes, the biometry is very important, because if you have axial length errors, you will end up with a higher refractive surprise. So preferable to do optical biometry in extremely short eyes when you're dealing with axial length of less than 22. So once you have done all this, you have three scenarios that actually come in. You do a trabeculectomy first, then do a cataract surgery. That's a sequential cataract surgery. You do only cataract surgery, or you do a combined surgery. So let's see one by one. So we'll do a trabeculectomy first when you want the IOP control is your priority. And you anticipate a difficult cataract surgery and you expect a higher surgical time. And as we know, as the surgical time increases, the chance of trabeculectomy success decreases. And in this case, the interval between the trabeculectomy and cataract surgery should be at least 6 months, because that is what studies have told us, that bleb survival improves with that duration. So I'll just share you a very small, interesting case. This gentleman was a known case of primary open angle glaucoma, had a trauma with almost 180 degree of subluxed cataract. When finally he had IOP of almost 33, which was not responding to medication, and this was his visual field, fairly advanced glaucoma. So the priority was to basically salvage the eye. So we took the patient for trabeculectomy first. And as you can see, as we were doing the trabeculectomy, the superior part actually gave way. There was vitreous presentation, but we managed it with vitrectomy and did off the trabeculectomy, and this was the thing. And in August, we did the trabeculectomy. The patient's pressure settled down. And in 6 months down the line, we did a phaco with the CTR and the IOL. Now it's almost 2 years. Patient is maintaining 6/6 pressures with a well-controlled IOP. This is the clinical picture of the same. Now, now the obvious indications when you would like to do only cataract surgery is when you are dealing with a patient who is an elderly age group, has a reasonably early disease, has well tolerated. He tolerates the medical therapy well, has good compliance towards medication, and classically angle closure glaucoma patients and NTG patients, you can actually do away with only cataract surgery. And combined surgery you would want to do in a patient who is a little younger, has moderate to advanced disease, intolerant to medication, non-compliant, and patients with pseudoexfoliation, because they tend to have a very aggressive disease. So cataract surgery alone, you will have two scenarios: patient on medical management and patient who had trabeculectomy. Important thing is that these patients should be, the post-op steroid should be tapered off fast, or better to avoid them, because they tend to have higher steroid response. And these things do matter. Even in cataract surgery, you probably, angle closure patient, you would still give a hyperosmotic agent. If you're doing an SICS, make sure you're doing it in temporal region. Newer machines allow us to actually titrate the IOP while doing phaco. So you want the lower IOP while doing surgeries in these cases. You can also titrate it by the bottle height. And of course, you don't want a posterior incisions in angle closure patients, because you'll have iris prolapses. These things should be handy, and you should use it case-to-case basis. Just a minute, I'll speak about choice of IOL. So basically, when spherical IOLs, where you anticipate that the patient will have decentration and the possibility of tilt, especially in pseudoexfoliation and loose zonules, you can go in with a spherical IOL. Small pupils, you can go in for a spherical IOL. Aspheric IOLs, very important that they should have a very stable zonular complex, because decentrations will cause aberrations. Large pupils, aspheric IOLs are IOL of choice, because they tackle the spherical aberration very well. Toric IOLs can be used if you have a stable zonules, but typically aim for a higher astigmatism treatment. EDOFs and trifocals one should usually avoid in moderate and severe glaucomas. Ocular hypertension is fine, pre-pentametric glaucoma is fine, provided their surface is okay, because they tend to do well. Very important is your pupil should be functional in these two categories. Phaco traps, just 2-3 points. The capsular axis size should be smaller than usual, because you don't want the IOL to pop up and cause optic capture. They tend to have a higher risk of trabeculectomy failure, so you need to be very aggressive with the post-op measures. And the refraction stability takes almost 4 to 6 weeks. One has to remember that. It can be either ways. You can do it a single site procedure or 2-site procedure. I'll just give you two examples where you can go in a little more than what you do for a routine phacotrabeculectomy. This was a gentleman who had almost minus 2.75 diopter cylinder sphericals in the refraction. We did a phaco trap with a toric IOL in this patient, And the patient actually did very well. The point of showing this case is that you can plan a toric IOL, explaining the patient that we are going to basically reduce the effective cylinder in the thing. We may not achieve plano, but we can still go ahead and do it if you have a more than -2, -2.5 cylinder. Another interesting case, this patient had a traumatic mydriasis, a young chap, extremely difficult, having a lot of photic symptoms. So we did a phagotrap with a pupilloplasty combination. So basically this was a single pass 4-throw pupilloplasty after doing the cataract surgery. So this is a very nice technique which Dr. Amar Agrawal has taught us all. So basically what we are doing is we are basically taking 2 sutures inferiorly and 1 suture in the superior part. So, so this is the thing, and then the trap was done, and this is how the patient looked. So sometimes you need to do variation for in certain situations and deal with it. So just to sum up, that decision for doing cataract or phacotrabeculectomy can be individualized. There is no fixed and hard and fast rule. Latest IOLs are there, but they have limited application in glaucoma patients because of the problem of contrast sensitivity. Moderate to advanced glaucoma have poor contrast sensitivity. You cannot put multifocal, trifocal lenses because you are going to compromise that further. And, but selected patients, you can still give a refractive solution. Thank you.
Thank you, sir. It was an extensive update on the whole topic. And we have reached the last talk of our session today. Dr. Prasanna will be talking on the MIGS. Please keep your questions ready. After this talk, we will be taking all the questions for this session.
Thank you once again for the Ophthalmic Society of West Bengal and Manish sir for giving me this opportunity to give an update on minimally invasive glaucoma surgery. For the next few minutes, I'll try to keep it very simple and few of my take-home points with the other literature that I have also learned from seniors like Murli Ariga sir here and other seniors in MIGS who are also here with us. So minimally invasive glaucoma surgery, it's an update. And my journey started in 2019 where I learned all these procedures before they came into India in a wet lab. That's how it all started for me in Australia, where I had this feel of getting this training done. But then for reasons in 2020, I was not able to implement it. We all went through COVID, and last year has been very kind, and that is where I really started doing MIGS procedures. So the main goal of an MIGS procedure is, these are the 5 most important characteristics. So it is an ab interno approach. So it is a minimal disruption of the anatomy, and the results are, at least from the Western side, it says it's very efficacious and it has a good safety profile, or the complication seems to be very less with good ease of use. So I'm just sharing you one of the data from our publications too, just the classification, and the red ones are the ones, can I have a pointer? The red ones are the currently ones that are available in India. We have the devices, I'll just stick only to that, increasing the trabecular outflow for want of time. We have the stenting devices like iStent and iStent Inject, and we have the trabeculotomy procedures and devices like suture gad, trabectome, Coutts dual blade, and the bent needle ab interno goniectomy. So these are the devices that are currently available in India. And recently I learned the gonio scrubber and Espelat from Dr. Murli Ariga sir. He'll also be sharing his inputs on these 2 devices which are being done in India currently. So we will not go into the suprachoroidal shunts and the procedures that cause reduction of aqueous production and subconjunctival filtration. We will stick only to the trabecular meshwork and the stenting devices and trabeculotomy procedures, which I will be sharing in the next few minutes. So this is again one of the articles that of mine that I published recently in the issue of IJO February 2023 issue, where I just showed you this table, and we'll stick only to this. And to add on to Manisha's direct gonioscopy, again, MIGS mainly it's the direct gonioscopy. So I just used this simple technique here. The company people marked and gave this technique where you can see that with just your technician rotating the microscope 30 to 35 degree towards you. I'll just show you this video. You can see the marker here. So this is an Axe Street microscope where you can see now after it's 30 to 35 degree rotated, a marking has been done. I'll just show you this figure. A simple marking like this will actually help your assistants to actually bring the microscope 30 to 35 degrees towards you. That really works for me when I finish a cataract surgery and then want to proceed with an MIGS. Then tilting the patient's head obviously away from yourself. Tilting the microscope towards us patient said away from us 30 to 35 degree. And this is a care that just keep the patient's head above the art to prevent blood reflux from the Schlemm's canal, which will be very useful to have a good media. So I have personally used only these two lenses. One is the transient volt gonio lenses and the one eye prism SX that is from Glaucos. This one is they say for single use, but more than 3-4 times you can ETO and use it. It's very good. And the other one, it's very good. Especially, I'll just show you a video here where this is a reusable lens, the old lenses, where you can see that once you have put the high molecular weight viscoelastic and the lens has been put, this is a good docking mechanism. You can see that me moving my lens left and right. So it docks the eye really well. So that I wanted you to know that in this lens, the docking is very good. And in the initial stages, when I started before placing the eye stent or doing an incisional trabeculectomy surgery, I just took the Sinski hook and tapped the trabecular meshwork to get the hand-eye coordination ready. So I also showed you a simulator, but this is again a real-time scenario where you can just orient yourself to the trabecular meshwork even before you get your chance to do the MIGS for the novice, the neophyte surgeons who are in the gallery. So this is the eye stent inject. Again, you can see the anatomy here, the direct gonio anatomy here, the Schwalbe's line to the root of iris. This is a slightly pigmented trabecular meshwork where we just go in and then the eye stent is actually placed. So this is an eye stent G1 where the release is done more manually. So you'll have to decide when you want to release it. So that makes it even more challenging. But the companies come out with a lot of even dry lab or wet lab training which you can undertake and then go ahead with this. So this is a generation 1 simulator. And in this case, post placing an eye stent, I was even able to see a single blood flow vessel here depicting that particular collector channel. If you are lucky, you will be able to spot that. So this is the anatomy. I'll skip all the theoretical slides. I don't want to stand in between lunch. And results from the Europe studies have shown that 68% of the patients who receive stent at the time of cataract surgery, it has to go in hand with the cataract surgery, not a standalone procedure. They were medication free 12 months with an IOP of less than 21 millimeters. Then we have the generation 2. In the generation 2, if you see, we place not one but 2 stents. So the 2 stents are placed 2 to 3 or 3 to 4 clock hours apart. So this is an animation of that. One is placed here, another one is placed here, at least 2 to 3 clock hours apart, where 2 stents are actually placed in this particular video. Again, this is not my video, but I just thought I'll show you this, how it's been placed in real time. You can see that first a single stent is placed and then a bleeding is arrived, there is a mild ifema, and then the second stent is placed here. So this is the eye stent G2, generation 2 eye stent. And this is again not going into the depth of the theory. So this is how the eye stent inject looks. And these results are also seem to be promising. In the eye stent with phaco group, 84% of the eyes were medication free for 23 months. And the comparatively to a standalone phaco emulsification group, the results seem to be very promising. And then we have our own cost-effective bent ab interno needle goniectomy. This I feel is very cost-effective, and the relevance in India, at least in our population, I feel this works very well. You just need a 26 gauge needle, the one that we use for a capsular excess or something. You just bend it the other way around, the reverse that we use for a capsular excess. So you can see that this is bent the other way around, and then this needle can just be swept across the trabecular meshwork. This is an incisional trabecular meshwork surgery. In this, the trabecular meshwork is being destroyed here. You can see that it can just sweep around the trabecular meshwork, and then you can wash away the hyphema with the high molecular weight viscoelastic. You can see a nice de-roofing of the trabecular meshwork in this particular video. So again, you can see this is the quadrant where the bang was performed, and I'll just show you an magnified view. So this is where you can see the drainage that is happening. It has to be done over 100 to 110 degrees. So this is a very cost effective, not as costly as the eye stent or eye stent inject, but with a simple needle again and with direct gonioscopy, even tomorrow or the next week or a month, even any one of you can easily perform this procedure. Some of the circumstances that I encountered, I just wanted to share with eye stent. Some trabecular meshworks are very friable. In the initial days, you can see me, I'm trying to place the eye stent inside, but the trabecular meshwork is just giving away. It will be sometimes very friable. So the learning curve is actually very tricky. So you can see I have just placed it, but if you don't remove it, again you'll have to come back. So that learning curve, it's slightly difficult. I wanted to show you some of my bad cases as well. So in this case, it just kept popping up. Then finally what I did was, again, then this is the area where I got my sweet spot. I placed it in, and then I ejected the eye stent. So the learning curve, not only for direct gonioscopy, even for eye stent generation 1, we need to know different trabecular meshworks are very different. It's slightly cheesy, or sometimes it, just like cheese wiring, that tends to happen. So I just wanted to show that particular video for the learning curve aspect. And this is something that I'm recently doing, not only with eye stent. Sometimes if the patient wants a combined MIGS, something like an eye stent with a bent ab interno needle goniectomy. So the eye stent is actually placed here, and then provided a 2 or 3 clock hours away, just go the other way, and just with the tilting the needle the opposite direction, you can see here, bent ab interno needle goniectomy is done on the other aspect if you want slightly more intraocular pressure reduction for that particular patient. So again, the points to ponder over. Sometimes combined MIGS is very controversial. Company says you need a closed system. But this really works well in my hands. At least 3-4 patients I have done. Yet to follow up for a longer term. But things are going on well. Based purely on physics, flow may happen through the bang opening that we have made compared to the eye stent opening. Again, this is one of the teaching videos that I wanted to show for the benefit of novice surgeons here. In the initial days of suture GAT, we would want to like to identify the trabecular meshwork and then slightly make an opening in the trabecular meshwork with an MER blade. So this is very, very important, as you can see here. That is how you can pass the suture GAT, because suture GAT has revolutionized MIGS. When talking about MIGS, it is always thought to be a cost-effective one, but it is never is the case. So again, this is one of the videos of my seniors and one of my mentors in MIGS, Dr. Swati here. She's an effortless suture GAT surgeon, and you can see here once the cleft has been made, as I showed you in my previous video also, with an MVR blade the cleft has been made. So once the cleft has been made, you can see that 60 Prolene suture is just being threaded into the cleft. 360 degree it goes in, and once the suture has been completely gone in, you can just see it passing out through the other way. It's not as easy as it seems, but she does it very effortlessly. And once the 360 degree passing has been done, you just need to deroof the trabecular meshwork 360 degree. And trabectome also came, it was more of like a micro cautery where the same, it's just like a bang, but it used a cautery, micro cautery to actually cause the damage, or it's again another one of the incisional MIGS procedures that we see. So there are so many MIGS procedures. The one that is with the KDB. KDB is very promising, as you can see. I just wanted to show you an animation of KDB here. So this is a sharp tip which has, and it easily penetrates the meshwork. It just lifts and stretches the meshwork here, as you can see. Once you identify the trabecular meshwork here, just make sure that you can just go one stretch. So that's KDB is more controlled. It creates a parallel incision in the trabecular meshwork. There are many ways to go about KDB. There are three techniques, outside in, where you can see the animation here. You can come from outside both the directions on the clockwise and anti-clockwise. And then we have the inside out. Again clockwise and anti-clockwise, but you will go from inside out. You can see that the procedure is done inside out like this and then inside out like this. And again there is another technique in KDB where you can go mark and meet. That means you just make a marking in one of the quadrants here. You can see here you just mark here, and then you start from that plane and you can go up to the marking. So it's a surgeon's comfort, but all these are currently in the market, and these are all cost-effective versions compared to the eye stents that are currently available. So the results of this is also very promising. 57% of the eyes experience 220 reduction of intraocular pressure. Indian literatures are yet to come, but these are all with European literatures I am trying to share. But coming to the ground reality, where do we stand from an Indian perspective? We have less Indian data, which is very much more in a conference, but it's yet to be published. The replication of this in India, how do we stand? How do the Indian eyes are going to react? We still don't know. Glaucoma practitioners, especially in India, we get advanced cases. We don't get the mild or moderate cases that the Europeans or the Western people get the luxury of. There is a learning curve for direct gonioscopy and the learning curve for the procedure. That's why I showed the eye stent video of mine where the trabecular meshwork was constantly cheese wiring before we were able to place the stent. And cost is one of the major concerns, especially when it comes to eye stent and eye stent inject. So with that point in mind, I'll just give 10 points before we close the session. So these are some of my references I've used for these 10 points. At least for reality, where do we stand now is, we stand now for the cost-effective version, where we use the Prolene suture in GAT for 360 degree, and we use the bent bank or the KDB, or we have the cost-effective versions that I showed, which is the incisional trabecular meshwork to de-roof the trabecular meshwork or the unroofing of the Schlem's canal. So this is where we currently stand. And maybe we can work some more on the dismissive mindset. Though MAGS is not alone expensive, there are some inexpensive ones or which is slightly more easily available. I think we can move towards that and we can try employing that like the suture GAT or the KDB that are currently available. And the advantages of MAGS, it is very safe. We don't meddle too much with the natural drainage system, and the conjunctiva is preserved. That much is very, very important. And it takes very minimal time, especially with the KDB or with the bent angle needle goniectomy. Just a direct gonioscopy, once you have mastered, it's very cost effective and it takes very minimal time. Very few complications as well. Very few only microiphemas, and the complications are also very self-limiting. In terms of limitations, a trabeculectomy might achieve a very low IOP such as 10 millimeters, which isn't likely to be achieved by MAGS. We do know the IOP is not going to be as good as trabeculectomy, but it's somewhere very effective. And every patient we cannot do MAGS. There is a selection criteria who we want to do. And the phaco MAGS or the phaco GAT or the phaco eye stent, they showed a significant reduction in IOP. Always combine the MAGS surgery with another surgery, especially the cataract extraction. A standalone MAGS may not really work well. So that is point number 5. And the prognostic factors, you can see here, GAT surgery seems to be a promising and successful surgery, at least for the shorter period. And there is a positive effect when you combine it with the cataract surgery. So that is very important. And the negative effect is the post-operative iphema. Sometimes, not a microiphema, even a macroiphema may be occurring. So patient selection is very important, mild and moderate patients, but unfortunately in the Indian setup, we don't get that luxury. More often than not, we end up with an advanced glaucoma, ocular hypertensus or a pigmentary or a pseudo-exfoliation glaucoma. See, what the data shows is effectiveness of a GAT, BANG or a KDB varies with the type of glaucoma, but also not only with the type, but also with the severity. So these 3 are the ones that I would mostly fit into our scenario, the Indian scenario. And this is the study again done by Davinder et al., primary and secondary glaucomas. They show that the results are very promising. I'll just simplify it. In a nutshell, this is a study. Incisional trabecular meshwork surgery can be performed for both primary and secondary glaucomas was the take home of that study. And again, for refractory glaucoma also, they did a study, especially with suture GAT. And they had good drop in IOP, good drop in the number of medications. Again, I'll just summarize this study. And they even did a patient who had tube and trab, and for those patients also MAGS was actually done. So this study in a nutshell showed incisional trabecular meshwork surgery can be performed for even refractory glaucomas, not only primary and secondary, even for refractory. Prior tube group did well than the prior trabeculectomy group. For a post tube, when you do an MAGS, the results are much better than a trab is what was arrived from that study. Even data shows congenital glaucomas and JOAGs. The European data, again, the Indian data is still grey. So the European data shows congenital glaucomas and JOAGs are also doing good. This is one of the very rare original cohorts that has been published, which has all the patients that has been included. Again, I will not go into the depth. I will show you only the findings here. So this study found out that POAG patients did well, SOAG patients did well, and the IOP, the failure at 2 years ranged only from 0.18 to 0.48. So the results were very promising. Very few complications, but with suture GAT, sometimes because of false passages, the suture may go into planes that we don't anticipate. Rarely even choroidal detachment has also been published. Choosing the right patients, again, that always matters. We need to choose the patients correctly. And there were different subgroups, and this was the results in a nutshell. So pseudophakic glaucomas, they were significantly worse when MAGS was done. Secondary open angle glaucoma and POAG patients did pretty well, and always when combined with cataract, again I am reinforcing this point, It was not a standalone done well. When combined with cataract, they showed good results. A word of caution is most serious diseases are unlikely to get help enough from an angle procedure, but that does not pave way that it has to be made clear to the patient that they cannot choose MAGS. MAGS is only for mild and moderate. That is the take home way that we need to go. And to summarize, it is an option. It is just one of the options that we have, ranging from all the glaucomas. Now even for select ACG patients, it has been contemplated. It can be even done after a failed trab or a tube. It is broadly classified as incisional and implants. I personally feel in the Indian scenario, implants are working much well. Sorry, the incisions are working much well because of the cost that the implants are bringing into the market. And IOP lowering is very good. 5-year studies are there for the implants, and for incisional surgeries, 1 to 2 year studies are there, but still Indian data we need to see. The comparable IOP drop is 20% drop, 20 to 25% drop, but ultimately the success will depend on the patency of the collector channels, which at this point in time, there is no gold standard test to really know how the collector channels are functioning, at least currently. So we have a lot of gonioprisms. Direct gonioscopy is the skill here. Learning the gonioscopy is the technique that we need to master, and once that is done, it's a step-by-step approach that we need to take into time. And for some tall surgeons, reducing the chair height will help prevent taxing the neck and back muscles. Very safe procedure, very minimal complications, and the advantage of this is we preserve the conjunctiva and we use it for mild to moderate, and we are trying to reduce the medication burden. So that's where we all try to fit MAGS, at least in the current era. So some of these videos are also available in my YouTube channel, so you can always feel free to go back, visit my channel. MAGS is something which is very promising, but it's a pinch of salt. We still need to see how things go in Indian eyes, and incisional trabecular meshwork surgery seems to be the order of the day, at least in Indian scenario. That's where we are currently standing. So once again, I thank the Ophthalmological Society of West Bengal for giving me a wonderful opportunity to show some of the work that I am doing. And this is a short glaucoma activity that we undertook in our center. We thought India is a cricket frenzy a country. So we played a cricket match for Go Green awareness last week. We also had the luxury to have George sir with us, and I just thought I'll show the activity that we did. Thank you once again for giving me this opportunity.
Thank you, Dr. Prasanna. It was a pretty exhaustive update on this MIGS, and we will definitely take the questions. Before that, I would like to request Dr. Rupak Kantevishwas sir, Chairman Scientific Committee, to say a few words, please.
This is an extensive talk by Dr. Prasanna. I think this is elaborating everything. But now this is a very proud moment for OSWB. We are going to launch a book, which is the major contributor from all over the India. But the chief editors of three of the chief editors out of three, two from West Bengal. So we need a big round of applause for Dr. Manish Singh and Dr. Arijit Mitra. So we are proud of both of them for this clinical handbook of glaucoma. So I would like to request Dr. Ratish Chandrapal to come on the stage, please, sir. And Dr. K.P. Ghosh, Dr. Pushpita Shahu, Dr. Muhammad Yasin, sir, and Dr. Shekhar Sharkar. So to be on the stage for the, as you all can see, this is Dr. Sibal, other than Dr. Sibal, Manish, and Arijit is here for this blue book. And one of the major contributor, none other than Dr. Murli Adiga sir, if you can please join us for this book launch. And stand in a row. think this book is available, and if not available, you can catch hold of Manish and Arijit to get off these books. So this is really a proud moment for us.
It gives us great pleasure to launch the book.
Yes. Thank you all. Really, really proud moment for us. And I think we all can have the question answer session if you have any questions there.
Do we have any questions for any of the speakers or our guest faculty? I think we can close the session and we can ask our Chairman Scientific Committee, Dr. Rupakanti Vishwas, to please give the vote of thanks.
First of all, I would like to thank all the delegates, to join us on a Sunday. More than 100 delegates who have joined us here on a Sunday and sparing the Sunday with us. Thanks to all the faculties and speakers, those who are present here since morning. A special thanks to Dr. Murli Ariga, Dr. George Puthuran, and Dr. Prashant Ramesh for their excellent contribution for today's scientific program. I would like to thank all the panelists and moderators who has nicely moderated the sessions. A special thanks goes to Giri and Shogato for the audiovisual to run it very smoothly, and Sun Pharma for being our academic partner. Thank you all, and please join us for the lunch here.